it was you had in mind. So you're exactly where you ought to be. We want to spend a few minutes doing introductions. And as if anyone has met me, my name is Ruth Prao Nganga. I'm one of the trio that is the Acquire team. Do I need another mic? I'm one of the trio that is part of the Acquire team. The Acquire team, you know, is Mary Adam, Lydia Okutai, and myself. And so when we say we are grateful you're here, it's the three of us speaking. Now, I'm going to start us off with introductions before I introduce the idea of why we are here. And it's going to be an interesting activity. I think the idea of patient safety and quality improvement is amazing. When Lydia, Mary, and I speak, we often talk about imagining this world where we don't need to go to other continents for good healthcare. The healthcare can be found here on our continent. It is as trustworthy as when you go to a KFC and you know exactly what the taste of that chicken is going to be like. And so a part of imagining this world, working towards this world, requires amazement and wonder. I wonder whether, is my slide up? Or maybe I'll just have to read it out for you. I'm reading from a quote from a lovely gentleman who talks about wonder. He says, everyone in the world should get a standing ovation at least once in their lives. His name is R.J. Palacio. And so this introduction is your moment to get a standing ovation. So I want you to turn to the person next to you and I want you to ask them, what reason do you feel? So basically they're going to let you know what reason do they have for getting a standing ovation. So maybe they went out of their way to do something and they know nobody in their team noticed. But they know they deserve a standing ovation for that. So I want you to listen to their story, their example, and then I want you to give them a standing ovation. Like genuinely give them a standing ovation. So look for someone you don't know. So Angie, not your son, someone else, stand to the other side and ask them, you know, what's your reason for having a standing ovation? A reason that nobody knows. You know it's just you who went out of your way to be kind, to do extra. So share that moment, that recent one that has come to mind as I'm talking about it. And then, so of course you'll start by sharing your name, your institution, and then you will tell them that. So when you finish with the person next to you, go to the person across from you on the table. So that the people on the table know each other. So I'm giving you 5 minutes for that. Hopefully hearing chatter.
Felix. Felix. Felix.
If you are online, if you're online, you can use this Mentimeter to share your answers. What is your reason for a standing ovation? So I'm gonna go around and hear from as many people as we can in the room. What are some reasons for a standing ovation? So can I start with this table?
Good morning, everybody. Thank you so much for joining us. My name is Bernard. I'd like to give a standing ovation to the members of my team, and I'd like to start with Philip. He's a political blogger, and he does a lot of work trying to make sure that we portray our politics in the brightest light. What can we do to inspire others? What can we do to make sure that we are telling the stories that need to be told? And his political blog, I'm going to look for it immediately after this.
Okay. So I want to be very clear. If someone has already given you a standing ovation for the food, it doesn't count. It needs to be something that only you are aware of. So if it's a blog, that means your mother already knows it exists. So that one does not count. you your standing ovations did not fall off. No, let me take you to another table. Did anyone do this assignment and actually gave genuine aha moments that were not about an achievement that will be on your CV or your eulogy
booklet.
Because we have to be genuine with these people. We know, we need to tell the truth. Okay, yeah.
Good morning, everyone.
Good morning.
So my name is Cynthia. I participated in a 21-kilometer marathon over the weekend. It was my first time.
Oh, well done. No, see, everyone is automatically giving you an ovation. Tell us about your planning for that.
I picked it up as a challenge. So I picked it up and I completed and I have a medal.
Well done. The Nairobi Marathon happened this Sunday, and we just met one of the people who completed a half marathon. Woohoo! Now, is there someone who has something that the world did not see and they did? I would love to hear about it. Let's give you a standing ovation for it. The microphone is ready for you. I'm coming to you, Gerald. Okay, so I'm hoping, do we have any coming in online standing ovations? I'm assuming the people online have the option of that screen. Ooh, okay, I love it. You will now see why I wear spectacles. I need to come closer. Wow, okay. So credibility, focus, drive, well done. You participated. There was an exceptional performance that moved and inspired beyond expectations. Well done. Now, me, I'm here because I want to give us standing ovation. So I'm hoping some people will give us some stories. So can I give 2 or 3 more people a chance? So that we give you a standing ovation. You're very well deserved one. Or are we trying to say that the people in this room don't feel like they deserve standing ovations? We do.
Okay, I'm going to come to this table because I haven't met this gentleman yet. Oh, here you are, BC. Give BC the mic. There you go.
We shared something you have rolled out.
Oh, you shared CV material. CV material, okay. I'm looking for non-CV material. Someone who stayed late at work. Something seemingly unimportant.
I have worked the last 4 weekends, and I didn't have to, but the work needed to be done. Yeah, and that was a first.
And you got the work done.
I got
well
the work
done. Can we
done.
give her a standing ovation? She got the work done in overtime and paid, but she did it. Well done, Samora. Okay, that's the kind of thing. The standing ovation that you deserve. Yeah, your boss has given you the standing ovation. Well done. Thank you, Lydia. Oh, yes, you see, the boss says that if Samora didn't do it, she would have had to do it. So somebody says thank you. Yeah. Okay. Any more stories come to mind? You know I'm coming here.
Good morning.
Good morning.
My name is Aswila. I come from Mombasa. I'm from Chuda Sub-County. We are quality leads in our facility. So yesterday as we were traveling in the train, there was this girl I was talking to, and I found out parents, sometimes we actually neglect what we are supposed to do. And as I was talking to her, I saw there was a lot of anger in her. Okay, I forgot to tell you, I'm also a counselor. So there was some issues with her. She was fighting some issues with her parents. And I noticed that anger was not well dealt with. So yesterday she was able to talk about it, and she was very happy. So I'm pleased I was able to talk to her and she was able to express herself. Yeah.
going out of your way to do counseling on the SGR train. Come on, that one is definitely worth the standing ovation. Mudhoni?
Are you asking mine or my
Anyone,
colleagues?
you can talk about yours or your neighbors.
We talked about achievements.
This is an important learning moment.
But I have one.
Oh, okay, there
Yes.
you go.
On my kitchen table, there's a bowl of tomatoes that I grew from the kitchen garden.
Wow.
I've been trying to do tomatoes and they've always refused.
Wow, even me, I'm impressed.
Yeah.
Growing
I am
tomatoes
impressed.
is not easy.
Yes, thank you.
Well done. You see, standing ovations are very well deserved. And we know we put in the effort and we thought about it and we tried. Okay. Where?
Good morning, everyone. I'm Onole from Lagos, Nigeria. I lead the QI team in my hospital, and then there was a time when a lot of people were discouraged from continuing with QI, but by God's grace, I was able to sustain the team, kept encouraging them, and today we have a strong QI team.
Well done. You know, we all know that in order for a team to work together, somebody has to be the encourager. And we are grateful for that. Mary, I'm coming to you.
I'm going to share one of my moments. There was a bad night in the neonatal ICU. And after a very prolonged attempt by the team and myself, I'm a pediatrician, in front of the mother, we lost the baby. And she watched everything that we did, and she was someone who was alone. And about 4 hours later, after I had a space to take care of someone else, I found her tea and bread and brought it to her, because her bed for recovering from this was in the ward with all the mothers whose babies were crying in next to them.
That's a standing ovation, noticing someone in need. I hope I'm getting the idea into our heads. The things that amaze us, the things we can wonder at, are many, and we are doing them every day. And they are not the things that land on
on our
us.
CV. And so each of us are very well deserving of that standing.
ovation. So let's perhaps start our day by giving all ourselves a clap. We deserve it. I also hope that by now you know the names of everyone on your table at least. That was also part of the work. Do you? So we're going to transition to session 1. And as we transition into session 1, we are trying our best to ensure that we rely on the people in the room, the people online, as the true experts. You know, a lot of times when we invite speakers who have a lot of experience and are definitely experts, we imagine that they are more experts than us. But we too are experts. So we are doing something. Every session has Mentimeter questions that offer us the opportunity to start with everyone in mind. So please go ahead, Ron, and share with us the session 1 Mentimeter questions. And as he is doing that, I would like to invite Lydia to come. Lydia, you can go ahead and come. She'll be leading session 1, and she'll be inviting the 7 participants from 7 different countries who are joining us here to come and join us. We are so grateful that you're here. Change happens with us. Okay, welcome, Lydia. So we can give a few moments for all of us to screenshot the Mentimeter. It's just 3 questions. And after you invite them as they're coming, I will go through the answers.
Good morning. In Nairobi, we say habari. Habari yako is how are you? So glad that you're here. I hope Tenza has pronounced it right. Habari yako. Great. So we will first have a keynote address from our great speaker, Reneville. Reneville is from Manila, and we are happy that she accepted to join us. Allow me just to open a document here. Great. So this is how the session will be going. We will have the keynote address, and then we go to the 7 speakers. We have multiple countries represented here, and we are so glad that we are having Africa on the stage after a very long time on a matter of patient safety. I remember, is it 2019? There was a patient safety initiative meeting. That must have been in Cape Town. Maybe a few of you could have been there, but I see countries that were represented. So once again, we have an opportunity to look at the Global Patient Safety Action Plan. What is that? It is a framework, it is a plan, a strategy that enables us all to know that are we meeting the required or the desired direction to ensure that there is zero harm at multiple levels, at a hospital level, at patient level, at the level of policy, and so it brings multiple stakeholders, including the healthcare workers. So the framework is a very important tool, and that will be the key deliverable of this session, of finding out where are we? Are we translating this strategy into action? What can we learn from each other? And so we will have Reneville come. After Reneville, we will go ahead to have the panel discussions from the countries that are represented here. And we are truly happy. We are truly happy to have you here in Nairobi, Kenya. I think I'll allow Ron to proceed and have Reneville's slide come on stage. Reneville works with the Ministry of Health in Manila. She's a medical doctor and has an MPH, Masters in Public Health, and she's been advancing patient safety in the healthcare space and supporting building capacity initiatives and just running the country's agenda with regard to patient safety. They did a great hosting of the Ministerial Summit, the 7th Global Ministers Summit. All the ministers of the world met in Manila this year in April, and Reneville was our host. So as we go towards listening to Reneville, she's not only at policy level, but she, at a global level, she's been bringing people together. So her and her minister were the hosts. She was part of the people who make things happen at the background, but they had a great global ministerial summit. Let me know when we are up with the slides, and I think Reneville can share. Or Ruth Paul, did you want a discussion on the Mentimeter as Reneville gets topping up the slides?
Reneville, please accept to be a panelist so that we can give you the opportunity to speak. But as she's doing that, let's see, what is the biggest barrier preventing your institution from implementing the 7 Global Patient Safety Action Plan strategic objectives right now? Okay, so I can't, we only have 3 responses. Are people in this room not responding? Okay, so as you people are filling out your responses, I want to hear how many of us have looked at the 2025 report of the Global Patient Safety Action Plan? Just by show of hands. Have you looked at the Global Patient Safety Action Plan at all?
2024.
2024. The one that came out in March last 2024.
Yeah.
Yes, that's what I mean, yeah. So how many of us have had a look at it? Okay. I see a couple of hands. So this session gives us all the chance to become familiar with the Global Safety Action Plan. So I know you all have your laptops in front of you, so why don't you go and have a look at the plan as we are having a discussion about it. Okay, let's see. I'll give you the answers to this. Wow, okay, so go back. I didn't see what was the majority. Okay, so QI leadership barriers. Insufficient commitment or support from management is what, and then second is system barriers, lack of infrastructure. Okay, resource barriers comes last, and of course, we don't feel like cultural barriers are an issue. Okay, let's go to the next question. So each session will have 3 questions that give us an opportunity to generate information. Let's do the next one. Okay, so everyone feels like the statement that best describes your experience with the Global Patient Safety Action Plan is it's new learning. Okay, it's great. We are all here to learn. So that's a good reason. Let's go to the third one. So the 7 strategic objectives, which is the most urgent patient safety priority in our context. Wow, we all agree, good with adaptation, relevant but needs significant local adaptation. You know where adaptation starts? In this session right now. So you're doing the right thing. So Ron, is Renevel ready? You're going to hear Ron's name a lot. He's a fantastic comms person running things over here.
Can you hear me? So as we wait for Renevel to load the slides, just to up your appetite, we'll be having the countries represented. We'll have Dr. Irungu from Kenya, who head the patient safety unit at MOH. Dr. Irungu, you can wave. Great. Thank you. Dr. Irungu is in the house. We have Dr. Selina Dusey from Ghana. You can wave. Great. Please a clap. Yes, thank you, Dr. Irungu. Thank you, Selina. We have Dr. Edwin from Uganda. Is Dr. Edwin around? Great. Glad to see you. And we have Dr. Oyebed Caleb from Ethiopia. Is Dr. Oyebed around? Awesome. You're welcome. Then we have also Dr. Alphonse Chandika from Tanzania, majirani wetu, our cousins. Thank you. Dr. Ebed, you will soon learn when Kenyans say you're our cousins. It has a big name, binamu wetu. Then we have Dr. Bogani from Malawi. Great. Then we also have Dr. Olatuji from Nigeria. Awesome. Session 1 is a nice, good representation of Mother Africa. Thank you for coming. I can see Renevel is with us. So we'll hand over to Renevel to give the keynote address to this session. Thank you. Renevel, you're welcome. We are very much honored to have you joining us. And thank you for having us in Manila just this year. You did a fantastic job. Pass our regards to your minister who hosted us very ably. Thank you. I'll tell you when I can hear you. Not yet. Somebody needs to unmute. I don't know whether it's our side or your side, Renevel. Maybe it is our settings.
I'm wondering, as we're trying to hear Renevel's voice, Lydia, you were in Manila this year. What was your takeout from that meeting? I'd love to hear.
My takeout is that we know what we ought to do. Maybe on behalf of Africa, we'll have the takeout in this room after this session.
Patient Safety Action Plan strives to eliminate avoidable harm in healthcare with the vision of a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. Key players include the governance, healthcare facilities and services, stakeholders, and the WHO. And the goal is to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally. It enumerated the 7 guiding principles to establish underpinning values to shape the development and implementation of the action plan. So this GPSAP demonstrates a framework consisting of 7 strategic objectives, each of which has 5 implementation targets, as shown on your screen. So I know most of us are already familiar with this, so I won't be enumerating them one by one, but those who aren't, you may download them from the website of the WHO Patient Safety Flagship. This targets guide the Philippines' activities and initiatives. So the GPSAP, as well as the National Policy on Patient Safety and its strategic plan, drives the Philippines' commitment and implementation forward to promote and integrate patient safety in health service delivery to improve health systems and outcomes. The program ensures its alignment to the overall implementation of the universal health care with the aim of preventing avoidable harm in prevention, diagnosis, and follow-up. Equipped with a clearer guidance for implementation in health facilities, our revised National Policy on Patient Safety builds on the previous version to better address current challenges and evolving risks. It outlines the specific roles and responsibilities of the Patient Safety Unit or Committee and the Patient Safety Officers, ensuring accountability and structured action, details of which were fully described in the policy. So the policy underscores the institutionalization of patient safety to improve safety in health service delivery, including that of the vulnerable population. This applies to all government and private health facilities providing preventive, promotive, curative, rehabilitative, and palliative care. So the National Policy on Patient Safety centers on 3 strategic guidelines. First is institutionalizing patient safety across all health facilities and at every level of care. Second is engaging and aligning all stakeholders to support the achievement of broader health system goals and establishing and sustaining a culture of safety and a no-blame culture. So the policy places a particular emphasis on fostering a culture of safety and promoting no-blame environment, recognizing this as critical foundations for the successful and lasting implementation of the patient safety efforts. So 6 strategies were subsequently identified to further guide the implementation, and these are improve operations and management systems, assess the nature and scale of harm, ensure competent and capable workforce, prevent healthcare-associated infection, implement key priority areas, and patient safety research. So to support these strategies, the National Patient Safety Program Strategic Plan was developed, which provides us now with a detailed roadmap and overall direction in the planning, financing, implementation, monitoring, and evaluation of the National Patient Safety Program in health facilities. So completed in 2022 with the support of the Patient Safety Technical Working Group, the program envisions that by 2028, all health facilities will fully embrace a culture of safety for both patients and healthcare workers. This mission is to lead health facilities in delivering people-centered care and fostering healthy workplace environments through collaborative, evidence-based approaches aiming for a 25% increase in data-driven implementation of the patient safety program within 5 years. So to achieve this, the program adopted 7 major strategies. So responding to the needs of patients, providers, and facilities, strengthening networks and partnerships, and enhancing monitoring and evaluation aligned with the culture of safety. Following this strategic plan, allow me to share some highlights of our national implementation. So through continuous advocacy and collaboration, the inclusion of a dedicated quality improvement, PC and patient safety unit in the revised organizational structure and staffing standards for level 3 government hospitals marked a significant step forward. Notably, this includes the designation of a patient safety officer or focal person whose sole focus is on patient safety. This development addresses a long-standing human resource challenge where the role was previously treated as an added responsibility alongside clinical duties. This often limits its effectiveness and the functionality of the patient safety program in the health facility. And to better equip the healthcare workers and patient safety committee, the basic course on patient safety and quality improvement was developed. This is accessible for everyone registered in the Department of Health e-learning academy. So the development of the advanced course and training of trainees is already ongoing as well. So now we go to the Philippine College of Surgeons collaboration with the Operating Room Nurses Association of the Philippines, who adopted the WHO Surgical Safety Checklist in their operations to better align with the local context and the specific needs of surgical practice in the Philippine healthcare facilities. The enhanced version includes supplementary tools such as the safety officer checklist and the pre-op huddle checklist to further support surgical care. The modified checklist underwent pilot testing in the selected facilities with the involvement of healthcare personnel, ensuring its relevance and usability. Following this, it was officially circularized for adoption and implementation across appropriate healthcare settings. Another important patient safety tool that has been adopted for use in the Philippine setting, even in primary care facilities, is the WHO Safe Childbirth Checklist. This checklist supports safe and quality care for mothers and newborns throughout the childbirth process and reinforces essential practices to reduce preventable harm. We also developed the patient safety indicators by the Patient Safety Technical Working Group to monitor and evaluate key priority areas for patient safety in the Philippines. So these indicators are adopted from the framework of the Agency for Healthcare Research and Quality, or AHRQ, which defines patient safety indicators as standardized measures that use hospital inpatient data to identify potential safety issues such as complications or adverse events. In the Philippine context, the PSIs focus on the following priority areas: patient identification, effective communication, safe surgery, medication safety, fall prevention, and infection prevention. So these indicators to performance, identifying risks, and supporting continuous improvement in patient safety across health facilities. These PSIs have been integrated as a dedicated module within the DOH Health Facility Profiling System, with all health facilities required to submit health facility data annually. So not only patient safety, but we also have infection prevention and control assessment tools, healthcare waste assessment tools, nursing service assessment tools. So those tools are integrated in this health facility program. The healthcare facilities. So this systemic data collection enables evidence-based decision-making and supports the development and implementation of targeted policies in key patient safety priority areas. So we develop, so those data are analyzed and they become the health facility profilings. They are compiled in a health facility profiling annual report, which is also published and circularized annually. So additional reports include an annual update on the patient safety strategic plan, which highlights the accomplishments for the year, as well as the priority activities targeted for the following year. So this guides the health facilities to target to target our activities for the next years. So we also institutionalized the use of standardized client experience survey tools for hospitals and primary care facilities. This is to measure the responsiveness of the health facilities to the needs of the patients and their caregivers. So submissions are already centralized through the previously mentioned health facility profiling system, and it is subsequently reflected into a dashboard. So the data is analyzed and interpreted to better understand the patient experience in our hospitals. So the hospital's client experience survey rating, along with the healthcare associated infection rates, serve as one of the core indicators of the hospital scorecard that is a big percentage of the computation of the performance-based support for hospitals under the national government. So this initiative does not only provide quality and safety that is felt by the people, but also incentivizes hospitals that continuously integrate continuous quality improvement in their systems. So stakeholder engagement and advocacies has also become an integral part of our initiatives, which has led to the expansion of the Patient Safety Technical Working Group to include a drafting committee for the purpose of developing the Patient Safety Manual of Standards. So this technical working group is composed of experts and stakeholders including patient organizations, private and government health facilities, professional organizations, and the academe. So continuous celebration of the World Patient Safety Day every September 17 is also done, where we encourage various health facilities and regional counterparts to lead and own the advocacy for patient safety by conducting activities. So these activities include lighting of iconic monuments, which is the signature mark of the global campaign. So if there are no iconic monuments in their areas, they light up their respective health facilities or do some candle lighting events. So while others conducted photojournalism and quiz bee competitions, lectures or webinars, and pledged commitment to patient safety. So, and as we are driven by shared goals to integrate initiatives across various national programs to advance quality healthcare, we hosted a best practices for quality conference where exemplary practices from hospitals and primary care facilities were showcased and awarded. A compendium of the best practices for quality healthcare services was then developed and published online as a flip book. So we conducted the National Patient Safety Summit to engage healthcare leaders. These are from the medical center chiefs, treatment and rehabilitation chiefs, and other stakeholders as well in patient safety. And we discussed leadership and governance in patient safety, patient engagement, research, and capacity building to get their commitment in actively supporting patient safety implementation in their respective organizations. So from the national, we brought the summit to an international level. The recently concluded 7th Global Ministerial Summit on Patient Safety, held in collaboration with the Asian Development Bank in the Philippines, served as a platform for fostering international collaboration and reaffirming the country's commitment to the Global Patient Safety Action Plan. So the summit brought together health ministers and representatives from member states to share best practices, promote collaborative learning, and strengthen partnerships aimed at reducing patient harm across international, regional, and local levels. With the theme weaving strengths for the future of patient safety throughout the healthcare continuum, the summit reviewed the progress of GPSAP implementation and facilitated discussions on the intersections of patient safety with emerging global challenges, including climate change, patient engagement, and the strengthening of primary care. It ultimately enabled participating health ministers to identify key priorities and explore strategic approaches to advance patient safety worldwide. So a major highlight of the summit was the adoption of the Mandaluyong Declaration on Patient Safety, which is a landmark document that outlined collective commitments to advance patient safety globally. So the declaration committed to strengthening global collaboration for patient safety through transparency, shared learning, and the spirit of bayanihan. It emphasized embedding patient safety in health system governance, prioritizing investments, especially in primary care, and integrating safety into disaster preparedness and climate resilience. So it also called for people-centered approach that values lived experiences and promotes inclusive, co-created solutions for safer, more equitable care. And with that, I would like to share my insights. Improving patient safety requires system-level integration into the governance, leadership, and financing. So a shift from a blame culture to a learning environment is critical to encourage reporting and improve learning outcomes. Leadership support remains also a gap. So this is often due to the perceived costs, and staff well-being is closely tied to patient safety and must be addressed together. Engaging patients as active partners in care improves safety and trust, and reliable data, strong monitoring systems, and alignment with environmental sustainability are also essential to building resilient, safe health systems. For our lessons learned, policies alone are not enough. So without funding, implementation, and accountability, they fall short. So fragmented systems and fear of punishment still prevents open safety reporting, and legal protections and independent oversight are needed. Also, diagnostic errors remain a major issue due to the systemic and communication gaps, and climate change has introduced new risks requiring built-in resilience technology, while promising needs proper integration as well as training and safeguards to ensure its safe and effective use. And so for our innovations, key innovations include the development of a national patient safety manual, integration of safety indicators, and the creation of online training for newly designated patient safety officers. So this also includes innovations, also include best practices that are shared through national summits and compendia, and climate resilient infrastructure is being promoted, and AI should be used for diagnostics, but also it still has to be monitored as well. Reporting and reducing clinician burnout. So tools like Team Steps help support psychologically safe workplaces and reinforcing a culture of safety. So, and that is all. Thank you very much for your kind attention, and I hope that you have learned something from one of our you have learned something from our national implementation journey. And for inquiries and collaborations, you may contact us through the following channels flashed on your screen. So again, thank you very much and congratulations for this forum. I'll give the floor back to Lydia.
Thank you very much, Dr. Renevel. Another round of applause. I hope you can see the room. Maybe we can have one of the cameras for Renevel to see the claps. Another round of applause. Thank you very much. For the online participants, you can give your claps virtually. So we are truly inspired, haven't we? Yeah, that is impressive of the effort. And that is why we are here, to inspire one another. Thank you very much, Dr. Renevel. The Philippine progress and story helps us know what we can attend to, what road or journey we can take with regard with all those specific strategic objectives and initiatives. Yeah, what can we prioritize? Thank you also just for giving us the lessons, what has worked. Yeah, usually we learn from the successes and then also the difficulties that we've gone through. So allow me to now invite our panelists. We are happy that Africa is gathering. I think we will start with the host.
So that we quite start the panel session. Dr. Irungu, you're welcome. Dr. Irungu is the head of patient safety in the Ministry of Health. Recently, his department has been moved to National Public Health Institute, the Kenya National Public Health Institute. And so you're welcome to the stage. Then we will get to the representative that is coming from Malawi, Dr. Bogani. Dr. Bogani, kindly let's clap. Dr. Irungu, we keep forgetting to clap for you. Yeah, we were with Dr. Irungu in Manila. He represented the Ministry of Health, and he's been in the road towards structuring patient safety in Kenya for a while. Thank you. So Dr. Bogani is from Malawi, surgeon by background. And we are glad that you have taken time to come and be with us. But during the other introduction, in case there's something specific you need to mention about yourself, I'm happy, and the team will be happy to get that emphasis. But allow me to bring them to the stage so that we are quick to hear what they have, what Mother Africa is saying concerning this very important topic. Leaving no one behind, that is UHC, but UHC is a mirage without quality of care and patient safety. So our emphasis is towards zero harm, no harm during care. Great, so then allow me also to invite Dr. Olatuji from Nigeria. You're welcome. A round of applause for Dr. Olatuji. Great. Allow me also to invite our other speaker. We have from Tanzania, Dr. Alphonse. Dr. Alphonse, you're welcome. From Tanzania. We clapped him when he arrived here. Great. Allow me to invite Dr. Selim from Ghana. You're welcome, Dr. Selim. Have I missed somebody? Nigeria, Ghana, there's Uganda, Dr. Ouma from Uganda. You're welcome. And we have Dr. Kaleb Oyebed from Ethiopia. Now we are full house. So we have public health practitioners, surgeons, clinicians, all supporting patient safety, but in their respective countries. So we are represented here at policy level and policy matters. So you're welcome.
We forgot that the moderator may sit, but maybe the moderator can just stand. He's a soldier. Great. So gentlemen, Wow, I didn't know we only had one lady. Luckily, the moderator is a lady. Yeah, so Africa, have more ladies in your policy space. Great. So you're welcome. And having heard from what is happening in Philippines, it helped us just think, where are we as a continent? So we're welcoming each of you. You will have the mic. Take about 5 minutes. We don't have to do everything on the 7x5 matrix, but the specific issue concerning each of the countries. And by the way, the program has all their profiles. I've not done justice to it, but I'll be doing it as we continue. So the program has all their profile, and I've seen some hard copy programs around, so I hope you all have. Great. So we really have a rich panel, but more so, it's including East Africa, West Africa, Southern Africa. I don't know whether Ethiopia is in Northern Africa. Yeah, so we have quite a good representation of Africa. If we would put all the dots, at least would come to a significant coverage of the continent as far as policy level in patient safety is concerned. So I will start with the host. In 5 minutes, kindly tell us where we are as Kenya in terms of implementation of the Global Patient Safety Action Plan, and are there any innovations we are doing? Are there any partnerships? Tell us something. Thank you.
Yeah, thank you so much, Dr. Lydia. And let me also take this opportunity on behalf of the Kenya National Public Health Institute and the Ministry of Health to invite all of us to this great engagement. So in Kenya, we pride that patient safety has been recognized as a key initiative in achieving quality health care. Initially, we've been running patient safety under the Ministry of Health, but now the division that was hosting the patient safety, we are now domiciled within the Kenya National Public Health Institute. And going straight to what we've been able to do following the 7 strategic areas. So under policies, we were able to develop a policy and action plan in patient safety all the way from 2021. And recently, we are having a quality of care and safety bill that is being pushed, and we are hoping that is going to succeed. And of course, we've always been able to mark annually the World Patient Safety Day. In terms of systems, recently, like 2 weeks ago, we launched our patient safety technical working groups focused on around 4 thematic areas on medication safety, IPC, and other ones that I'll not be able to mention. And of course, as a country in the clinical space, we've always adopted the key WHO checklists, like the Safe Childbirth checklist, a surgical checklist, and we also have a division of health products and technologies, and issues around vaccines, blood transfusion that ensure safety on that. In terms of patient and family engagement, I can say we've not been so well placed in that, although during the development of our patient safety policy and action plan, we are able to engage and involve patients as well as patient safety advocates. And we have now recently included both patients and patient safety advocates in the patient safety technical working group that we just developed we started establishing last 2 weeks ago. In terms of health worker training, we have a package on patient safety training, which we have been able to incorporate into our MOH Virtual Academy, and we are working closely with the regulatory body so that we can be able to have CPD points attached to this training. In terms of research, not so well done, but we've been piloting monitoring of key patient safety indicators in like 8 facilities in 4 regions. although of course as expected, due to issues of blame culture, we are not getting so much feedback in terms of the incidents. We are not without partnerships. We've continued collaborating with patient safety organizations in Kenya, like the Society for Quality Health, Choir, we have COFPAC, we have regional collaborations, we have a group under the Patient Safety Afro team. We are a member of the Global Patient Safety Network and Global Patient Safety Collaborative. And recently we've been enjoying the Joint Commission International as a partner. And regionally also with other countries like Ethiopia, we formed the communities of practice, although these are specifically in IPC and AMR, but as you are aware, IPC and AMR are core system issues in terms of patient safety. So maybe that's in summary what we've been able to do as a country. Thank you.
Thank you very much. A clap. We'll go to our brother from Malawi. Thank you very much, Dr. Irungu. Indeed, there are unfolding new documents coming, new alignment. We didn't have such a robust technical working group. So it may look very small, but I think it is congratulations for having that happen, that it is an inclusive technical working group. When people talk, that is when movement starts. Thank you. So we'll allow Dr. Bongani to give us some highlights about Malawi. Kindly put your questions down. Reneville is still online, and the experts here, the policy makers are here. So put your questions down. There'll be a point we can raise them. Those online can post the questions online and specify to which presenter. I'm sorry we didn't do some housekeeping. We have washrooms. Ruth Pal, the washrooms are that direction? Great. What else about housekeeping? Wi-Fi? Okay.
We are getting your chair, Lydia, so just take a moment. I want to just mention, yes, we have washrooms just across that side. We have tea available outside as well all the time. The Wi-Fi this is an Accor hotel, A-C-C-O-R, Accor. It's like a big name brand. If you look at the Wi-Fi and you log in using your email, you will be able to have access to the Wi-Fi. And then I want to say to our people online, we have the chat enabled and we have a Q&A section. We're going to give you a chance to speak out your questions if you ask us to unmute. So you are as much a part of this forum as everyone else. So we want to keep welcoming the people online just so that they know they are a part of us. Please note that the people online are more than the people in the room. So I wonder whose meeting this is. Okay, back to you, Lydia.
Thank you very much. Dr. Bongani, kindly introduce yourself a little bit more in details and the specific work you're supporting at the ministry. It is usually motivating to hear and know what people are doing, especially to the leaders in the room. Then share the Malawi story, where you are and where you see yourself going with regard to the Global Patient Safety Action Plan. Welcome.
Thank you very much. Thank you for giving Malawi a platform to share its experience. So my name is Bongani Chukwapulo, and I wear two hats. So my first hat is I'm the Deputy Director for Quality Management in the Ministry of Health. And the way our department is designed, we've got norms and standards, quality improvement and quality assurance, and I head the norms and standards unit within the quality management. The second hat, I co-lead the Learning Center for Quality Management at Kamuzu University of Health Sciences. Its vision is to strengthen learning within the healthcare system in Malawi and in the region. So patient safety in Malawi has been integrated in the broader quality strategy. So what are the efforts that we've taken to at national level towards achieving milestones under the Global Patient Safety Action Plan. So we don't have a separate policy or strategy for patient safety, but the patient safety is prioritized in the national quality policy and is also prioritized in the overarching health sector strategic plan 3, which is running up to 2030. Within the national quality policy, we have got 7 priorities that are aimed at improving quality at health systems level, and client safety is one of the priority. Some of the strategies that we are prioritizing in that strategy is to safeguard against malpractice and harmful products, implementation of patient safety standards, implementation of IPC WASH standards, and antimicrobial stewardship. Within the overarching National Health Sector Strategic Plan 3, the first objective is to improve quality of care, and one of the strategies there is to strengthen client safety within the healthcare system. We have integrated patient safety standards within the National Quality of Care standards, and we're using these standards to rate facilities from 1 star to 5 stars. So the higher the adherence, the higher the stars, the higher the adherence to patients' safety standards. And the aim of this program is to build high reliable systems at facility level. Within the Quality Management Directorate, we have got a national patient safety focal person that is championing safety. We've also been involved in a number of patient safety grant challenges, so the surgical safety where a number of secondary facilities and tertiary facilities using a WHO surgical checklist. We've been involved in the reduction of medical-related harm challenge. We also do commemorate the patient safety day, and this year we'll also be commemorating it in September. Preparations are underway. We've been implementing infection prevention control and WASH interventions in almost all facilities, and the outbreaks that have happened, COVID-19, we've also been struggling with cholera and the mpox. This has also helped in intensify these interventions. We are implementing antimicrobial stewardship programs in a number of secondary facilities. The star rating program has been introduced to over 190 healthcare facilities, and we also have got a hospital ombudsman who does client exit interviews. This is a role where they're there to attend to complaints from service users, so that these inform improvement at the facility. And this one is an assigned role. It's either an administrative person, somebody that is not providing direct care. In terms of innovations, we're thinking that the star rating program has created a sense of competition among healthcare facilities. It's creating a sense of pride for those that are doing well in their stars, and it also created a sense of looking at adherence to standards as a journey, as opposed to just accreditation where either a facility is accredited or not accredited. We've also been involved in a number of partnership at facility level. So we've got hospitals that have partnered with international facilities. For example, one of our tertiary facilities is partnered with a facility in Germany, and they're looking at prioritizing reduction of medication-related harm. We're also at regional level. We're involved in partnership with a travel partnership with Zambia and Scotland. And one of the focus areas in that partnership is patient safety, and we're also prioritizing reduction of medical-related harm. In terms of challenges, yes, I think we've had a number of challenges. For the facilities that have been introduced to the star rating program, we've noted that most of them do not have policies to support, to assure patient safety. And as much as we have got quality improvement structures there, I think there is not much that is happening around patient safety. Most of the patient safety indicators have not been integrated into the routine health management information systems, and most of the patient safety initiatives are happening at secondary and tertiary level, except IPC and WASH. And yet most Malawians will access primary healthcare services. And this is something that we need to do to ensure that we decentralize patient safety at primary level. We are also yet to standardize patient safety training materials for in-service and pre-service, focusing on prioritized Malawi patient safety priorities. And just to finalize, looking at opportunities that we are thinking would benefit from cross-country learning. One, issues around patient service standards implementation, issues in relation to sustainability of certification and accreditation program. As you're aware that these are resource-intensive program, issues about capacity building for integrating patient safety and quality in pre-service, issues around co-production, which is a core issue that is being talked about that will be talked about in the next 2 sessions, and we would also appreciate to learn the integration of patient safety indicators in routine health management information system to encourage learning. Thank you very much.
Thank you very much. A round of applause from what is happening in Malawi. You know, there are times we go for conferences and there's somebody who's looking at me, would find out, so what can Africa pick from this session? Because some of the things being discussed are not in our context. So we are truly happy that we are hearing what is working within our context. So we've heard from the two. Next, I'll call somebody very special. We'll go to the farthest end before Dr. Uma. We will go to Caleb. Why? Because he represents also a sector that really bears the weight of patient care. Strategic objective number 3 is to do with the clinical aspects of patient safety. And it's good that Caleb, you are a nurse by background. That is very important. Are there nurses in the room? Yeah. There are very many nurses in the room. You even have nurse educators. Are there nurse educators in the room? Yeah. Hey, I thought somebody here will raise their hand and they're not raising their hand. So the nurse educators, you hold a great role in patient safety because patients will encounter you majority of their time in the hospital. But this time not with the lens of nursing, but with the lens at policy level from Ethiopia Ministry of Health. Let's allow Caleb to give us some insights on what is happening in Ethiopia. Kenya and Ethiopia were part of the Global Patient Safety Network. I think we are going to round 2, Dr. Irungu? Yeah, we're in round 2, supported by World Health Organization and by Imperial College in the UK as the academic partner. And they've had a lot of help from being part of the collaboration, but help given needs to be absorbed and contextualized. That is why we are here having this discussion. Caleb?
Okay, thank you so much. As already mentioned, my name is Yobed from Ministry of Health, Ethiopia. So I just represent the eastern part of Africa, especially the Horn. So now I'm going to present you in 5 minutes what has been done in Ethiopia related to patient safety. So the process of patient safety or the activities has been done related to patient safety is just started from implicit to explicit one. So it's progressed bit by bit. So the first thing we have done in our country, we have developed patient quality and safety strategy in 2016 to 2020 is the 5-year strategy. Through that strategy, we have developed a structure, national, under ministry, we have quality and safety structure. So that structure coordinate all the quality and safety activities. And also we have regional health bureaus. So under those health bureaus, there is also a representative for quality and safety. So after that, we also developed the second national quality and safety strategy. Here we have safety given priority by just after of the 5 strategic objectives, 2 strategic objectives are primarily focusing on safety. The 5th one, especially reducing avoidable harm related to healthcare service provision. So after that, we have developed strategies and policies, of which we have developed the IPC monitoring strategy, IPC policy, and also IPC monitoring and evaluation documents. And also we have introduced hospital-acquired infection surveillance, which is very important to know what is the magnitude of the infection. So we also introduce national patient safety guideline, which is very important one to shape our activities in our country. And also related to legislation and regulation, we have also introduced some legal aspects like every healthcare professional to report incidents when it's faced. So under the FA-MACA regulation, we introduce that too. So the other thing related to standard, we introduce the accreditation. So we have developed the accreditation program. So we also in the process of finalizing the hospital and health center accreditation program. So related to advocacy, we have celebrating Patient Safety Day since 2019 with WHO with different theme and slogan. So we use that as an advocacy and to just engage community on patient safety. And also we have also introduced clinical process related things like as you already know that there are 3 challenges in WHO. That one is clean care. That is IPC. We develop IPC program, and also we also introduce the medication that harm MR program, and also surgery. We just focus on the safe surgery checklist utilization, and also we develop national perioperative guidelines so that it helps us to improve the surgical services and IPC activities. So one thing we still need to do is engagement, patient and family engagement. We try to develop a committee at national level. Representative from patient associations are member of it. So we try to engage them through different policies development, strategy development. So that is also one of our activities we've done. So related to information.
You're summarizing?
Okay.
Yes, the last point.
Related to information system, so we have capacity building, capacity building, we develop in-service quality but safety training, which improve health workers, and also we develop master's program for healthcare workers for in quality and safety, and also we are incorporated pre-service patient safety in the curriculum, so we have also doing that. There is related to information system and research, we also develop incident reporting guideline, even though we still a lot to do in that area. We have also identified some hub hospitals, like excellence hospitals in safety, so we are also working on that.
Thank you, Caleb. Sorry for cutting you short. I hope you heard him say they're having master's program and training. I mean, myself, my heart is warmed to hear that happening in Africa. Thank you very much. I think we will then go to Dr. Latuji from Nigeria. But they deserve a clap. Let us give them a big clap. The three that I've shared. Yes, from Nigeria, you're welcome. Kindly proceed.
Thank you very much for having me on this platform. My name is Olanraju Olatunji Sulaiman. I'm a trauma and orthopedic surgeon. I work with the Federal Ministry of Health, specifically in the Trauma Emergency Disaster Response Division. I'm part of the National Coordination Unit of the Patient Safety, and I'm also part of those that develop the patient safety and care quality documents for the country. Nigeria as a country has embraced the culture of patient safety. However, despite the importance of patient safety, the implementation is still a bit slow. After the adoption of the 7th strategic objective at the World Health Assembly, the country swung into action and established a national coordination unit for patient safety in the Federal Ministry of Health, and they appointed a DEX officer who initiated the process of development of patient safety and care quality and implementation strategies, policy. So the strategic objective, 7 strategic objective, Nigeria has adapted it, and the action plan related to these objectives, some of which are already in the process before 2021, while some is still ongoing. As part of, at the national level, we have a document on patient safety, which was initiated in 2021 and concluded in 2023. We have other things at national level that is in operational with respect to patient safety. Take, for example, the country as a whole now include patient safety program in its budget. However, the funding is still not adequate enough, probably because the government funds some activity of healthcare that directly or indirectly affect patient safety. An example is that there's always provision for safe medical equipment in the budget. There's provision for training of medical healthcare workers to ensure patient safety. Another thing that we have at the national level is that the government have initiated the process of incident reporting system at the national level. Also at national level, we have a well-established clinical governance, and this is further cascaded down to the institution. At the national level, we have a well-robust safety clinical process. Take, for example, we have an established IPC program, policy, guidelines, and protocols, which is well established at national level, and also this is cascaded down at the tertiary level. At the IPC at the national level was further strengthened during the COVID, and training of trainers are ongoing for the IPC. Other safety programs that we have at national level, we have the medication safety program, we have the waste management safety program, we have different clinical guidelines and protocols that have been developed that is being implemented at the tertiary level. Also, we have standards for our facilities. We have standards for primary healthcare facility in our country. The country is in the process of developing a standard for tertiary hospital. At the institutional level, at the hospital level, we have a quality improvement team. We have a M&M reviews. We have clinical audit system at the hospital level. We also have clinical protocols that is being implemented at the institution level. Some facilities have incident reporting tools. However, there's still a bit lack of awareness with respect to that, probably due to blame culture and lack of legal protection. Nigeria as a country also, we have our own challenges. We have a lack of funding for patient safety, like I said, not because patient safety is not being funded directly, but indirectly in other parts of the budget. Patient safety activity are being funded. We also have weak reporting culture. Like I said before, health workers ordinarily wouldn't want to self-report themselves if there is any medical errors or clinical error. In fact, the country as a whole, when you commit a crime and you decide to go and report yourself, they'll look at why do you have to come and report yourself since you have been since nobody caught you in the activity. Also, we have because of that, because we don't have because we have a weak reporting system, we don't have enough data to actually learn from. And one of the solutions we are thinking that we're going to implement is to, in the next couple of years, the National Health Act will be reviewed, and hopefully patient safety is going to be prioritized in it. We also hope that we have a sustainable financing for patient safety, and we also want to continue engagement with the frontline professionals and also patients and patient relatives. And it is good to know that during the development of our guideline, patients and patient relatives were invited for the development of the guideline to share from their experience. We also need to establish and strengthen the incident reporting system in our hospital. So by and large, as a country, we have recorded some achievements, but we still know that there are areas of improvement in terms of patient safety culture in our country. Thank you.
Thank you very much. A big clap for Nigeria. With your population, we think your federal government, we give them a big round of applause for having that kind of reach. I think we will go to Celine before we finish with Alphonse and Ouma. Let's go to the lady so that we hear some soprano. Yeah, Celine,
thank you very
welcome.
Much.
Kindly represent
and
Ghana.
Good morning, everyone. Sorry, I have a bad cold, so my voice is a little bit hoarse. So my name is Selina Duse. I work at the Ministry of Health as the head of Quality Management Unit. The Quality Management Unit was established in 2017 when the Ministry of Health launched the first National Healthcare Quality Strategy, of which patient safety was embedded. So since then we have been working to ensure patient safety at all levels. In Ghana, we have now reviewed that strategy, and then we have the 2024 to 2030 quality strategy. But then we have now developed also from 2021 to 2023, we have worked to have a national patient safety strategy. Now we have a separate document for that, and we are working to improve patient safety. At the policy, again, we have infection prevention and control strategy. We all know when COVID came, we were needed to improve infection prevention. So as part of this patient safety thing and quality, we have a separate IPC strategy. And all these strategies are in line with the national health policy for the Ministry of Health. When you come to regulation, as part of the things that we are doing, we have two main regulations that I will talk about, even though we are three, but let me say that we have a separate regulator for facilities. So if Ghana, you want to develop, you have to have a clinic or a hospital. We have a regulatory body who to come and assess the safety of your facility before you can operate. Aside that, we have the FDA, the Food and Drugs Authority, that regulates our drugs and the food and also medical equipment at the national level, which is also an agency under the Ministry of Health. With this, I said earlier, we had the AMS, that's the Antimicrobial Stewardship document developed to implement for safety. Now we come to regulators, when I get professional regulators. Now, to the extent that we have made it compulsory a CPD, before a professional can review or renew your PIN, you should have a CPD in quality and patient safety. We have also included this into the pre-service curriculum, of which we are trying to get it at the medical school and then at the nursing training colleges. We also have a separate specialized course on infection prevention at the nursing and midwifery college, not the basic, but a professional one. When we come to capacity, again, we have built capacity for a lot of people in the health space, of which they have to know what we are talking about. If we're talking about patient safety, we're talking about quality, we needed to work on that for this. When we talk about field innovations that we have done, is that we have been able to establish a national quality and patient safety committee, and then also a national IPC committee. And then again, at each level of service delivery, Ghana, we have the national, the regional, district and sub-district facilities. And so we have quality teams across all this level. The National Quality and Safety Committee meets quarterly. But let me say this across, we're being supported fully by USAID. So this year when USAID left, we have been doing a virtual meeting every month. And last Thursday, we share, it's like a learning platform. We learn from safety, we learn from quality, and then we make input for that. And at a district and regional level, they also have their learning platform that they do. We have been able to implement the WHO surgical checklist to improve surgical site infection and also wrong site surgery. We have done this in assessment in the national, like teaching hospitals and some regional hospitals. What have you done again in involving patients or family and the community? We have a system of yearly patient safety conference and quality in Ghana, of which we allow patients, relatives, community members who come and share their experience. We also carry out every half year, we have client satisfaction surveys that is mandatory for every facility to conduct. This will help us improve the safety and the quality of care that we are providing. Again, we also have community scorecard, of which at the lowest level, community members meet quarterly to assess the services that they have received from the facility. And this has helped us a lot because when they meet, they bring us some gaps that they have identified, and then we have to improve on that. What can we do in the
last point?
Yes, moving forward. I am looking at a partnership where African countries, we can come together, if monthly, quarterly, we have a learning platform where we can share experience from each country like we are doing today, so that we can learn as to where we are getting to and what can we learn from each country to do better to improve the African system. Thank you very much.
Thank you very much. We'll then go to Dr. Alphonse. That is great. You've had USAID left, but we are still meeting. Yeah, we need to occupy our space. The patients are ours. Africa is our business. Plus or minus, all the partners. So it means that we truly appreciate the platform they gave you, but you have continued. Let us hear from Tanzania, Dr. Alphonse Chandika. You're welcome.
Thank you. Good morning.
Morning.
I'm representing the Ministry of Health. I'm a national focal person for patient safety, but professionally I'm a general surgeon, and I've also worked as the CEO of one of the tertiary hospital in Tanzania. So Tanzania, as other countries have presented, we are also doing a lot to implement the global patient safety action plan. First and foremost, with regard to strategic objective number 1, which is about eliminating avoidable harm in healthcare. We are currently reviewing our health sector policy, and the priority has been put much on the patient safety issues. So our past health sector policy, which was launched in 2007, now is being reviewed. So patient safety has been given a lot of priority to ensure that we align with global patient safety action plan. So when it's launched, then we'll ensure that we implement all those objectives or strategic objectives which have been mentioned in the global patient safety action plan. But in addition to that, the country also has developed some tools. For instance, we have AFIA supportive supervision tool, which has been developed to include patient safety standard. And it's a tool which is used to assess health system performance. So like this is done at the ministry level, and then it's trickled down to the health facilities where supportive supervision is done to ensure that all the services which are being offered there, they take into consideration patient safety. But also, the country has also developed a national patient safety guideline for healthcare delivery, which is in compliance with WHO recommendation, and it's also in the final stage for signing. So soon it will be signed and the guideline will be in operation. But still on the same strategic objective 1, the country has developed a national framework for safe surgery in Tanzania, and is also in its final stage, and later it will start to be operational, and all this takes into consideration of patient safety. But with regard to strategic objective number 2, we came up with an innovation which is on reduction of maternal and perinatal death, where we came up with a measure which we call maternal perinatal death surveillance and response. We abbreviate it as MPDSR. And this is a measure which is on ensuring quality improvement, including safety issues with regards to maternal and child health. And this is a measure which starts right from the health facility. In case when there is maternal death, the death is reported within 24 hours, and to the next level, up to the national level. And through this measure, the deaths are discussed from the facility level up to the national level to identify gaps, and then come up with action plan, and also running through that process people tend to run. But through this, we use the principle of no shame, no blame, and no name, which has also been emphasized in the Global Patient Safety Action Plan. And we have seen it working so well, because as as per now, we have managed to reduce the maternal mortality rate right from 553 per 100,000 live births to 104 per 100,000 live births. So we assume that this measure has contributed significantly to maternal mortality reduction. So we think this is something which our colleagues also can learn from us if you think it's the best option, and you can also apply it in our country. We have seen it working so well. So again, still on strategic objective number 3, as a country, we have been strengthening the use of tumor boards to ensure safety on cancer patients. We have really been very strong to ensure those referral hospitals who are taking care of cancer patients, they discuss these patients in tumor board, which is specialty discussion where multiple disciplines meet together and discuss and plan for management and care of cancer patients, which has really also improved on safety of cancer patients to make sure that they get the right treatment and also avoid avoidable harm which could arise from not discussing the patient thoroughly. But also the issue of...
Kindly summarize.
Yes, the issue of medication safety in the country, it is focused on a pharmacovigilance system and the reporting of adverse drug reactions. So there is a surveillance which goes on day to day at health facilities on reporting adverse events resulting from medication, and also the country has developed a national guideline for monitoring medication safety. But also going to blood safety, the country designed a national blood transfusion services where there are 8 centers in the country at each zone. These centers, they are all accredited except one. So the 7 centers are accredited, and these are the centers which are used to screen for TTIs, meaning that this is ensuring that patients get safe blood and avoid those blood transmission, infections. So, and these are doing very well, and it has helped to enable having, availability of blood, but also ensuring safety. So basically, there are many other implementations which we are doing to ensure that we align with the global standard of patient safety, and few challenges we are encountering. For instance, the culture, building culture in health facilities of safety is still a challenge. We are still working on it to ensure that all the health facilities...
Thank you, Dr. Alphonse.
Thank you very much.
Thank you very much. Sorry for cutting you short, but we are glad to host our cousins here. Yeah, thank you, Dr. Ouma from Uganda. Yeah, I remember when we were looking for somebody from Uganda, it came like, yeah, Dr. Ouma used to support this program. We didn't even know you were in the Ministry of Health. We thought you were a partner. So we are glad to have you. And it's like you did some remarkable work somewhere under some program, and that's why the flavor remained. Yeah. And we are glad for the Tanzanian team. They mentioned about lessons from MPDSR, from pharmacovigilance, hemovigilance, all to be taken to patient safety. Thank you, Dr. Chandika. So Dr. Ouma, you're welcome. Kindly share something from Uganda.
Thank you so much, Lydia, and the choir team. I'm so happy to be here, all of us, learning. I'm from Uganda. I'm Dr. Edwin Ouma, and I'm housed at the Ministry of Health in the Quality Department called SCAP, Standards, Compliance, Accreditation, and Patient Protection, where there's a specific program still ongoing on patient safety establishment through 5S Kaizen TQM, that's quality improvement. And really, we can talk the whole day, but we have to share in 5 minutes. So please just appreciate the summary, okay? As you can imagine, there are a number of things being done. They are fragmented, so there's no clear strategy. Following the GPSAP, we don't have a patient safety strategy yet as a country, but that is where we are heading to. What has happened is baseline studies have happened with support from the World Health Organization. We understand our patient safety situation in the country, but this specific project on patient safety establishment is supported by the government of Japan, that is JICA, and all we are trying to do is develop a culture of patient safety. Uganda, we run a regional approach. We have 16 regional referral hospitals, and it's a free-for-all public, healthcare system. No one pays. So the government funds everything. So we use those regions to support the healthcare system. All the lower facilities learn from the region. So this project is supporting those regions. Then whatever positive outcomes, we scale them nationally. And what I can say is that the quality improvement is strong. The structures are really strong. And we are hoping to use those structures to now onboard patient safety, okay? From the national level, we have a national steering committee. All facilities have QI teams, so the knowledge and understanding is there, but patient safety is weak, okay? And we also have other partners, civil society organizations and other partners that have been supporting, but since the Trump levied his instrument, it has been now, funding has been a challenge, but we shall still go on. So through the project on patient safety establishment, the idea and the approach is to start with work environment improvement. That is called 5S. It's a mindset change tool. People appreciate the work environment, make it safe, and then we keep moving upwards. Every facility that achieves good 5S practice, then we introduce quality improvement. Then from quality improvement, that is through Kaizen, we introduce safety initiatives. And based on the data that we have collected and the situation that we have, we recognize a lot of gaps, okay? But we need to first drive awareness, we need to drive ownership and people to appreciate these things. Then we can start on, talking about patient safety in a more pronounced way. So currently, with the data that we have developed, we are thinking that through introduction of an incident reporting system, which by the way we are calling hospital safety report instead of incident reporting because of the positive connotation, we hope that facility teams can learn from what is happening in there and then try to work upwards through QI approaches to establish safety mechanisms for the patients. And that is really what we are hoping to establish. So right now we are developing the guidelines or the guidebook on safety reporting. And once this is out, we hope that we can roll it out all nationally. The reporting is still very weak. The ownership, especially by the clinicians, is very weak. But it takes time. We really believe it takes time. Organic growth is what is needed and people will appreciate. The blame culture is still there. People do not want to come out and showcase. They think they will be blamed. But once this starts changing, we believe that we can develop this. So probably the opportunity we have right now, we have a quality improvement framework and strategy. It is due to be revised. We are thinking of now introducing in patient safety strongly in that framework to coordinate all these fragmented approaches we're having. So we have one national program on patient safety that is very strong, and then we can ensure that we collect all the data and have data-driven decision-making from all our facilities. We of course observe World Patient Safety Day every year, annually in September. We have client engagement has improved. We have the routine client feedback system. Every day, clients give feedback, and all facilities nationally have targets monthly from the lowest to the national specialized hospitals, and that's very good. So we have data coming through. What we don't have is the specific patient safety program that we hope probably this financial year we can work on through stakeholder engagement. I'm here to learn more from all of us and see what can aid us to develop that in Uganda. Thank you so much.
Thank you very much. A big round of applause. So we would want to stop on time, but why did we have all these countries represented? So that we can know how to engage and learn, and then also to have an opportunity to have, like, what if we would have a clinic whereby you're saying policy level, there's a hospital, there are patients representatives from the same country, and we hear what they will say. So this is the beginning. So thank you very much. We'll only take 2 comments and 1 from online. In case there's somebody online who can say something, a question, a comment, and from the room.
Okay, so as she's taking the microphone, if you were here last year, you remember I enjoy this role of reading on behalf of the online people, so get ready. We are so grateful to hear from people from Kenya, from Botswana. Uganda Matters Hospital is saying, good morning, Arthur. They're saying, we are excited to learn. They're saying thank you for the good work. They're saying thank you for making this possible. Then on to some comments about this actual work. Let me do a better job scrolling. First time attending, I'm learning a lot. I'm a physiotherapist from Botswana. We see you, Mafane. We are saying lots of learning from my end. We are doing things in favor of promoting patients. It really warms my heart to see this discussion. That's Lawi from Embakasi in Kenya. We see a lot of learning a lot. There's someone saying we believe inbuilt behavior of nurses and technicians must be implemented. We must practice the discipline. Well done. I hear Lynn Fube from Zambia is saying she's learning, she's listening. What a story that African is telling. We are rest assured the learning and implementing is happening behind the scenes. So thank you for giving us a taste of what is happening on the ground. Remember, there's a Q&A button. If you ask your question, we will read it out. And if you put it in the chat, we'll be able to unmute. Let me hand it back to Lydia.
Yes, any 2 from the room? Yeah, we have 1 at the back. We can take 1 from the front. Sorry, we'll only take 2. The first one at the back. Ruth Pal, you can bring a mic to Tenza, and then I take the one at the back. Who was it at the back? Yes. So we'll only have those 2 so that we try to keep time.
Peter Muremi. I have two questions. The first one was to our first presenter, Renevel from Philippines. She talked about performance-based support for healthcare facilities. I think that's something interesting. I'd like to hear how they make that one work. And then the other question I have is from Dr. Bongani from Malawi, who talked about a very interesting concept of a star system of rating for healthcare institutions in regards to quality. And one of the big questions I'm having is, what is the impact of that rating, and is the rating public?
Thank you very much, Peter. I hope Reneville is able to give a feedback there. We get the next question, Tenza, or the next comment.
Thank you very much. Good morning, colleagues. My first comment is to the colleague from Tanzania. It was very interesting to hear that there is a country in Africa that has started to implement the no name. We hear a lot about no blame, no shame, but we don't hear about no name. And it will be interesting to know how they establish the anonymous reporting, if there is such an anonymous, but how do you achieve the no name part? And then the colleague from Malawi is also around the STAR program. I just wanted to know how is objectivity ensured in the evaluation of the STAR program? Thank you. How do you make sure it's objective, the evaluations? Thank you.
Thank you for those two questions. So for Malawi, we started with accreditation on a pilot level, and in 2023 we transitioned to the STAR rating program because we noted that the accreditation was not really working for us. We realized that facilities will be at different levels. So in 2023, we developed standards and we started assessing facilities in 2024. And we have not yet started making them public beyond the Ministry of Health, but there are plans to do that. I think the idea is to be publishing in papers, to be going on radios. I think those things will be done this year. But during our joint annual review, the results of different facilities were made public within this, to the stakeholders that are working with the Ministry of Health, and the facilities were given certificates, those that scored 2-star and above. In terms of objectivity, I think that's something that for national assessors, we train national assessors, so it starts from training national assessors. So we have got a pool of national assessors that are trained. They undergo 2 weeks training and they are certified. Every year they're expected to, for them to be part of the program, they're expected to be involved in at least one assessment that year. I think there's still opportunities for us to ensure that the assessments that are being done by national assessors are comparable. Yeah, so I think that's also something that will continue improving and supporting the national assessors. Thank you.
Thank you very much for the response. Usually for change management, at times the diffusion goes slowly, yeah? And we are futuristic. So I hope you've been answered, Tenza? Okay, thank you very much. But I know in terms of anonymous reporting, no name, no blame, it's usually a seesaw. But you try to see whether you can get an average somewhere and that you keep improving. That is bold, and indeed we hear you. There was another question for Tanzania. Oh, it's been, okay, great. And I hope Reneville is on to give a response.
Yeah, thank you very much. Yes, the no name issue you asked. Yes, the issue is to not like stigmatizing someone. because when we are assessing the cause or the root cause of the problem, we are looking at the system. For instance, you don't need to mention probably a patient maybe was supposed to be seen by a specialist, and then maybe the specialist did not come. Now, when we are reviewing the case, we look at what is like the system like. Is there something lacking at the facility, or are there some protocols missing which we are supposed to make sure that the specialist is supposed to be there? So you don't need to straight go and mention someone, rather than you discuss, looking into the system, what are the deficiencies in the system so that you can make improvement. That's why we don't want, otherwise if you mention someone, they will tend to shy away, the blame automatically will come. But otherwise, if the issue is assessed and probably we realize that there is negligence, that is another issue. But if the system issue, then we need to solve the system issue rather than going into an individual. Thank you very much.
Thank you very much. I know we have questions. We'll talk about them during tea. But before we leave, before Renavel leaves, and we come to a close, kindly expound on the performance-based model. There was something you talked about, I think quality improvement and patient safety, that as a country you're having a performance-based model. I think the interest could be, so what metrics are we using, or what has been the journey, if somebody wants to take that on. Welcome.
Hello.
Yes, we can hear you. Yes, we can hear you.
All right, so the metrics, so we have this, what we call the hospital scorecard. So every year there is the Department of Health of the Philippines. They give maintenance and operating expenses budget, right? So with that, there are also formulas that is included in the company expenses for each of the facility that is under the national government, which is under the Department of Health. So aside from that, there is a performance-based bonus. So the hospital scorecard is included there. So there are indicators. So these indicators are based on the programs and based on the strategic direction of the Department of Health for its strategic direction of the Department of Health. So these indicators are set by the Department of Health, but we consult our hospitals here. So they are consulted regarding the indicators, and then they come to an agreement of what are these indicators. So these indicators will depend on what are the priorities of your ministry, and what are the priorities for the health facilities. So we have, for us, we have strategic indicators. So this strategic indicators comes from is based on the strategy of national health sector, and the other one is core indicators. So core indicators include the percent of, for us, the core indicators includes the percent of ER patients with less than 4 or less than 6 hours turnaround time. Examples are this one. So percent of patients with less than 6 hours discharge process. So it's on indicators on laboratory disbursement of the laboratory test result, and the rate, hospital-acquired infection rate, client experience survey score rating, and disbursement rate of cash allocation. So they have corresponding percentages on the hospital scorecard, and if the hospital achieves a certain percentage, there is a corresponding additional performance-based support that will be given to them. So this encourages the health facilities to implement this quality standards
so that the more that they implement this, it's the more that they are given, the more budget that is given to them. So as I have said, two of these indicators is involved in patient safety. One is for the hospital-acquired infection rate and the client experience survey score. So here it puts emphasis on infection prevention and patient satisfaction. So I hope that answered that question. So there is no set guidelines on creating this hospital scorecard, but you should, what was considered in creating this hospital scorecard is the priorities of the health of the government in health and the standards that should be the quality standards that should be followed in the hospital.
Thank you very much, Reneville.
Thank you.
I think that is the aspiration of even any health financing, to have value-based approach. So we are truly grateful. And so once again, allow me to bring this to a close, starting with our great participants. A big clap for yourself. Great. And we are grateful for our panelists. A big clap for them. And thank you, Reneville. A big clap for you. Love to see this. Thank you very much. So allow me to bring this to a close. Before you do that, I started with a question. Am I going to get the answer?
Next Reneville and Philippines for this year's Global Patient Action Plan meeting. What was your takeaway, Lydia? It was novel, ministerial, sounds. There we go. Yeah. My takeaway, actually, Reneville is the one who organized our academy. So as we were technical experts, while my brother here was with the ministers, so they needed to have security and everything and make sure. So we found them so busy, yet in all that mix, we got the technical aspect of who is running, who are the people, who are the foot soldiers, and I truly appreciated her level of depth. She didn't do any session, but she organized us, she planned us, and she made sure that every other minister had an experience in Philippines on behalf of her boss. So I think to me, her heart was at the right place. Okay. Yeah, to move this agenda, and I thought, why not export a bit of that to Africa? And I'm glad that it has happened. So Reneville, thank you. Thank you very much. I'm going to invite the panel to take a group photo. Amos, our photographer in-house, will lead that. As they're taking a group photo, I want to welcome us to take a break. Our tea is right outside here, so I'm going to go ahead and repeat what I said.
The washrooms are right across from you. You go through those doors, and there's a green divider that has shows you the men are on the right and the women on the left. I think you can figure that out. Now we are exactly 10 minutes late. So we are going to come back 10 minutes after 11. I want to also apologize in advance. The pre-check program has an error. We will start with Dr. Lachman's program at 10 minutes after 11. He's our keynote speaker. I am sure, we will introduce him at the time, but I'm sure everybody in this room is waiting to enjoy the 90 minutes with him. After that, we'll have a very brief opening ceremony, and then we will go for lunch. That Mentimeter screen you're seeing there is inviting you to share your takeaway. Both the virtual people and the people in the room. We've had 7 different countries give us their experience. What is your takeaway? What needs to be done? So please allow yourself to be accountable by writing them. You know, they say when you write your thoughts, it's like almost like a commitment. So let's go ahead and do that. But for now, we will be back in the room at exactly 10 past 11. The people online, you're going to forgive me. In about 10 minutes, we are going to close the Zoom and start again. We bought the license, we hope, for the breakout rooms. Dr. Lachman's session is breakout room, so we are trying to make sure that is ready by the time we start. So we're going to have to shut down the entire Zoom webinar and start again. So please just log in again on the same link. We'll only be shut down for about 10 minutes. If if that's okay. And we apologize, we are trying to fix things for everybody. What other things should I have mentioned in terms of housekeeping? Oh, Wi-Fi. Ron has shared the Wi-Fi. You log in using your name. Ron, if you can help us. Meg, is there anything else I needed to mention? So, nothing else? So those are the people who are a part of the team. I think you're going to hear their names over and over, but this is me saying, hope you're feeling at home. We can go for tea. Remember now you have a question to ask someone. What is the standing ovation story they did really tell you? That's what we talk about during tea. Okay, see you at 10 past. compassion and kindness. So is there a better person than Dr. Lachman to be offering us the keynote for our session at the Acquire 2025 Quality Improvement Leadership Forum? Let's give him the standing ovation he deserves. So as he's about to talk, I want to say one more thing about him. You know, titles are important. He was the head of the International Society for Quality, right? We should say that. And then you can talk a little bit about the Oxford publications you have. And then please mention that you're on our board as Acquire. So talk about all the wonderful things you've done. So your 90 minutes start now. Thank you very much.
90 minutes. Okay.
Oh, okay, maybe 80. I'll take 10 away.
She's very strict. Hello, everyone. Okay. So rule number 1 for the session is no telephones. Unless you are using Mentimeter. No email. You know, email is a terrible thing. Because what did we have before email? We had fax. Remember fax? Now we don't have fax, we have email. But before fax, we had letters. And before letters, we had people speaking to each other, with each other. Now we have email. And we're always on the email. So emails can always wait 90 minutes. Don't you think? Okay, so I really struggled to think what I'm going to tell you. So you've just heard what 7 countries do for quality and safety. Now, I'm fortunate I work in Mozambique. They weren't there. That's my next stop on Sunday. I go to Mozambique. We've been working there 10 years with the hospitals in Mozambique. And it's great work we've been doing with there. Next door to Malawi, just south of Tanzania. In May, I was in Tanzania, working with the MOH in Tanzania. And previously, I was in Ethiopia. And also in Sudan. Unfortunately, they have a civil war, so I can't go to Sudan anymore. But online, I do that. So that's my time here. Now, what I'm doing today is do a lot of table work with you. Okay, so that means I'm going to be walking around the tables. For the people online, you'll have Mentimeter. You'll go into breakout rooms, 5 per breakout room. There are 200 online so far. So when you go to breakout rooms, you'll have 5 minutes or so at your tables to quickly discuss a question. I'm going to do feedback because it's too much. But it's for you to start learning some of the principles I'm going to teach. Okay, let's go to the slides. Please, thank you. Okay. I've changed the title slightly. It's very pretty. So this is what idea number 1. You can see learning health systems for high quality care. Okay. It says sub-Saharan Africa, but I was asked them, I'm on the board, on the next board meeting, I'm going to say in Africa. Hey, don't you agree? In the whole of Africa, not only sub-Saharan. The people above above in the Saharan also want quality. Yeah? Okay. So I'll ask them to change the big idea to a bigger idea. But you can see the... Sorry. Okay. See, the bottom is to strengthen the capacity of frontline healthcare workers. That's why you are here. Now, as I was listening to people on stage from the ministries around Africa, the key thing that they have to do is this one. Strengthen the capacity of frontline healthcare workers. Without that, you can have as many documents, many strategies, many plans, but without the frontline healthcare worker, being able to improve and to be able to be safe can never be safe. And that is what we're here for today. Now, really, I think, now, oh, sorry. This is something that, last week I spoke on the ISQA program. They asked me to speak about patient safety in Africa. Okay, I'm kind of African because I lived in South Africa most of my life. I lived out of Africa for a year to a third of my life or so, but in Africa most of my life. And I've worked now in Africa over the last 12 years in those countries. And the idea is that patient safety should be part of our DNA. It's not part of a structure. It's not part of a plan. It's part of our DNA. You know, your DNA tells you what you're going to do. So that's the trick that we have to do, is how do we get into the DNA of people? Now, I'm actually not going to talk about a lot of that today. Today I'm going to talk about kindness mainly. And we work on a bit of kindness, but really, because I think kindness will be part of your DNA too. So, how we achieve this is that we've got to really get it at the bottom line. So in medical school, nursing college, physiotherapy, occupational therapy, etc., colleges, we need to insert the gene of patient safety into the. That's where it starts for the future. It's a bit late for all of us. You know, we've already got our genes from medical school. Not very good for patient safety. How many doctors in the room? How many of you had the gene of patient safety inserted in medical school? No hands. That's the problem. The gene of patient safety and quality from medical school and from nursing college inserted in year one. We've also got to have the gene of kindness. And that's the part I'm going to talk about today. Okay, let's get on to, okay. I'm going to go, then I know how this works, human factors. So, we're going to talk about the human lived experience. It's not patient lived experience, it's the human lived experience. You see in the middle, it says the patient experience. Let's put that down. The patient experience, and then you have the workforce experience, and then you have the community experience. This comes from the USA, from the Beryl Institute. And we can adapt it here for Africa. The first one is the environment, where people live. They come from a village. So when in Tanzania, we're working with them on developing quality improvement programs for primary care. So I said to them, I want to see where people live. So because the smallest area is a dispensary. Dispensary is a doctor and a nurse in a village. 4 rooms, 1 storage, maybe medications and so on, 1 treatment room, and then 2 consulting rooms, 1 for doctor, 1 for nurse. And it's in a village with a hut. Now in South Africa, we used to do this many years ago. Go to the villages and look at the villages, the context, the lived experience. Where do people live? How to deliver care at the bottom line. That's the real basis. That's where the quality starts. Not in the hospital. It starts in the villages around the country. So that's the lived experience of the people. And if we're living in Nairobi, I want to go where the people live, to understand their environment for quality. That's the start of quality and safety. The lived experience of the people. Of course, it's the lived experience of the people delivering care as well. So, sorry. So the lived experience has interactions at the touch points, every touch point across the continuum of care. So someone who lives in, I'll go back to Tanzania because I was there only 6 weeks ago. Someone lives, and I was working in Dodoma province, I was in Morogoro, and we went to villages. The person we call a patient has to come from the village, go to the dispensary. Then the dispensary says, no, we need to have more treatment. Then they've got to go to community hospital, community clinic. And then the community clinic says, no, we know now they need a community hospital. And the community hospital says, no, now we need to go to tertiary care hospital. The patient experience, the touch points. That's the patient journey. And I'm sure in Kenya, Malawi, Ethiopia, it's the same. They have to go at each point, and at each point, they have to receive kind care. At each point. They have to receive safe care at each point. It doesn't help one point being safe. Each point has to be safe. That's the continuum. But of course, the people in tertiary care don't know what the dispensaries are doing. When we were working in Mozambique, the people in a community hospital up in the middle of the country, Mozambique is a very long country. Unfortunately, being a very long country, it means that Maputo is at the bottom on the border with South Africa. And if you go up the country, the people have to travel to Mozambique for tertiary care. Now they have to go 1,000 kilometers, there's no transport, etc. And the people in the middle hospital said, the tertiary care doctors in Maputo, they never respect what we do. You know? They never respond to us. They always say, oh, what are you doing there in the community? Can you see? So the interactions for the poor patient, the person we call a patient, if the doctors and nurses don't respect each other, what can they get? Because they're the people at the bottom. The people with the lived experience. Two people. The people we call doctors, nurses, and all other health professionals, and the people we call patients. And when they come together, that's where quality comes. And tomorrow I'll be talking more about that. But I've got a bit of it today, okay? So, but the healthcare workers, you all healthcare workers, how many of you feel powerlessness to make change? You feel it's very difficult to make change. You can put your hands up here. Only one. You all like it. It's all easy to make change. Then where are your hands? Your hands must go up. This is not a question. This is a test question. This is a test question. Do you feel empowered to make change? Yes. A mix. So. Okay. Because that's what they were all talking about. We have to make changes. So we have to, but a lot of you, if you really go and speak to the nurse or doctor who's working with you, they'll say, I have no power to make change. That's powerlessness. That's the lived experience of most healthcare workers. A lot of healthcare workers do not have a sense of belonging, which is very important, a sense of belonging. This is the lived experience of healthcare workers, that they belong to a team with a common purpose, with a goal. That there's no meaning to their work because it's overwork. People belonging. This is one of the 20 I spoke about last week. It's on the ISCO website, hopefully very soon, for the African Community of Practice. You have to give people a sense of belonging. Then, and this all comes to kindness, because of course with kindness it's about a sense of belonging. A lot of people feel they're isolated and they get estrangement. We call this alienation. They feel alienated in their work. And when they're alienated, they get what they call normlessness. This comes from when I studied sociology with Durkheim and Weber, the Greek thinkers of the 19th century. And they would say that alienation, people feel estranged from their work. And when they get estranged, they get burnout. 50% of healthcare workers have burnout at some stage. When you have burnout, patient safety incidents go up, harm goes up in burnout. So we've got to address this. So that's the lived experience. So this session's about kindness, because kindness is aimed to get rid of all of this, being kind to each other. So we're going to talk about this today. The first part of my session is going to be a bit of talking, and then you're going to work the second half of the session. So don't think you're going to just have a lecture all the time. But yesterday I didn't have a lecture, actually. I came and I said, what do you want me to do? Because they only told me last minute. We wanted to talk. I thought, well, what am I going to do? So I had to think very hard. So everything is new here today. Okay, I just want to go forward. You just click the next slide there for me, it's easier. It's stuck for the moment. Oh, okay. So, next slide, yeah, okay. So, there was a quote somewhere. Mary, where's that quote? I couldn't find it. It was the quote of Paul Batalden. You had it somewhere. And it's in the program. So there's Paul Batalden, more or less what it looks like there now. Now I met Paul, I was fortunate, I was IHI in 1994, 2004-5, I met Paul Batalden. The man next to him is Chris van Hecht. He's from Belgium. Now I met him around about the same time. He's in Belgium, Paul's in America. And we started thinking together. I'm lucky to be working with Paul. He's now 83. Actually, I forgot to send him his birthday wishes yesterday. So he's 83. He's 83. And we're working together on defining where's the next stage. So what I'm going to do is, for this talk, I'm going to just take you through our latest thoughts. So Chris van Hecht and Paul and I came to an idea a few years ago, and tomorrow you'll hear more about it, about what is real quality in the new world. Next slide. I don't know why this is not working. Okay, the quality journey starts with standards. Now, when I was listening to the previous session, I was hearing more about quality 1.0. We have got standards, we've got accreditation, we have Malawi. Where's Malawi? I'm very interested in hearing that you have in stars, because it didn't really work in England, but they're bringing it back in England. Is like, is this a 5-star hotel? I think it is, a 5-star hotel. And then across the road's another 5-star hotel. But the quality may be different in each 5-star hotel. Doesn't mean having stars mean you have good quality. It means that on the day that the inspectors came, they had very good quality. You know, I always say to people, are you JCI accredited? And they say, we JCI. Are you COSASA? We COSASA accredited. Whichever one you want to pick. And I say, is the quality good? And I say, yeah, the quality is good. And I say, on the day the inspectors came. Doesn't mean that you're good all the time. So it doesn't mean you mustn't do it. I was head of ISQA, we accredit all the accreditors. Standards are your baseline. Your baseline. And we do need them. So it's very important. Quality 1.0. It's the start point, not the end point. Next one, please. Then over the last 30 years, we have quality 2.0. This is how do we improve our quality. I'll give you more about this tomorrow, if I have time tomorrow. Quality 3.0. So that's from quality assurance, quality 1, to quality 2, quality improvement. How do we improve? How do we make our service more reliable to meet the standards all the time? And the next one, quality 3.0. This is co-production, tomorrow's talk. So more tomorrow. This is to get you back tomorrow. So I'm not going to say too much. How can we co-produce health? But I'm going to give you a bit of this. Can we get the next slide, please? So that's the paper, free to download, and if you can't get it, you just email me. I give it to you. And we wrote that 3 or 4 years ago. People are now getting very interested in that. Next one. So this is what we think. 6 domains of quality. Click again. Person-centered care goes. Hopefully. Yes, there it's gone. And it surrounds everything. Now you have 7 domains. And unfortunately, it doesn't show. Just click, continue, click until I start. Next one. Okay. That's the whole one. So you can see in the center are values. Values. Oh, it looks nice. I'm better on that one. Values. Kindness with compassion. Dignity and respect. Holistic or integrated care. And partnership and co-production. The values. Surrounding the values, you have leadership and resilience. Resilience is learning, continual learning, and transparency. We're going to cover all of these. This is what we're going to talk about for the rest of the morning. The values to get high quality care. Okay? So we call this a multidimensional model. People are getting interested. Now, Chris is a researcher in Belgium, so we have hospitals in Belgium, 30 hospitals, implementing this. Testing, does it work? So we're testing the model in hospitals in an upper income country. We'd love to do it in lower middle income countries too. Australia are interested, and some people in South America are interested in testing this model of how can we get teams. And these are just the ones in Belgium who are testing, are ones who say accreditation doesn't work for us anymore because we're already JCI 4 times round. But we're still not safe, we're still not conscious. What do we do more? So we say, let's look at your values. When people say value-based care, I heard Lydia say value-based care, you can't have value-based care unless you have high values. English is interesting, the same word. Yeah, value and value. What is valuable? Depends on what you have as your values. Yes? So some people think it's really good to have very fancy clothes, spend lots of money. That depends on their values. Other people say, no, it doesn't my values. I'll have simpler clothes and give money to charity. Can you see? Values. Anyway, so next one, please. So this is the latest stuff, the latest theory. So then we finish with the theory, then we're back to table work. Okay, so good health care. This is what Paul and I are working on right now, so you're getting the very latest work. The first thing, it's about listening. Huh? How many of us listen to the people who come? How many of us listen to each other? How many doctors don't listen to their nurses? You know, when they're talking about deterioration. Okay, just to say, yeah, because I forgot to say it early on. I'm currently writing the World Patient Safety Day goals for 2025-6. World Patient Safety Goals the theme is neonates and young children. And I'm writing the goals. If anyone wants to help me, pediatricians in the room, just come and speak to me. I need some help quick. I have people from India. I need someone from Africa to help me. But I have also parents helping me. And one of the big things that parents say in safety of neonates and young children, we spoke and no one listened. We spoke and no one listened. So listening is very important. Observing nuances, body language, acknowledging the other, their opinion. How many times have the nurses in the room, hands up? How many times have you had to say to the doctor, I told you so? Lots of times. Or you wanted to tell them, I told you so. That doctor didn't listen to me, didn't acknowledge me. And for those who were here recently with me when I was here 6 weeks ago, I'm very pleased to be back so soon. Reflecting. How many of you reflect every day? So if you want to do that, we've got a course for reflecting, which I did last time, teaching people to reflect. So here you have good health care that's gone very quickly here. I'll tell you to change when I want it. So you've got listening, observing, reflecting. At the top, you have the patient. So there's the patient. They have a story. They have feelings. They have understanding. They want to know. They come into your clinic to the doctor. At the bottom, you have the professional, the nurse, the doctor, whoever it is. They have knowledge. They have skills. Unfortunately, they also have habits. Habits are good and bad. So, for example, a good habit is hand hygiene. A bad habit is not hand hygiene every time. A good habit is prescribing accurately, never abbreviation, double checking. A bad habit is having poor prescriptions. Unfortunately, that's a very bad habit. It's a terrible habit that most doctors have. Poor prescribing. That's a habit. Okay, so then you have it. So one more click. So now they come in, they come together, and then you have shared planning and anticipation. I'm going to try if I can work this one again. I'm going to come stand closer here. Just get this one done. Yeah, okay. Yes, working now. Okay, so now they come in and they've got two options. They can either make a service or make a product. What do we mean by service versus product? Okay, I'm here in a 5-star hotel. I actually get in a service. I go for breakfast, they say, you're welcome. Where do you want to sit? I'm getting a service. Or they could say, there's your breakfast. I'm getting a product, breakfast. Can you see the difference? The service is about people relationships, kindness. So they either get service or product. So if I come into my ICU, into my emergency room with a cardiac arrest, I want product. But my family wants service. Can you see? The family want to be treated well while you give me the product. I don't want you to be busy and say, how are you feeling? What are you doing when I need you to resuscitate me? That's the product, resuscitation. But the family need the service around the product. Can you see the difference? Do you all understand the difference between service and product? Unfortunately, most of us only give product, not service in healthcare. So we're trying to understand what's the difference. So this is where there's this interaction between service and product making. And to understand what happens, you have to start reflecting. Should I be giving service? Should I be giving products? Or how can I interact the two? And that goes back to your preparation. And this is what we call the safe connecting space. Okay. So that's what good healthcare we think looks like. It's this interaction between service and product. Knowing when to give the product and knowing how to give a service with the product. Lots of more slides, so you can click away. Okay, we're going to look at service and product making now. Okay. So let's look at, do you want someone take a photo of the last one? Okay, any photos? The slides will be made available to you anyway, so you don't have to worry too much. Okay, and we want feedback on this because we're learning on this. Okay, so here's the making a service. You have two parties have to make the service because the patient, person we call a patient, the person we call a doctor, a nurse, they have to make the service. They have to have trust. You can see trust and respect in the middle. Very important. You have to know each other. Tomorrow I'm going to talk more about this service and product stuff, on learning how to dance with each other. Sometimes they're changeable roles. Sometimes the person we call a patient knows more than the doctor, and the doctor's got to defer to that. The family, especially for pediatrics, people who are pediatricians know that never discount what the mother says. You get into big trouble if you don't listen to the mother. The mother knows the child best. How many times the mother told me they didn't listen to me? I know my child. My child was sick and no one listened. Okay, I'd say the change lean methods are not helpful. So it's no use bringing Lean Six Sigma to this part of work, which is more for product. How many patients can we see? Oh, we'll teach you how to do Lean, and you can see them faster. Doesn't help here. Making a product is a little different. So you see time removal may add value. Time removal may add value if you decrease waiting times. And here lean methods are helpful because you want to take out waste in the system when you've got product. Now healthcare went on, I think we think, now Paul, remember, is the person who kind of said every system's perfectly designed to get the results it gets. He said that many years ago. Sometimes he said he didn't say it, it comes from Deming. But he also said, he's also said in the quote that it's everyone's responsibility to improve healthcare. So making a product and making a service are both very important. Okay. So that's the action we have to take. So here we are again, back to my original slide. So the patients have to be prepared, and you see I put my story. What is my story? When they come to hospital or clinic, what do we take? His story. We should say a her story. You know, his story is very sexist because it's his story. Why don't we say her story? Her story. I'll change English because it's sexist. Because the people who wrote English were men, not women. So we can change it to her story or his story. That becomes the history. But the patient's saying, no, it's my story. They come with my story. So here we go, the preparation. Because this is a bit about storytelling. So the patient has to be able to tell their story when they come to see you. And we have to listen. We have to acknowledge. We have to reflect. There's in the middle. The professional has pedagogy, what they learned in medical school, nursing college. They have documentation. The documentation of my story, which, but whose story is it? It's a shared story. Now it's a shared story because it's a story of the patient, but as soon as your interaction, what's your name? Milton. Newton. Newton's my patient, is my doctor, and I'm Peter. I tell him my story. Now it's our story. But he takes my story and says, oh, no. It's his story. Can you see the problem? That's the fundamental problem in healthcare. We take people's stories away from them. Then we wonder why they're unhappy. And when something goes wrong, we say, oh, we've lost your story. We can't find the notes. Huh? No transparency. So, there they've got that. There, because the patient also has documentation. They may write down things they want to write, or they may bring someone with. Particularly, they come from a village, they can't read or write, or their level of health literacy is too low for what they have to talk about. And now they're going to come, and we've got to say what helps. Listening, observing. This is what helps. Yeah, I've got the roles. What's your role going to be? And hopefully, what are the steps? So these are the factors that we're starting to look at where are these steps going to happen in order to get good health care. Because at each level, the patient, the person we call a patient, has to be prepared. The person we call a healthcare provider has to be prepared. They haven't been trained to do this. They've been trained to steal stories and call them our story, now they're his story. Very interesting the way we use language. Okay, when and how do we change from one to the other? So let's see again the patient story. I think patient preparation. You see some of the things they say. So I'm a patient at the moment. You might hear a bit of the story tomorrow, but before I go to the doctor, I need to think about my story. What am I going to say? How many of you have been to the doctor and you don't tell them everything? You say, well, I'll tell him as this much. Anyone who smokes or drinks, the doctor says, do you smoke? Oh, 1 or 2 a day. Do you have alcohol? Maybe once a week. You know? We tell a bit of the story. How's things at home? Oh, fine. Can you see? We censor the story. So we tell that, but the things that have to happen, the language support, the resources needed to enable a person to tell their story. And this session is about storytelling. Healthcare is about storytelling. The person who comes to us tells us their story. We have to listen, acknowledge, process, and turn that history into what we have to examine for. When I trained in South Africa, the professors used to say, when you examine the child, if you find something if you couldn't find what you were looking for or something, you didn't listen. That's what they used to say. Your examination must confirm the history, what the mother has told you. If you go and do, then when you're doing your investigations, they must confirm what you learned from the examination, that you learned from the history that's tied. You mustn't find unexpected things because you haven't listened. You haven't listened and acknowledged. So that's very important for the patient preparation, and we have to teach people to do that. How will I tell my story? What language do I use? You know, in a place like where I worked in London, and we had 140 languages. In Cape Town, I used to work with children with very severe disability. And I would have in every clinic, I was in Cape Town, so they were speaking Xhosa. I couldn't speak Xhosa. So I'd have my translator. So I would say, ask them how they are. And then they'll talk for 10 minutes, and she'd come and say, fine. I say, what do you mean fine? You've been speaking for 10 minutes. But they've been discussing a whole lot of things. I said, right, tell me more than fine. Tell me the story that they've told you. You know, that they wouldn't tell me, but you know that. So the language is very, very important. Okay. How would I ask my questions? That's what they're saying. How would I ask my questions so I'm acknowledged as an equal? As an equal. What are my needs? What do I need? Huh? Think how difficult it is. What matters most to me? You know, I tell you, I've got prostate cancer, and when I went in to see the doctor, my oncologist, I said, look, I'm not interested in long life. I'm just interested in quality of life. Just quality of life. That's all I'm interested in. That's why I'm standing here. I've got quality of life. I'm not interested in long life. But another person may say, my mother has a difference. She had pancreatic cancer, non-treatable, and all she wanted was long life. She wanted to see my brother turn 50, she wanted to go to celebrations, and after all of that, she died. She wanted a long life. But the quality of life, terrible. She had to have chemo to do it. Difference. So I said, no, I just want quality of life. So what matters most to me? We don't often ask it, what matters most to you? A simple question. How do I feel? How do I feel? Can you see these are the kind of things of the building the patient story? And we have to enable people, we call patients, to do this. What resources do I have? Now you might say, oh, this is upper income stuff. But no, it's anywhere. This is human stuff. No, I don't have time to it. It's about your values. You can create time if you ask the questions in the right way, if you empower people. This is not about upper and lower middle income countries. It's about human values. So we're very interested in seeing how we could do this in resource-poor settings, where people say we're very busy, but I can tell you, I go to England and they say, oh, we're very busy. And they've got lots of resources. Go to America, very busy, but they've got lots of resources. So everyone's very busy. It's what you do with your resources that you have. So, okay, so I've got to go backwards. Okay. So here's just remember, this is the good health and care. And we are looking for people, while I show this, we're looking here for people to help us define this. Are we on the right track? So after the session, if anyone wants to help me, just come to me and you link up with us. The privilege you'll have is helping someone like Paul and I define what it is, and we asking for help. Does it make sense, everyone? So the whole thing is about storytelling. As you can see, We all have our own stories. Now, I just got to check my time. Okay, how long have I gone? Half the time. Is that right? So now the other half is all your work. The first thing is you have to have a vision for kindness. Okay, so Mentimeter number 1. The guys online, everyone online, you've got a Mentimeter. The people at the tables here, you have a choice. You can have 2 choices. What would a kind service look like? One word. This is kind of one word. What would a kind service look like? And also at your tables, discuss this. Yeah, the people in person can discuss it together. We had to move from Slido to Mentimeter very quickly. Ron, thank you very much. Team over there, they did a fantastic job being kind to me to put the Mentimeters in during the tea break. They didn't have any tea break. Okay? There can we see the results? What would a kind service look like? Hopefully they'll put some words up. You can put them into breakout rooms. Can you get some results?
Yes, so the breakout rooms are open, so just to let the virtual people know that they can join them.
So in your tables and in the breakout rooms, discuss what's going on there. What a kind one be. Go about 3 or 4 minutes. Breakout rooms take a bit of time. We're testing the breakout rooms now. So this is discussion time at your tables. So after you put in your phone your one word, each puts one word, not more than one word, and then now talk at the table what you've seen going up there. Okay, over to you. I'm walking around the tables to make sure you discuss. Words. Okay, there's some great words here. So, breakout room people, please write in the chat. Breakout room people. Ruth Pearl. Okay, everyone, I'm coming round to a table or 2. Okay. I think we're getting some excitement here. Okay. Are you ready? Okay, everyone. This table, so they're going to be, I'm not going to every table. I'll choose a few tables. You get different turns, 10 questions. What is the most important thing for a kind service? Who's speaking? Say who you are, who you're from, and where you are.
Thanks. Nicole Wamaitha is my name, from Kiambu County. So for us, empathy. Empathy comes first.
So they've got empathy. Here we go. Someone's big smile. Big smile.
My name is Dr. Victoria from the Aga Khan University Hospital. The one word we choose is collaborative.
Collaborating. Empathy, collaborating. I go right to the back. They hide at the back, you see.
We chose personalized because each person's story is different.
That's really good. So we've got collaborating, personalized, empathy. Okay, we can choose one more before we go to the next one, because we've got a lot of these things going on. And Ruth Pearl, oh, you've got a big smile. Where are you from?
Being present.
Yeah, was being present.
Yes.
Oh, that's a very interesting one. Being present. Oh, that is the first thing. I'm just going to comment on the being present. When I asked you not to look at your emails, I was asking for you to be present. That was, I'm very bad at being present. But I was asking you to be present. Now, I'll just reflect on the being present one. Because for healthcare workers, to develop psychological safety, this is very fashionable, psychological safety. Amy Edmondson, who's a big thinker about it, says you have to be present. That brings your whole self to work. Your whole self. Not only part of yourself, but your whole self has to come to work. And this being present, I really love the four that we've got. So we had empathy, collaboration, personalization, and being present. Someone write those down, please, before I forget them. I don't think I can remember more than 5. Anyway, those are very important. Just remember, because we're going to come back to these words afterwards, because I want you to remember. Does anyone want to give me one last one? You know, now remember, it was 5-year-olds, 6-year-olds in class. And the teacher says, does anyone want to give me one? And someone goes, me, teacher. Now, who's that person?
Can I bring in the online people?
Huh? Online people,
yes.
Yeah.
So the chat is very active. The variety of answers is very, so what, I see patience and empathy, then we go to listening, being safe, respectful care, quality and safety, timeliness, responsiveness, excellence, empathy, personalized. So it's the same variety.
Very same variety. Okay, so we're doing really well here. So this was my PDSA number 1. The system's working. We've got the people online as equal partners. Not so equal because we're not in the room, but they can see me. That's right. They can't see you, but they can see me, I think. Can they see them in the room? Oh, that's good. They can see them in the room. They can see who's sleeping, who's on the email. Okay. Those are the values. Okay. These are values you gave me for kind care. To have a vision for kind care, you have to have these values. Okay, now I have to find where I put the clicker. Somewhere. Anyone see the clicker somewhere? Oh, someone's table. Oh, there, the table. Okay. My first visit. Okay, sorry, I've got to walk back there cameraman. Okay. So we now know what a kind service would look like. It would be personalized. It would be one where you're present. It would be one where you show empathy. Empathy is feeling with the person. It's different from compassion, where you feel kind of sorry for the person, so you give them compassion. Empathy is you with the person. With the person. You feel their pain. You hear, you listen, you collaborate. And we've got all those other lists, which I hope we keep in, Ruth Pearl, as a record. Number two for kindness is inclusiveness. What does inclusiveness mean? I think I've got a question for you on that. But inclusiveness, we're often exclusive in healthcare. Any neonatologists here? Anyone work in neonatology? Yeah, but people who work in neonatology, they'll say, oh, what we have a baby, and then they'll start giving letters. Babies who's, jaundice, they won't say jaundice, they'll say LBI, low birth weight, LBW, low birth weight. They all use letters that the parents say, what's this number of letters? My baby's long letters. They're not being inclusive. We talk a different language. So part of inclusiveness is the language we use. The language we use. And in healthcare, we're very good at excluding the patient. We talk in a language they do not understand. One of the things I learned very quickly, there's a video clip I had of Don Berwick, which I took out because of time, in which he said, how do you write the patient letters? So when you write, the person you call a patient, the parents, for me the parents and the child, they come to the clinic, sent by the general practitioner. Then I write a letter to the general practitioner. What's your name? Olatunji. So Olan, I'm going to, Olatunji. Easier than your surname. Olatunji brings his child, then I write to the general practitioner. But who's my real client? Is Olatunji and the child. So my first letter, the general practitioner gets the letter, and then onwards, I write, Dear Olatunji. Dear Olatunji. And now I have to write in a different language than I wrote to the general practitioner. I have to work out what his health literacy is. What will he understand? He won't understand medical terminology. So now I have to change the language I write and speak. And can you see, that's been inclusive. Okay. Very important for storytelling. Because I'm telling his story and his child's story. If I tell it in a different language, what's the most common language? Swahili. Yeah. Swahili is now is the Swahili here the same as Swahili in Tanzania? A little different. It depends. You say, it depends. So, look, I'm from South Africa, and there are 12 official languages. 12 or more. There are 17, I think, actually. So it's no use writing in English and Afrikaans. They think it's the two big languages. They're not. But if the person only speaks Zulu or Xhosa, I need to make sure I write in Zulu or Xhosa, not in English, the universal language. English is the universal language. So you can't really do it. You've got to be practical. So you have to really make it more simple for people to understand. So inclusiveness. I think I've got a question for you now. Okay. So I've given you some ideas. So at your tables, first on Mentimeter, how will you make your service inclusive? And we're going to gain 5 minutes of this. So I said about languages. I've given you one example about language. Another about inclusive is how we design the clinics to be kind and inclusive. So I'm going to speed up on some of these because we've got 10 of them to go. And what we're learning from you. I'm trying to be inclusive here. So my talk is I could have told you all of these things, and I thought, no, I'm going to be inclusive. Are you ready? Okay. Show some results. Let's see what the results are showing. And breakout rooms quickly. Quick breakout room. Only 13 out of 86 have come. Oh, look at this. This is really looking good. Okay, see, we're getting great ideas. Great ideas for Acquire to take back. Okay, great ideas for us to take back and create programs to help people learn how to do this. These are wonderful. Okay, so which table haven't I been to before? Oh, at your tables, 2 minutes discussing what you've seen there. There's so many. Okay, at your tables, quick discussion. I love making a participant listening to their views. Okay? Is it okay with me walking? Okay, thanks. How's it going there?
Yes. Yeah, so I'm giving them 5 minutes. I'm going to give them a little longer. And then it takes about 60 seconds to bring them back, so prompt me, because I'm trying to do it.
Okay. I'll just... How's it doing?
Doing well. Just trying to multitask a bit. Actually, just trying to multitask, but we're doing very well. Yes.
Okay. I'll ask one table. Now, before I ask the table, I'm going to ask Ruth Pearl, what they're saying out there. Ruth Pearl's going to bring them back. Can bring them back from the breakout
Yes,
rooms.
I'm bringing them back. I see Catherine Buyane saying, let us have consideration for the disabled, elderly, and mentally challenged. Florence Kakanu is saying integration of patients and community in all process from design. Use simple language that patients will understand, encourage feedback, and focus on two-way communication, client feedback and engagement, patient education, and informed consent. Auma Mireri and Caroline Omondi agree on that. So everyone is back from the breakout rooms as well.
So we're trying to be inclusive, you see, with them. I'm trying to be inclusive here. Now, which table is going to go next? Have I been to this table? Yeah. I haven't been to this table. Your turn.
Thank you. First of all, we looked at the translation of the word so that we find a Swahili word for it. And the one we came up with is kujumuisha. So how do you bring everybody along? You look at it figuratively and literally. Is it accessible? Is it within reach? Yeah.
That's great. That's really good thinking. Really accessible and in reach. I'm going to do one more table. Where am I find a table? Have I been to this table? No.
Thank you, Peter. Actually, we discussed with my colleague here, and okay, we didn't check in Kiswahili, but the thing is we thought, okay, it said kujumuisha, but okay, myself, I'm a medical lab technologist, so I'm looking at it this way. A patient has been sent to the lab and they've been told to go do the test. Let's say, for example, they're supposed to be HB1C and a lipid profile, and the doctor wants the test or the results there and then. So when the patient comes, I will explain to them that these are two tests that are supposed to fasting, the other one is supposed to, it can be done now. So to the patient, do you want it to be done now? Because the other one is supposed to be fasting. So I can remove the sample today, one, and the other one tomorrow. So if the patient opts to be bleed once, that is for tomorrow, they come and I remove both of them, that is, it will be better for them. But then if it should be done then I'll have to do one. So I've explained to the patient what the test means, so the patient will be going home knowing that one can be done today, and then so it's up to the patient to decide what. So I've explained to the patient in a simple language. I've simplified the language to the patient for him or her to understand. Thank you very much.
That's great. So we have an example, a clinical example of making it easy for people to do the right thing. So now we're going to go back to my presentation, please, Ron. Now we get to the word kindness. The reason you think I'm here for. What is kindness? So, this is from a previous article. It is risky to do kind. What's your name? Huh?
Benjamin.
If I'm kind to Benjamin, what does Benjamin have to do? He has to be kind to me. That's human nature. If I'm kind to Benjamin, he will be kind to me. That's not all the time. I can tell you it works. It works. If you're kind to someone, it's called reciprocity. That's the word it's called. If you talk to your children, they want to be friends with someone, you say, don't worry, we invite them to come and play. Because then their mother will say, you have to invite them back. That's human nature. So, it's really important, but it's a risk. Because maybe they will say no. So being kind is a risk that we have to take. Bennett and Camplin wrote a book called Intelligent Kindness. Because what they're talking about is that kindness is not just something that just happens. It's not a sentimental thing. It's binding, creative. It focuses your imagination. So when we're talking about kindness, we're not talking about a soft thing, it's a hard thing. It's not just being nice. If you remember the model I had, it said kin-centered care. Kin. Kin and kindness. Kin is family and community. Your kin, kind. Can you see? The word comes from the same stem. And there it's the glue that you require to have good cooperation and collaboration. It's the glue, kindness. This is the theory. And the virtuous circle of kindness. A virtuous circle is what happens. You have kinship. You all know what kinship is. We're related to each other. We develop kinship here, this community of learners. That gets kindness. Once you have kindness, you get attentiveness, I think the next one is. Then you're paying attention. Once you get that, then you get alignment to your context at what's needed, and that gets to the most important thing called trust. And once you get trust, you get an alliance, and that then gets to the co-production of safety or quality. This is called a virtual circle. It originally comes from Adam Smith, who's an economist in the 17th or 18th century, who's speaking about what happens in economic circumstances when you do things in economic sphere. But here it is, Camplin and Ballot said for intelligent kindness, this is what happens. You start with the kinship. The kinship we have here as learners in quality and safety. So, is that clear for everyone? Those online, if you've got any questions, please put them in and Ruth Pearl will tell me about this. Now, I'm not going to show this video. I'm just showing you the video because I'll share the video. This is a video from Belgium. Okay, we're not showing it here because we can't see it. So there's Vivian, okay, and she's in intensive care. Okay. And what happened with her, could you just, I'll go back. Yeah, there's, no, I don't want to start the video. You see that mango? Mango is called the queen of the fruits. Everyone loves mangoes. Not everyone, but most people love mangoes, huh? Now, where are the mangoes best? Are they best here in Kenya or in Tanzania? Kenya. And and I go to India, they say ours are better than Kenya. Everyone wants to have the best mango. Okay, the queen of the fruits. Like the lion is the king of the jungle. The mango, if you have a good mango. So this Vivian, so I'm going to share the video because we think it's too long to show now. And we can't get the sound right. The journalist comes into the hospital to do it, and she sees this patient and she interviews her. And she says to the patient at the end, "You're starting to eat?" "Yes." She says, "What would you like?" She says, "A mango." And the next day, she brings her a mango. And she's been in ICU for 3 months. She's only had drips and nothing to eat. But all she was dreaming about was a mango. So Chris van Hecht, who wrote the paper, called this a mango moment. Small acts of kindness. And I will give you the video because it's wonderful to watch. I often cry at the end of the video because it's so exciting. Because she says to Vivian says to the journalist, "I will never forget this." The mango moment. So we call them mango moments now. Now, to create the mango moment, you can do every day small acts of kindness at work. Because if Benjamin is at work, and I say, "Benjamin, simple, how's the day going? How are you feeling? Can you see?" He says, "It's going good." Or he says, "It's been difficult." Then I say, "How can I help?" Small acts of kindness. Can you see? Just by asking, he feels better straight away. Can you see these little small acts of kindness between us? So I'm going to, you can, the video's online, so I can give it to you. Anyone wants the video? It's got subtitles because it's in Dutch and Flemish. So just so, I'm going to go back, sorry. So there's the mango moment. So kindness is the mango moment. And J.M. Barrie, who wrote Alice in Wonderland, had this lovely quote: "Always be a little kinder than necessary." So every day, if you're kind to a fellow worker, they will be kind to you. If you're kind to your team, the team will be kind to you. If you're kind to your patients, they will be kind to you. If everyone starts being kind, now you can say, what is kind? It's little things. Very little things. Very small things. So you're going to have to get the next question is asking about that. The first one is, what are the barriers to kindness in healthcare? So for the people online, for this one, how much time doing, Ripple? Am I slow or fast?
Well, 9 more minutes.
9 more minutes, so everyone, just quickly in Mentimeter, no breakout room here. Because 9 minutes, I mean I've got to go faster. Okay. So we're going to cut out some Mentimeters. Quickly, what do you think the biggest barrier? And I'm just going to go here at the tables here because you're here. Mentimeter's ready for online. So at the tables, I'm going to ask you quickly to do it. Okay, quickly go show the tables what they think. We're not going to spend much time on this one. Okay, here we can see the barriers, the negative things of kindness. The negative things, all the things we have to overcome to be kind. Culture, pride, self-doubt, workload. Why is it that one can be too busy to be kind? Anyone? Ruth Pearl, how the chat's going? Okay.
Hey, I hear fear of being misunderstood, low staff morale, long shifts, bad attitude, workload,
okay,
fatigue, lack of respect.
Who wrote there's not enough time to be kind? Anyone write there's not enough time to be kind? And that's the person who wrote not my job. Who wrote not my job to be kind? Okay, here we go.
Just another one. The doctor-patient relationship sometimes is formal and does not give you room for
So you can see the problem, all the negatives. Our job is to turn them into positives. So go back to my talk, please, because I've got to move on, because I'm asking Ruth Pearl to be kind to me. Give me my full 90 minutes, Ruth Pearl. And how many minutes left? My full 90. 6. I don't believe you. Okay, so I'll go faster now. Number 4 is respect. To be kind, you have to be respectful. So we're not going to do the Mentimeter on this one because I'm respectful for Ruth Pearl. Respect is very important. So we're not going to do this. Okay, because we don't have time. Okay. So you have to respect the person we call a patient and the person we call a healthcare worker. And it all takes courage. You have to be brave to be kind. Okay? Okay, next one, humility. You have to be humble to be kind. So, we started off with kindness. You need to be respectful, you need to have courage, and you need to be humble. Nurses in the room. I'll speak to the nurses now. I'm a doctor. How many times do you work with doctors who have no humility? Hands up. Honestly, hands up. They're laughing. It's not a joke. Huh? And the doctors Doctors, just think about humility. Huh? You know, it's often very well, the doctors go to medical school, they come out, now they've got a degree, they go into the hospital, they have more power than the nurse who's been there with lots of experience because they've got MBBCH or whatever, and they can write prescriptions, they can write death certificates and birth certificates. But can they treat patients? No, the nurse knows how to do that. But they're now the doctor. Am I right? Humility. Number 6. I've only got 4 more to go, so we'll get there in 6 minutes. This is a very nice series of what we have to do as leaders. Shared purpose, sense of belonging, giving power to the people, learning. I'll leave that for you to look at later. Number 7 about kindness is we have to be transparent. And here I'm talking not only transparency about the clinical records I spoke about earlier, but the transparency of our notes. We have to be transparent about our stories. Very difficult. That takes courage and humility. Number 8, because I'm very, okay, I'm going to leave that out because we're running late. I always put this in my talks. We need justice and equity. So every talk I have is justice and equity in the talk, mainly because we do not have justice and equity. So this is just to remind us that wherever we live, I'm currently living in an upper income country where there is lack of justice and equity. Now I'm sitting in a lower middle income country, there may be more justice and equity, maybe. I can't comment on your own countries. But the justice and equity, sorry, I'm going to click back, is we have inequity. We want to move to justice. So justice is where, in the United Kingdom, I use that, we've got a National Health Service. Everyone gets free at the point of access. Is that equity? No. Depends where you live. Because some areas is better than others. Same as here in Nairobi. Okay. People often said private health care is better than, I said no, not necessarily, because in public health care can make it better than private health care. Okay, so really, we really got to move to justice, where we take away the reason. So I always put it in every talk because kindness has got to have something about justice and equity. Okay. Co-production's tomorrow, so I'm not going to say anything on it. We have to co-produce with the person we've been kind. Very important. You'll hear about that tomorrow. And you'll see the slide tomorrow because we have to have Ubuntu. I thought Ubuntu Sub-Saharan, is that right? Because the last time when I was there, the Nigerians didn't know what Ubuntu was. Is that correct? It's more East and South Africa. The Ubuntu feeling, and because we are. And this is what the kindness is all about, Ubuntu. We are both human beings. I am the doctor, you are the patient, but we are people in this together. And we will be kind to each other and co-produce health care. What does that require from the doctor? Courage, humility, transparency, respect. What does it need from the patient? Courage. Not so much humility, because they are already in a position where they've been treated away. We are one. So talk more about this tomorrow. So that's very important in co-production. Then we have the last word is where I want you to go, if I've got a few minutes, in the breakout rooms. What is your one take-home message you have learned from today? So now you can go start putting that into the chat, so Ruth Pearl, Mary, and Lydia can see what the take-home message is from today. And that's the last slide, not the last slide, there's one more slide after this. So I've got 2 minutes or so this, breakout rooms, and then we're going to see what you say now. What you have learned, you can talk at your tables after you put it in. Each table have one thing you can learn, because I'll come to the table, you've got one thing to say. Huh? Can you do this one? You've done it already? Which is the one? Is it transparency? Is it transparency? Or is it transparency? Respect? What is it? What have you learned today? And discuss at your table. Well, I find out how many minutes kind Ruth Pearl is going to give me. So we're fine. We're okay for 5, yeah. Okay, we've got 5 minutes for this exercise. What have we learned? Okay, start discussing once you've put it in. And can you start showing? Ron, if you can start showing, please. Okay. This is great. The word kindness is coming up all the time. Lovely. Yeah. Good. Okay, good learning. And I'm going to come around to table. I'm going to come to the small table here. Why, you're all alone. You're but too alone, you know. You've got rich discussions. Do you want to tell us
what are you taking away?
What you're taking away? We're going to start. What we can take away from table number 1.
For me, what I'm taking away, I think. Oh, my name is Irene Ogongo, Kenya.
From Kenya.
Yes.
Where in Kenya?
Here in Nairobi.
Yeah, in Nairobi.
Yes.
Where in Nairobi?
Like right here.
In this hotel?
In this hotel, in this moment.
Okay.
Yes. So I think for me, the thing that I'm taking away is the power of presence. We talk about it as much, but just being here again and hearing it and seeing that's where everything starts and stops. For me, it means the thing that I'll carry with me.
Okay. So could I just ask one of the choir team to remember each takeaway that's coming from the tables right now? The power of presence. Remember, that's so important. Often the
Writing down.
The person we call a patient says the doctor wasn't there. No, they were thinking about the football. How many times? Okay, I know. How many times? Which is the most popular football team here in Kenya? Another trick question. Which is the most popular football team in Kenya?
It's not a Kenyan team. All Kenyans are very thrilled about the British Premier League and the
Okay, she says that they love the Premier League. Who likes Manchester City? Oh, here we've got someone.
The treatment for malaria is standardized.
No, the most popular Kenyan team is Gor Mahia. Who doesn't know Gor Mahia?
I get it.
Yes.
He comes to you.
And when they play, the patient says they're all talking about the team, not about me. Okay. So presence is important. I come back to this table. Who wants to go here? Another speaker. Another speaker.
No. The standards.
Not now. Like a takeaway? Yeah, so my takeaway from this session is that kindness has to be intentional. So we have to ensure that we are intentionally building kindness, capacitating the health workers to ensure that they are able to to offer kindness. The other issue that I've also been struggling with is, the kindness issue, ensuring that a client is able to tell their story is good, but how do we emphasize this message and empathize with the situation on the ground where, like for example, primary healthcare centers in Malawi have got a lot of patients and they've been attended by few health workers.
Okay, that's great. You're from Malawi.
Yeah.
What's your name?
Bongani.
So Bongali has raised something. How'd you be kind when you're busy? I'm going to say, how can you be unkind when you're busy? Yeah. So you start being kind with your next patient, and then you say, hey, I'll try the next one. And then it starts growing. How you can be kind? I've got a hand up here. Good, first hand up.
Yeah, sure. Thank you. Same question we discussed here. Uganda, Edwin Ouma, I'm from Uganda. And the most typical situation is public settings where patients are too many. It's very difficult to give a patient 10 minutes or 15. So, in order to showcase the kindness, you need to acknowledge it to the patient. For example, hello, Mr. or Mrs. X, I am unable to see you for 15 minutes because of this and this, but I recognize where you're coming from. And I will appreciate, if possible, you could share with me your story or a summary in maybe a minute or two. If you talk like that in a soft voice, the patient understands that you can't give them much time. And then after, ensure before they leave the room, at least you touch them. Touch them wherever it's paining them, they will appreciate.
Okay, that's great. That's fantastic. Now just remember, I forgot to tell you that there is research that shows that when you're being kind, in the brain, you have different serotonin and etc. going on. That starts working. It starts working and you feel better. You feel better when you're being kind than when you are being unkind. You start feeling better. When someone's kind to you, you start feeling better. You both start feeling better, and guess what? Things get better. So Ruth Pearl's been very kind to me. I have, oh, you got one?
Yes.
Yeah, Ruth Pearl, be kind.
The last one. Morini Chabalala from South Africa. So just to say, in terms of us, what we discussed, we forgot there's a lot of discussion going on, but for us, kindness is non-negotiable. Number one, yeah, it's for free.
For free?
Yes, and also it's about choice. So despite whatever that you're going through as a healthcare worker, you have to make that intentional to be kind. Yeah. And even your body language will tell.
That's right.
You just need those simple things that you can do to be kind. Even if you have a minute, you can be kind.
Kindness is free. Remember that. So I'm just going to show you something free. Could you, Ron, go back to my slides, please. I've got lots of things coming up here. Okay. So show me my slides. Okay. You've got to have learning. We're not showing that. Oh, sorry. I want to go back one. So now I'm being kind. So I run this program, the Interprofessional Safety Fellowship. Is Bernadette here today? No, she's not here today. No, she's not here today. So this is the fellowship that we're now opening up on the 11th of July. That is tomorrow for applications. We have had 3 from Uganda, 3 from Kenya, 1 or 2 from Nigeria, 1 from Ivory Coast, I think, and some from the Middle East, of fellows who spend a year with me on this fellowship safety program, putting the genome into these doctors. and nurses. It only take nurses. So applications open. Last year we had over 100 and only take 12 a year. I'm being kind to you because you've seen it before anyone else has seen it. I received it this morning and it's only going live tomorrow. So, today's the 11th or 10th? Today's the 11th, going live today. So if anyone wants to come and join me for a year, hopefully you'll be successful and I can spend time with you over the course of the year on patient safety. So I want to thank you very much for this morning. This presence is all yours. The learning is, I've learned a lot. And I think that's the end of the presentation. Oh, sorry, just go back to my last slide, my very last slide, which is my, before the last slide. Yeah, there's my address. Okay. So that's my, so before I go there, I always have a Mandela quote for me. So, go back one slide, Ron. One slide back. Yeah. So I've always found Mandela has a good quote. So this is my quote of the day from Mandela. See, Mandela was very wise. And this quote is about leadership. So I always think it's a good quote. I give a different quote from Mandela every time as my Mandela quote. Okay. That's what good leaders do. They lead from behind, but they know when to go in front. So hopefully I have taught you how to be kind. Intentional kindness is just free. It's free. Last slide is my contact details. If you go forward, one more. This is where you can get me on LinkedIn, my Gmail account. If you want to ask me questions, I can. I generally answer very quickly because I look at my phone all the time. But thank you very much for being kind to me, Ruth Pearl. And thank you everyone for being kind and good response.
He deserves that round of applause, that ovation. Thank you very much. You have been fantastic. Thank you so much. Oh, is this yours or mine? I think it's yours. Amos, help me with the third microphone. The three of us are coming before you because the one thing about us is that I think I am the least formal and then Lide is the most formal. So when God brought us together, He allowed the three of us to exist so that we help each other. So this is supposed to be an opening ceremony. It is an opening ceremony, but because of time, we are going to put it together. So first, I want to, I guess I assume some of us are curious. How did this Acquire thing start? So I want to tell you, I want my colleagues and I to tell you that story, and then we will conclude by having a couple of minutes of a formal introduction from a Kenyan ministry representative who is going to be Dr. Irungu today. So allow us to do that, and then Dr. Irungu, you can come closer and we'll give you a chance to just formally invite the ones who are not from Kenya to Kenya. And then we will go for lunch. So I think beginning stories are fascinating for me. I think we've all been talking about stories. And so, Mary, where did this thing begin?
Well, it all started because Bruce Pearl and I each had a story about it shouldn't be like that. And we started working together during the 2017 strike, trying to understand people's stories. And our idea was we'd review the newspaper articles that were printed during that time. I had done other academic work around the strike, and we would try and do a better job of telling the story. And while we learned a lot, it didn't end up in a longer term opportunity to work.
Although we did go to the standard offices and found all the stories written around the strike. We did some hard work.
Anyway, and then I met Leah at an ethics meeting at lunch, and we clicked, and so we started talking. And then in 2019, in November, December, I saw this grant proposal request for proposals. And I leave for the US to go kiss my grandbabies, and I sent it to Ruth Pearl and said, I'll never hear anything about it again.
And then Ruth Pearl was just sitting with her family over Christmas. And then I started, you look at a request for proposal and then the idea begins to percolate. So I wrote to Mary, I was like, I think this can be done. We can get the hospitals to do this. We've been talking about this now for a couple of years.
And then I said, and we need Lydia.
And so when 2020 was beginning, you were all watching COVID, we were busy trying to write a proposal. And let me tell you, we've always been ambitious. It was a $10 million proposal. Our first one, but $10 million. And we actually submitted it at the end of February 2020. And it was, when the work it takes to gather all the documents, articulate your idea, bring your partners together, get them to actually formally show interest by providing letters. We're like, this idea is good. Whether they give us the money or not, shouldn't we try it? And that is how 2020 happened. 2021, we started doing a small project here and there. 2022, by the way, we didn't get the $10 million, obviously, you would know. But we did get someone to give us $20,000
We were
here.
unknown.
We were actually,
Totally.
tell them the reason they put on, because we went through the first round, the second round, and then why didn't we get through the third round, Mary?
Well, we were unknown, and they couldn't find anyone to review the proposal on quality improvement because there were no domain-specific experts they could identify.
Domain-specific experts in Africa. So think about that. We're trying to do work around quality improvement and patient safety. They need reviewers that are experts in quality improvement and patient safety. We are trying to create the experts. So can you see that roundabout logic? So they couldn't find the experts, so they just said, sorry, there's nobody to review you. I mean, can you imagine that? We were so sad. But we kept going. So 2021, 2022, so we keep writing proposals. Someone gives us a couple of $1,000s here, a couple of $1,000s here, a couple of $1,000s here. And then last year, let's go to February, we had an opportunity to train a group of healthcare workers online. So tell that story. Mary or Lydia, do you want to go?
So we pulled together people who had successfully completed an online virtual course in quality and patient safety, because we all know that the training options aren't robust yet. And if your team applied and had a team of 6, then we would take you into this virtual training. And we were shocked because we thought we might get 200 people sign up. We had over 1,000 that wanted to be in a week. And we said, wow, there's something here. And then if you completed the course with all your team members, you were eligible to apply for a mentored, coached QI experience.
Go and talk about that. So that's what we did this year. Go ahead, Lydia. Talk about the 3 experiential courses.
We had that theory, IHI. We were calling it Acquire IHI theory, but they gave us a package of about, 13 units? 13 units, and they could be done in 17.5 hours, but mostly people took a little longer. We made it to happen in 6 weeks. Why? Because most of the time you apply for these things. I'm sure Maureen, by the way, Maureen works for IHI from South Africa. Yes, and even Peter is
Mutanda,
Peter Mutanda. Yeah, Peter, you can wave. Yeah, those are IHI people. So most of the time when healthcare workers register for these courses, they don't complete for one reason or another. And also there's a cost implication at times if they don't know how to apply as students. So we had a good success of about 84% of all the people who submitted, who enrolled, were able to transit. And so that translated to how many people? We were about 700?
Oh, yeah, well, yes, about 800.
About 800, yes. Yeah. So a very great success rate. And so we thought, Yeah, actually that deserves a clap. Great, you did well. And in this room, there are people who represent institutions. They brought together people from Malawi, Botswana, Namibia, Cameroon, Nigeria, Ghana, and we had Ethiopia. Yes, we had Ethiopia, Tanzania,
Namibia, we have
Uganda.
so many countries, Cameroon.
Yes, Kenyan counties, I mentioned Mombasa because they had like 3 groups. Actually, more than 3.
Yes.
Yeah, they had like 6 groups or so from Mombasa
Yeah.
County.
Yeah.
And then, of course, the rest of Kenya. So having done the theory, we thought we should get opportunity to move to the next of experiential, for them to use the knowledge to address the challenges, the problems in their real life, and then also to get groups, multidisciplinary groups. Initially, it was theoretical friends within an area, but now it is people who will function. And so this year, we managed to have about 26 hospitals are being taken. Actually, there are about 40 applicants, but we could only manage 26 because we had 14 coaches. So in the room, there are about 14 coaches here. Who are the coaches in the room? They can wave.
We would love for you to stand up.
Yeah, please stand up.
Because
Clap
none
for you.
of this would have been possible
Yeah.
without each of these people.
Yes.
Every week.
Yeah.
And just say, I'm present, I'm available. How can I help you be a part of the project? They have been absolutely phenomenal. If there's an engine behind a choir, you're looking at them right now.
Yeah.
Good job.
So thank you very much for the coaches. So each of them had 2 hospitals doing a QI project, a real project, and they would walk with them. So we took the coaches through some bit of theory, some roundtable. It was a co-produced program whereby there's a curricula, but you say which you'd want us to emphasize on. So we worked with them every other week. They would meet their specific groups. Then the next week we meet coaches only. So we've been able to have almost 8 sessions and 1 in-person session where Professor Lackman was there with them. They have graduated their groups last week.
Yes,
last week
last
we had
week.
26 hospital graduates.
And sorry, Tenza, this is
Yeah.
partly why we were overwhelmed. We had
Yeah.
too much going on.
And they had their leadership, some had their leadership attend
Yeah.
because we need the support. Of course, some did not complete their projects like finish. QI is continuous, but there are some who needed further support. So we have created networks, friends. There are people who are being invited to go to Nigeria. There are those who are being invited to go to other parts of the country, of Africa. And so we think this is becoming real. What was a dream is becoming granular. And the challenges that are not unique to some countries, we are sharing. The ones that are lower level. Our Namibia, Botswana
Yes.
facility was a level 3 or level 4. Almost like a group of dispensaries. It was very heartwarming seeing those group of dispensaries doing QI, and they would show up and they use the systematic method. So we sell the science of improvement at Acquire and all its affiliates. When I'm here, I'm affiliated to Society for Quality Healthcare, and I'm seeing my people there. So we sell the science of improvement, that this can be systematic, and there are proven methods, and it can be adopted to our settings, even in our circumstances as Africa, and regardless of the level. So without us embracing this to a granular level, not just a policy shelved somewhere, it will not make a difference. And that is why Acquire exists.
So I want Mary to say something about the critical mass and the idea of building a critical mass. Then I will have Lydia say something again about what we realized when we participated in the ISQA meeting last year, that it's just those who take the next step. But before that, why am I telling you this story? Because I think we believe, the 3 of us believe that we can't do it on our own. And what we are trying to do is just be the catalyst, the fire, the open door that brings everybody together. We have nothing to hide. We are not trying to compete. There are no resources we are trying to hold on. We believe that it is possible for us to come together, share learning, be the fire that warms each other. It's not that there's any like brilliant idea or anything we are doing that you guys haven't heard of. I mean, is there anything we've said that's unique? No, not at all. We are simply saying that if we all together decided to move one step forward, we actually would begin to move forward. That idea that we have, that the science of quality improvement can be a part of our systems, of our institutions, of our day-to-day work, can become a reality. That's what I think we are trying to say. So what's this critical mass idea?
So, you know, when you build a fire and it starts burning low and there's only one coal left, what happens? It goes out. Quality improvement takes a lot of motivation. And it also is a foreign language to many of our healthcare institutions. And so for us, critical mass is essential because you can't walk alone. This is a journey that requires a team. And when you go together and you have that down week because nothing's happening, you can encourage each other. When your administrators don't quite get it yet, okay, you have someone, a group of people that are learning. And it's so much easier to learn a new language in a group, not just by yourself with headphones. And so that's why critical mass matters.
And that's what we're working towards. If you ask us what our idea is, get more and more people speaking the quality language, sharing with each other the stories of the quality work they are doing, sharing with their peers the challenges. That's all we are getting towards. And I think that's what this meeting is really about. So let Lydia go.
Great. So when you look at the landscape of what enables this to happen, there is the front line, which a great number of us represent the front line. But there is the place where policies are made. There is where we build capacity in pre-service. Before you are made a doctor, before you're made a nurse, did you hear of quality improvement, patient safety? There is the part that now you come to encounter because you're the front line. So in Acquire, our approach is that we're able to build this community that can support across at the front line, building their capacity, then come to the level of enabling the faculty. The Faculty for Quality and Safety for Africa could just be in this room, because at times we do programs, but we don't have teachers. But you are the nurse who will be able to teach quality and safety in that institution. You are the academician who will be able to articulate this. And it matters that it's articulated with authenticity. So we equip the front line so that from there will spring capacity across, because you cannot teach if you don't know what happened. So at the front line, we hope that you will be the movers to influence the others. The policy level has been spoken to many and many times because we do well, but it can remain in the shelf. So we hope to influence across levels, but also to do what Mary is doing, to what Mary mentioned, to have what is called a community of practice. People who are bound together by this genuine desire to do better, to share their valid experiences, to share tacit knowledge for Africa that maybe has not been documented, because we don't do that very well. So our hope is to create that enabling environment. And then also, in the last meeting we had various professional societies. So at one point we would want to hear the Society for Quality Healthcare from
the Africa Community of Practice.
From society, from, is it South Africa? Mm-hmm. From Nigeria, yeah. Ajay is there, the pharmacist. So would want to see how we can synergize and bring the other groups that could move this in a different way. Because remember, Acquire, we do not sit on the Senate, we do not sit in the academic institutions. We may not sit in all Ministry of Health issues. It just happens that currently we have a good representation in various places. So our hope is that we get tangible path, or rather a direction that we can dare do something about. What Ruth Pal was saying, we go to conferences, we come back home and go back to where we were. What does it mean doing that small step with regard to quality improvement? It will require all of us. Yeah, not just one person, not just public sector, but private sector, not just the mission hospital and faith-based, but all the other players in that field.
So now I ask you, who's going to be the coal that gets your fire burning? It's gonna be in this room. So as you go for lunch, as you sit on tables, as you interact, don't stay with the fire that you already know. Look for another one. Look for them. Find an opportunity to learn from the other. Again, this meeting would not have been possible without the planning committee. So I want to ask them to stand. Tomorrow at 8:30, we'll have an opportunity to hear from them verbally. But just now, you know you're a part of the planning committee. Tenza, Ajay, Dami, this. Oh no, this is not
Bernard.
sorry. Yes,
Angie.
yes, please go ahead, stand up. Thank you so
Carol.
much, Faith.
Yes.
Thank you, Mutanda. Thank you, Bernard. Thank you so much, Carol. You know, these people work hard. They suggest ideas, they find speakers, and we are so grateful for each and every one of you. You will tell us your why tomorrow at 8:30 because Ruth Pal has to try to keep time. So now over to Dr. Irungu.
Great. So allow me to just invite Dr. Irungu. MOH is our host. Dr. Irungu is the lead for patient safety at MOH. Recently, they moved to the National Public Health Institute. We are still getting used to that, but on behalf of the powers that be, kind
Dr. Oktoi, that's a pure ambush because I know someone else was meant to do this. I think in the government, they say when you are called upon, you have to arise. You have no choice. Yeah, so I think on behalf of the Minister of Health, as well as the Kenya National Public Health Institute, I think mine is to invite all of us to this great meeting that is revolving around issues about quality of care. And for all those in the who have been in the medical practice, and especially in the African setup, you know, equality is an issue. And I think that's what sometimes determines whether or not, you know, when your kid gets sick, you'll take them to that public facility where you work, or you have options. And I think all this revolves around issues around quality. So as Dr. Oktoi has rightly put it, okay, over a long time, okay, the Ministry of Health has had two main state departments. That's the State Department for Medical Services and the State Department for Public Health. And for quite some time, we've been in the State Department for Public Health and Professional Standards, within which was a division of quality assurance, where issues of patient safety were being run. But in the early from late last year, but although it has been a discussion that has been there for a long time, National Public Health Institute was officially gazetted in 2022, but it was launched this year. And then some units, like my unit, or our unit, was called Patient Safety Unit. And we dealt mainly with issues around patient safety, IPC and AMR as a program. But now that unit transitioned to the Kenya National Public Health Institute and now got a mandate of a division of quality improvement, IPC and AMR. But of course, there are a few issues, especially related to patient safety specifically per se, because patient safety, as you know, it revolves more around the patient. And now in the institute, our mandate is more on public health response, where issues around IPC, AMR are stronger. But we've been told, you guys started this journey, move with it until otherwise stated. So I'm happy to keep on representing issues of quality improvement and IPC and AMR. And I think one key thing I would wish to state so that I don't take so much of the time for lunch is the role of leadership, health leadership, in supporting any initiative that is of public health concern. And I pride in the fact that over time, our ministry has really supported issues around quality improvement and patient safety. Okto is telling, we've moved this group with DOC, supported by the ministry, to try and institutionalize patient safety and quality of care within our ministry. But for people here, it is never an easy journey. You know, especially for ministries, something that does not directly has a financial outcome is funding it becomes a problem. But what I say, we've been mandated, no work given, fully supported and committed to do that. To me, that's enough support for quality improvement and patient safety. And of course, with other support, we are now trying to institutionalize patient safety in the country. A lot is going on. I know a lot is happening, but in a very siloed manner. Everyone is doing something. And that's why recently, with the very kind support of the team from Dr. Oktoi and so many other faces I'm seeing here, we sat and said, no, this journey, we need to walk it together. As someone has just said, we had so many coals that were burning at different corners of this country. But we realized by bringing them together, now we'll be able to light a fire that can warm the whole room. And that's the journey. That's why I'm challenging any other person, especially for those in Kenya and who are here. We were a very small team that started thinking, how can we institutionalize patient safety? But we want to onboard more people so that we can also say we are doing in terms of patient safety. I think for everyone else, especially from the people in the African region, the moment we build a house, we build your houses and create a village. Yeah? And then beyond that, we'll join other regions and create a city. And that way, I believe that the work of quality and patient safety will have a mass that will move it for generations to come. So for mine is to thank all of you, welcome you, and on behalf of the Director of Health Standards, Quality Assurance and Regulations, I declare the meeting officially opened, and I hope he'll be able to join us before we finish. Otherwise, karibuni sana Kenya.
Thank you very much, Dr. Irungu. Another round of applause. Thank you. So I think without much further ado, you're welcome for lunch. I think you all have some coupons, so we can kindly go for lunch so that we come back on time. When does our next session begin? It begins at 2 and 10 past 2, yeah? So do we have enough time for lunch? Yes, we do. So kindly network. Yeah, ask those country representatives the questions that your hands were up, but you did not ask them. Great. I think that is good. Great.
that keep time. What a high level of respect you have shown us. Thank you very much. So I want us to all take our phones and start to answer the Mentimeter questions. There are going to be 3 of them. Thank you for helping us with that. Where is the link? Oh, you can't. Okay, so leave the link on so that people can fill it out. So the 3 questions are pretty straightforward, and we thank Angie and Mary for putting in the time to give us questions. So session 3. Which statement best describes the current incident reporting system in your healthcare institution? How would you describe the current around error reporting in health setting? And what is the biggest barrier preventing healthcare workers from reporting in your setting? Those are just the 3 questions that we want to hear from you. So please, you either use the code or use the QR photo. Give us your thoughts. So I'll give it like a minute, and then we'll go ahead. As you're doing that, I just want to mention that everyone who submitted a scientific poster and is amongst the 14 people that are in the room, at the end of the day at 5 p.m. we will have a small prep conversation behind the podium over there. So at the end of the day at 5 p.m., give us just 5 minutes behind the podium over there. Okay, I think that's enough time, Ron. Let's see what the answers are. Aha. But how come there are 4 options? So which statement best describes the core? Oh, sorry, which statement best describes the current incident reporting system in your healthcare setting? Okay. Are the online people doing this as well? Are we giving them the same access, John? Okay. So I get the best. Oh, wow. We have a system but it's inconsistently used or lacks feedback mechanisms. That's really... Okay, not surprising. And then we have a lot of informal reporting, verbal reporting, informal documentation. Very few have a well-functioning system with regular reporting and feedback. And there are those of us who are admitting there is no system at all. Okay, let's go to question 2. So the current culture around error reporting in your setting. Oh, no answers. Yet. Oh, okay. So online, I'm waiting to see you as well. Okay. I think the blame culture is winning. It's an unfortunate win, huh? But we are living in the truth. So we can say that the fear of punishment and consequences is limiting our error reporting, the blame culture. The silence culture and the mixed culture are actually equal at the moment. Okay, Ron, let's see what the 3rd question is. So our biggest barrier is a lack of systems. Okay, but that's only one person. Let's hear from the rest of you. Oh, okay. So the fear of punishment, disciplinary action, or professional consequences is what is holding us back. The previous question, remember we said blame culture. Here, we come to fear of punishment, but that's actually quite interesting. Okay. I thought the shame or blame culture would be there, but it's a fear of punishment. Okay, so we're going to spend a little time, the next 80 or so minutes, having a conversation about incident reporting. It will be guided by Lydia Okutoi, the great doctor and head of quality from Kenyatta National Healthcare, but I know her as the co-founder of Acquire. We have a couple of presentations and a couple of questions, but this session is actually to hear from you. So it will be different than what we've done in the past, in the previous sessions, because we really want the thoughts to come from you in the room and online. So we'll try and minimize the presentations and increase the time when the microphone is on the floor. Right? Over to you.
Thank you very much. Apologies that you'll hear my voice again. I'm representing Dr. Rhoda Kalondu. I don't know whether you can see her on the poster. Allow me to say a few kind words about Rhoda. Rhoda is my daughter. Rhoda reports to me at Kenyatta National Hospital. She's the head of healthcare quality, head of patient safety. So she's the head of patient safety, patient affairs, standard and process improvement. And the people who report to Rhoda in this room, they can't wait. Yes, those are the teams that reports to Rhoda at Kenyatta National Hospital. So today she's receiving the bulletin on behalf of Ms. Stand here. So it's an honor that I acknowledge that we have our emergency to add to what she is a Peace Fellow, and also got the opportunity to have a Peace Fellowship that leads to Patient and Human Factor Master's program, ADC, which is one of the few in our country. So we celebrate that. The hard work of supporting patient safety at a large facility, doing incident reviews, and so research. Those are the kind of our emergencies. And I tell you that we need critical for 1 or 2 days. Yeah, so that is Dr. Rhoda Kalondu, was moderator for this session. So having introduced her, we will go on and have some opening presentation by myself. I'll be setting stage for Ronel. They are very short presentations. Then we come to the gist of the matter, where Dr. Ruth Pearl Ng'ang'a will guide us through the panel. We will have Oyebed representing Ethiopia, Selina Ghana, and Dr. Olatunji. Dr. Olatunji, I prefer that name. So we'll start with my slides, and then Ron confirmed that Ronel will be ready for the next slide. Yeah, so we'll start with my slides just to give a general overview. Great, as my slides are being put up, the Society for Quality Healthcare in this room, kindly wave. Great to see you all here. And of course, my other people from Kenyatta National Hospital have waved, and you are all Acquire. And I have a member of my family can also wave. That is the member of my family, is my Oga. Welcome, Prof. We are good? Great. Fine. Incident reporting. I don't know what we think about when you consider incident reporting, but by itself it's not a panacea of the only thing to do. That is why many other actions to do. But without knowing what is happening, you are unable to improve. Without having a way of marking your bouncing back when things go wrong, you are unable to improve. So it is an important topic. And it is one of the indicators that
the system can look at itself, that it can reflect. Yeah, it's called learning health systems, that they can look at what happened and reflect and decide to do better. Great, so we will proceed. Next slide. Great, so just as an introduction that there is a significant burden of harm, of unsafe care worldwide, and having an incident reporting system proposes that an organization can learn and so reduce the harm. And a medical error reporting system, we are referring to a structured approach whereby we collect and we analyze both harmful events and near misses during patient care. And so this, to make it be more adapted, it is made anonymous, it is made simple and confidential. Next slide. Literature indicates, the previous one, that this results into more accountability, transparency, and while other countries, including the North Asian countries, have had more adaptation, maybe because they also have more electronic medical error, electronic health systems. In Africa, there is much to be done. But with regard to incident reporting, one of our participants from, is it not panelists, from which country? Tanzania, mentioned maternal review, maternal and perinatal surveillance and review. So we are doing that for maternal audits. We are having pharmacovigilance and reporting adverse drug events. We are also reporting adverse vaccine-related events. We're also reporting adverse events related to blood and blood products. However, the general medical error reporting is not quite happening routinely. Next slide. Great, so there is the Global Patient Safety Action Plan. Objective 6 is to do with learning and incident reporting and use of data for improvement. And the report done in 2024 showed that we are at 32% of the countries having adapted some form of incident reporting for errors. Next slide. However, the rest of the indicators, red is basic, below 4. So there is a Likert scale, or rather scale that goes up to 7. Above 7 is having advanced system. So this is where Africa is. Africa has everything in the red. So with regard with patient safety and learning, we are 3.3. Patient safety in we are at 3.0. Patient safety surveillance system, 0. Patient safety research programs, 1.5. Digital technology for patient safety, 3.1. So you can see with the incident reporting, we are at 3.3, which is, we are still at basic. So we are at red. But in your Mentimeter, you really showed that we are doing well. So it means maybe in our hospitals, we are trying to improve, or maybe we've not also defined. So as a continent, including Kenya, this is a topic, Objective 6. We need to relook it, especially 6, the first part of patient safety incident reporting, which is of our interest today. Next slide. So South Africa implemented the patient safety incident reporting and learning systems. We appreciate the South Africans who are here. And this was a statement in that report of 2024, that there were discrepancies in the hospitals, in the directorate on how to report. And one of the challenges of reporting is lack of definition, that it is not standardized. And so they came up with that guideline. So kudos to South Africa, and that's why we'll be having Ronel share with us where we are. You can see the low and middle income country, availability of designated people to address patient safety and incident reporting is below 15% in the low and middle income countries. And so it is an important topic for us, and we will hear a story from South Africa and then from the other panelists. Next slide, which could be the final. In Kenya, we have the national policy on patient safety, health worker safety, and quality of care that was launched in 2022. And also we have the quality of care bill, which is still a draft, that puts this aspect of incident reporting in a document that can give guidance. And so there's been some form of movement, but we don't know how much. How do we move from policy to practice? What are the enablers and barriers to this? And what can we learn from each other? There are policy documents that are being made, that are already made, but where are we? Next slide. And so a scoping review, we did a scoping review, which was meant to be published, but it never left the shelf. But there are many other scoping reviews that have been done on the topic, that in Africa there is low medical error reporting, whereas there is awareness, but there is a great awareness on the need to report. But few countries have a policy direction on patient safety. The quality of care is general, but on aspect of patient safety, it is a small subtopic, and at times very little on the need to have incident reporting. Then electronic health records are still in the early adoption stages in most of our African countries. Acquire had a poll in the recent past as we get to the conference, and we found when we asked the questions about reporting at institution, whether the health workers can report easily, just the same like the Mentimeter we gave here. And it gave more positive results, that there is some action. So this is the time we'd want to hear from the people in the room, from the people who will come to the stage with regard to this. Thank you. I think that was my last slide. Last slide. I think we are done. That is the essential topic that we are asking ourselves about. Thank you very much. We will welcome Ronel to take on and share the South African story. Maybe you can clap for Dr. Kutoi. Thank you very much. So our next speaker will be Ronel. I think as Ronel comes on, we can call the panelists on the stage, or they will not be able to see. No, let them. Maybe it is easier from there. Ronel, you're welcome. Thank you very much for being with us. You'll introduce yourself because I know it will take a much shorter time, but Ronel works in the Department of Health in South African. Is it a republic or is it just South Africa? In the Republic of South Africa. Great. Tell us when you are ready. You will kindly proceed.
Can you hear me?
Hear you, Ronel, and we are glad to have you.
And can you see my screen?
Yes, we can. If you can make it full screen.
Yes, I'll put it, yes, there it is. Good afternoon, everyone, and thank you for the opportunity to also tell our story today on our journey for developing a patient safety reporting and learning system in South Africa. So I'm working as a Deputy Director at the National Department of Health in the Quality Assurance and Improvement Unit. And one of my responsibilities is to set up a national system for patient safety reporting and learning. So that is what my presentation will be today, is to just share with you how did we go about, what progress have we made up to now, as well as our challenges that we experience when setting up the system, as well as lessons that we've learned. So why did we develop a patient safety reporting and learning system? So at the time, there was no national uniform system to report patient safety incidents. At the time,
Ronel,
there was also...
Can you hear me?
I can.
Could you make it full screen, if possible?
From my side, it is full screen, Lydia.
Okay, from here it is still having the other.
Okay, let me just go out. You see there, I'm now not in full screen. Let me try and do it now. Better or still not?
It's okay. I think we will just proceed. It's okay.
Yeah, let me just see.
Otherwise, maybe you would stop sharing, then reshare.
Yeah, let me try that.
Yeah. Or you put your screen to be full. Great. Oh, it's gone back to.
Is it better now?
It's still the same.
Okay.
If you put it on full screen and then you join, it will remain on full screen, or you won't see the buttons.
Yeah, you see, I can't see the buttons once
Okay,
I've
great. I think it is
put it
okay.
on full screen.
It is okay. Let us proceed.
Let me just try something else. No. Okay. I am not sure why it is doing this. Let me just see.
I think it is okay. We will.
Yeah. No,
We've tried.
yeah, I don't know my laptop setting, but from my side, it's in full slideshow view. So I'm not sure why I can see when I exit, it's actually not in full slide view show.
You can just proceed.
Yes, sorry about that. Coming back to why we decided to develop the reporting system, at the time the WHO also made a call for countries to develop a system, and South Africa also had hosted a Medico Legal Summit in 2015. And that summit was hosted due to the rising cost of medical litigations in the country. And one of the outcomes at that summit was also to set up a national reporting system for patient safety incidents. The first step that we did is that we did a rapid assessment in 2015 of the current situation in the country. There were 9 provinces that in our country, which we did the assessment in. And the outcome of that assessment was that basically every province did something. So everyone was reporting, but everyone had their own manner in how they managed PSIs, what they reported, and what they did. There were very few similarities among the 9 provinces. We then took the results of those assessments and used it to draft the first national guideline for patient safety, incident reporting and learning. We were also very fortunate to be invited by the World Health Organization at that time to attend a workshop in Sri Lanka that basically was about setting up a reporting system. So we learned a lot there as well when we drafted our first guideline. After drafting the guideline, we shared the guideline with the 9 provinces, because if you want buy-in from your stakeholders, it's very important that you get input from them from the start. We also shared the guideline with the World Health Organization for inputs. And then after we have collated all the inputs that we received. We also hosted a national workshop to finalize the guideline. After that workshop, we took the guideline to the National Health Council, which is our governing organization for or committee to approve all national guidelines and policies. They then approved the guideline, and the guideline came into effect on 1 April 2018. When we started to draft the guideline, we also commenced with developing a web-based information system that were launched at the same time that the guideline was launched. This is just to show you how our first guideline looked that came into effect on 1 April 2018. There is also a screenshot of our information system. We opted to use an existing information system that we refer to as the Ideal Health Facility Information System. At the time, that information system was used to collect information on quality assessments in our health facilities. Yes? Yes. Is it not moving on?
Not a problem, Ronel. We'll use the slides we have.
So we project?
Lydia? Are you
Yes.
projecting?
Can you hear me?
Yes,
Yes,
thank you, Ron. Good job, Ron. So, Ronel, are you being able to see the slides?
I only see my own slides. Yes, there I can see it now.
Okay, so I think you can continue and we'll just tell us to move slides. Thanks, Ron.
Okay, thank you. Okay, so what you see there on the screen is a screenshot of our information system. And as I mentioned, it was most cost effective to use an existing information system that we use for quality assessment. So we basically developed an additional module for staff to report patient safety incidents on. And you can see the screenshot at the bottom of that slide. It's just basically how it looks, the capture screen where staff capture. So just to tell you a bit more about what we report on, we report on both harmful incidents, no harm incidents, as well as near misses. We use the World Health Organization's minimum information model. They also have an intermediate information model, but we use the minimum information model to collect information on patient safety incidents. So the information that is required by the minimum information model to be collected is the patient's age and sex, the time that the PSI occurred, as well as the location. We have different classifications, which is the contributing factors, the incident type, the incident outcome, both for the patient and organization, the actions taken, as well as the final outcome of the investigation. And then there's the free text to summarize the PSI description, what the PSI was about, as well as the findings. We also use the severity assessment code risk rating to risk rate every PSI, where your SAC1, which is the abbreviation for severity assessment code, your SAC1 incidents are those incidents where serious harm is caused or death. And then SAC4 is where no harm is caused, and 2 is for moderate harm, and 3 is for minor harm. We also have free indicators, which is included in our national indicator data set. Those free indicators are the PSI closure rate, the closure rate within 60 working days, and then we also have the third indicator where we require staff to report all SAC incidents, so those serious incidents, to the next level within 24 hours. I can also just mention that we also establish patient safety committees at all levels. So there's patient safety committees at facility level as well as at provincial and district level. Those committees have, in the guideline, we set out the terms and reference for those committees, and they are basically responsible for monitoring the implementation of the guideline. Next slide, please. Now, just since we've published the guideline in 2018, we have made some progress, so that I also just want to share with you. So we commenced with sharing quarterly reports with provincial quality assurance managers. So in those quarterly reports, we indicate the compliance rate. So just to explain what we mean by compliance rate, we developed a report on the system that basically requires every facility to access the system on a monthly basis. Even if they didn't have a PSI, we require them to report a null report on the system. So we basically count the number of facilities who has accessed the system. So that's the compliance report that we report on quarterly. We also report on the indicators in the quarterly reports. And then we also do an annual report every year that is shared through the office of our Director General to the 9 provincial heads of health. That annual report contains detailed information on the compliance rates, all the different classifications that I've mentioned previously, as well as the indicator data. The report also sets out data per level of care. So you will have for your different types of hospitals, district, psychiatric hospitals, TB, provincial hospitals, and then your PHC, the data is set out separately. We then also had to revise the guideline in 2022. It was prompted by the annual report in 2021-22, which indicated to us that our classification system needed some adjustment because it didn't make provision for all the type of PSIs. So that is to enable us to get better trends when we analyze the aggregated reports. We also, at the time that Lydia has also spoken about the Global Patient Safety Action Plan, and that plan also set out specific indicators which wasn't included in the first set of classifications. So we also added that when we revised the guideline in 2022. We also added some additional information on just culture because we also know that staff still fear to report patient safety incidents, so we added in some guidance on that as well. Next slide. We also added an automated notification on the information system. So how that works is that once this serious adverse event, the SAC1 incidents are captured by staff, an email or an SMS notification is sent to the next level to notify them of the incident. We have given this functionality to the provincial offices so they can set up their own notifications so that staff at each facility can receive the notification once the incident is captured. When we rolled out the revised guideline in 2022, we also developed online training modules, which is available on our training platform, the Knowledge Hub. Though the training course is about 3 hours, and we've also accredited it with, it is accredited with free CPD points. Next slide, please. The challenges that we experienced when we initiated this entire process is that we did not initially have all 9 provinces on board. it really took us a few years to get everyone on board. Initially, we would have 6 provinces and then 7, and we are very glad to report at this stage that we have all 9 provinces on board and everyone is reporting. We still experience challenges with poor data quality that is captured on the information system, in the sense that the staff don't describe what the PSI is about. So when we review those incidents, we also check whether the classifications were done correctly. And if the description wasn't done correctly, it's very difficult to determine what the classifications should be. We also experience that some staff still don't understand exactly what a PSI is, so we will have cases which they report which doesn't fall within the definition of a patient safety incident. This was also spoken quite a lot about during the course of today, is underreporting, because staff still fear disciplinary action. So we have the same problem with our reporting system, where we know that global data tells us that 1 in 10 patients is harmed while receiving hospital care, and it's even higher in ambulatory care, where it's 4 in 10 patients. And our reporting is far less than that global data tells us. We also see that because this, we monitor compliance, and I can also maybe just mention that we have also norms and standards regulations for our health facilities. And the reporting of PSIs is one of the standards that they need to report on. So we see that facilities just see it as a compliance exercise and don't actually use the data to drive improvement. We've really put a lot of effort into developing the training courses for the guideline, but it is not utilized optimally. We would really like a lot more staff to access those training modules. We do see that every year it does increase a bit, but we will continue to remind staff on that. The next slide, please. Then the lessons learned. Partnership and resources are so important, especially if you don't know how to start, which was really where we were at when we initially started. And you will see on top, I've just put some images of some of the guidelines that WHO has available. We were also part of a training course that was developed by the WHO for setting up learning systems, which we did for the Maldives. So it's so important. All those guidelines are available, especially the one on developing reporting systems. I think it was published by the WHO in 2020. And then also partnerships. You heard I spoke a lot about the WHO who assisted us when we initially developed the guideline. And then when we revised the guideline, we had the British High Commission who assisted us with revising the classifications as well. Then the second lesson is that you really need to pilot your guideline before you roll it out nationally to make sure that you identify gaps and correct that before you commence with implementation of the guideline. We've also seen some countries who developed their web-based information systems before they've published a national guideline, which is a bit problematic in the sense that you don't have a standard that you are working from for staff to report on the information system. Then leadership commitment, it is so important. And that is not only at the national or provincial level, but it's at all levels within the health facility. We've seen that at facilities where there's leadership that promotes a just culture, we see much higher reporting of patient safety incidents. So that is really important that you have leadership buy-in when you develop these systems and roll it out as well. And also, which I think also comes in with leadership, is that you use, it's been documented in literature that staff are more likely to report patient safety incidents if they see that something changes by the reports that they are doing, because that's an encouragement for them. So that also comes in with leadership, that we actually don't just report, but we use that data to drive improvement and to show to staff that what they report makes a difference and that changes actually happens. Continuous monitoring and feedback to all your stakeholders is very important, because if you don't do that, you will not get all your stakeholders on board eventually. And then just lastly, challenges, change takes time. So be patient and don't give up. You will eventually get there. The next slide. Right, thank you. So this is just, and you will see in the guideline from the WHO about patient safety reporting and learning systems, there's a whole section on the advantages of having a web-based information system. So it allows you to actually prevent or reduce risk with similar incidents occurring in that specific case setting, but also elsewhere, because if you monitor your trends, you can also inform the rest of the country of trends that you see in other at other levels. As I mentioned, you have the option where you can send out automated alerts and notifications to allow for immediate intervention. It allows for standardized reporting and trends analysis. It allows you to, through your analysis of data, to identify gaps that can be used for to train and educate staff. And then your aggregated data allows you to produce larger volumes of data that are capable to identify patterns and root causes in country settings, as well as different levels within that country. Thank you for listening, and that is all that I have for now. Thank you, Lydia.
Thank you very much, Ronelle. A round of applause. I think the right people are in the room. She talked a lot about what happens at policy level and how to move that. I think we are truly honored to have you join us virtually. So allow me now to have the next, the panelists to come over. Ronelle, kindly don't leave. We will have a panel. So we have Dr. Esaias, Professor Esaias from Ethiopia. A round of applause for Professor Esaias. He is online. Ruth Pali will confirm that he's had. We welcomed him. We will have Dr. Selina from Ghana. And I think Caleb also will come. Kindly come over. Caleb can come also to represent Ethiopia. And we will have Dr. Olatuji. I've just discovered there are many surgeons in the room from Nigeria. You're welcome. A round of applause as they come. And then we will have Lavenda, Madam Lavenda Adhiambo from Nairobi, Kenya. We share a profession with Lavenda. We are both midwives. She works in the labor room, labor ward. Great. A round of applause. Okay, so I think for those who've not been up here, they'll also introduce themselves a little bit in detail, even as we start. You had some prep with Dr. Kalondu. it's unfortunate that she's not able to be with us, but I think this is an important topic that you're well prepared to share. Where are we as an institution? We have institutions represented, we have governments represented. Rubber meets the road at the institution, so we'd really love to know also how government level or national level is supporting the institutions. Ronelle has shed light in a broad way, so we'd want to have some country-specific responses. Great. I think we have a third mic somewhere? Not yet, yeah. Great. So we can start. Just share your name and then what you're doing with regard to incident reporting. Any challenges? What you'd advise those who are beginning? Ronelle said, don't start web-based reporting before you have a guideline. It didn't work. I think that is a very great advice. So what is this that we shouldn't try at home, whether at institution or at national level? Great, we will start with Madam Lavender. You're welcome. I think this time I have a chair I can sit.
Good afternoon, everyone. My name is Lavender. I'm a Kenya registered community health nurse working at Metropolitan Hospital in the maternity unit. I'm also a quality improvement champion and also dealing with the infection prevention issues in my institution. One thing we realized as a quality committee is that in terms of incidents reporting, people are not reporting because many incidents were happening, but people are not coming forward to report. So I think a year ago or 2 years ago, we decided, because we were using the manual incidents reporting, and we realized people are not coming forward, and also people were having fear of coming out, maybe due to intimidation and also fear of losing jobs. So
when you say manual, what do you mean?
So manual is just dealing with papers, just writing. Yeah,
okay.
we're just writing, and once the incident report is written, you just put it in the file, and we share one copy with the in-charge and also with the quality team. And we realized people are very fearful of reporting a lot of incidents that were happening. So we decided maybe we could initiate the process of having digital way of reporting incidences through not writing your actual names. We just keep it anonymous. So as per last year, before we were reaccredited for COSASA, we had tried the digital way, which proved at least to be quite effective. We had some people coming out and reporting incidences because there's an option of not writing your name. Once you submit it, the notification will be sent to the quality personnel that is in charge. Yeah, so as per now, we're still in the process of empowering our staffs to go the digital way. We are hoping maybe by the end of this year or maybe hopefully end of next year, we'll have shifted from manual to the digital platform where you can even write, you can even do it in the comfort of your home, your phone. Yeah, so we're doing a lot of internal CMEs. We're doing learning forums for our staffs to, embrace the digital way of reporting incidences without having fear of intimidation and victimization. Thank you.
Thank you very much. Lavender works at the Metropolitan Hospital, and they have an online system, but you're hearing they are not all there. So it means there is no one silver bullet that you press a button today, and tomorrow everybody has onboarded. Thank you for sharing that. I think we will go to Olatuji from Nigeria. the surgeon have peculiar behaviors, but now you're at national level. So what is the situation in Nigeria? And we congratulate you. You have a lot of publications on perceptions, attitudes, knowledge from your country. A lot of master's students are doing a lot of those, but with regard to the specific systems that exist in the institutions, I think we are not getting a lot of writing on that. So, and we know that Nigeria is a country of many contrasts, so it's possible that these are happening somewhere. Kindly shed light on incident reporting in Nigeria at national level, and maybe for the institutions in case you have anything in that regard.
Okay. Thank you very much. Like you said, we don't have so much report from the country. However, we have multiple channels of incident reporting in Nigeria, both at the national level and both at the institutional level. At the national level, the first point of call for incident reporting is Federal Ministry of Health. We receive a lot of incidents from our hospitals. In fact, last month we received one where the family of a patient was complaining that they lost their relative because he was not properly attended to by the doctors in the hospital. So we receive a lot of incident reporting from our hospitals through the FMOH. Also, we have the Medical and Dental Council of Nigeria. Medical and Dental Council of Nigeria is regulates practice, medical practice in the country. So the agency also received a lot of incident reporting from maybe wrong side surgery, maybe unprofessional conduct. So they are also an agency that received a lot of incident reporting in Nigeria. Also, we have the National Agency for Food and Drug Administration. They receive a lot of incident reporting. In their own case, they receive with respect to drugs because their mandate is to regulate drug manufacturing, distribution, production, and the likes. So when there is substandard drugs, they receive incident reporting and they investigate, and they have the right to withdraw the drugs from the system. Also, we have the NHIC. NHIC is expected to set standard for our hospitals. However, one of their mandates is also to regulate organ transplantation in the country because we have organ trafficking in the country. So these institutions have the mandate to regulate. So they also receive incident reporting with respect to organ transplantation. We also have the blood transfusion service in the country. They are expected to conduct hemovigilance. Although the hemovigilance is not so strong, but once there is blood transfusion reaction, the hospital is expected to report to the nearest blood bank, then to the national. We also have pharmacovigilance, which is well established in the country. Pharmacovigilance are expected to receive incident from adverse drug reaction, both from the orthodox and also the traditional medical doctors. So, and in their own case, it is either voluntary for the medical practitioner to report, and also mandatory for the company in which their drugs have an adverse reaction. At the institutional level, we have incident reporting system, though still very weak because of blame culture, as we all know, which is common.
I have a question about the national level. You see this blood, pharmacovigilance, hemovigilance, those are all like silo. Do we have any at national level that is for reports for incidents that are not necessarily in those silo categories? For example, I do a second surgery, a repeat surgery because of maybe something, maybe an intentional retention of a foreign body, a gauze. Is there a national monitoring system that can pick that?
Yeah, like I said, at the national level, we have different agencies that represent the national level. So most of these reports, drugs, wrong side surgery, medication safety, they have different agencies that they go to. However, the country is working on a unifying system of this incident reporting. So at the national level, we have different agencies working in silos. But presently, we're working on a unifying reporting system. So,
thank you. At institutional level, I think I like it when a surgeon gives institutional example. Welcome. Let's give you a minute for institutional level in Nigeria. What can you say?
So at the institutional level, we have, of course, the incident reporting system and some name it quality improvement team. Once there's any problem or any incident or any medical error, the medical practitioner is expected to report, but most times they don't self-report because of fear of punishment, no legal protection. So the burden is on probably a fellow colleague or a fellow health worker to report it, and which the hospital management investigate and make their recommendation. Also, a form of incident reporting that occur at the institutional level, which is common, is the morbidity mortality review. In this case, doctors or nurses come to present their mortality case, where a review is being discussed at the ground round. Also, we have the interdepartmental review too, like clinical pathological reviews too, which occurs in case you have a very bad case or maybe a patient died. The department concerned needs to come together to review the case to determine what is the cause, and the lesson will be learned. And lastly, patients also have the opportunity to use the Servicom route of the hospital to report any incidents at all, to declare their grievances if they are not satisfied with the conduct of the healthcare professional in the hospital, whereby the hospital management will investigate and, of course, make their recommendation.
Thank you very much. I think we'll go to Dr. Caleb. I like what he said about the patients being able to complain, because at times some of the complaints are incidents that ought to be reported. So that is, it is a pragmatic approach. At the hospital I work, the patient affairs unit is very close to the patient safety. Patient safety investigates incident, but some of them come as complaints. So we can hear from Ethiopia. And I'll be happy to also hear the inputs from the nursing side. Nurses are custodians. When we initially introduced our forms, if the nurses didn't keep them together with their notes so that they can give them in the ward rounds, there was no way we would have taken off. So you can give us a national picture, but then also you can situate for us the role of nurses in integrating these practices into institutions.
Incident reporting system in Ethiopia. I would say like at infancy stage, like we have just tried to establish it. So regarding to the structure, so all hospitals have incident report, incident focal. So every hospital have a focal person, not only hospitals, there is also health center, so there is a kind of structure at hospital level. And also recently we have developed a guideline, incident reporting and management guideline, near final guideline. So that guideline is, as already mentioned by a lady from South Africa, just it is based on the minimum information model, the WHO minimum information model. We have developed that guideline. It is starting from identifications to feedback. So there are tools used to, report, to identify, and also to learn to avoid further incident. There is a kind of a learning system there. So we have such kind of a guideline. Regarding reporting, we have a limited reporting culture in our hospitals because of the already you guys mentioned blame culture. So people are afraid of reporting because of the legal issues and the blame culture. So we also have, we did a study regarding this. Almost more than 50% of healthcare professionals do not want to report because of fear of blame. So that is a big issue, and not only in Ethiopia. Now I understand in Africa also it is a problem. So we have tried to avoid that. We have tried to develop the guideline, as already mentioned, and also we have in contact with some legal logistics to come up with some legal and legislative measures to have give freedom for healthcare workers to report those incidents, and it's an talking stage. So I think that's also very important.
Thank you, Caleb. I wanted a clarification. So you have a specific guideline for incident reporting, not just part of your general quality of care and patient safety policy. You have one for incident reporting, like the South African one.
We have a patient safety guideline, which is a holistic one, and also a separate incident reporting guideline.
Okay.
So that it is a little bit detailed one, so every healthcare professional can identify every steps, and it is easy for them to understand what their role and what they are going to do.
Thank you very much. I think they deserve a round of applause. So we've gotten the South African one, and now we have one in Ethiopia. We will all be Googling those documents and seeing how to come up with one. I know many institutions have, but mostly at national level, I think it is a good journey that we are learning, and we look forward for it hitting the ground. Yeah, Madam Selina, Dr. Selina, let's hear from Ghana. After Selina, we'll have Professor Esaias from Jimma Hospital, Ethiopia. Yeah, thank you.
Thank you very much for the opportunity. So our incident reporting system in Ghana, so far, not too much, but I have a few points to give out. At the national level, we have the Food and Drugs Authority that look at the medical vigilance issues. And this system, individuals report, and coalition of health facilities who also report on drugs events. When we come to the national, the ministry level, I said FDA, for the Drug Authority, is an agency under the Ministry of Health. So when they receive all this, they come and report to us. But individual patients also report adverse events on whatever services they are receiving outside, which is not prescribed. They also write straight, or they walk to the Ministry of Health. Those who are not closer to the Ministry of Health, that's the capital, they will put in an email for us what is happening. When we get to the national facilities like teaching hospital, incident reporting system is very good. We have a form, incident reporting form. So whoever detects the incident, pick the form and write. This form is handed over to the ward in charge or the unit in charge, and then handed over to the quality managers. And they will collect all these incidents, and they also look at in a monthly what exactly has happened. What are the incidents that has happened? If it's about drugs, they move it to the pharmacy department. If it's about blood, we have National Blood Service where we have to report all these things. But we come together also to analyze the reports that has incident that has happened. And then we look at it and then have some few training and learn lessons from it. The other things that we also do is about maternal mortality audit. So we report audits, we audit all mortalities within 7 days. And this platform will learn a lot as to what has happened to that patient before he died. We learn a lesson, we come out with recommendations of which we don't want this type of incident to happen again. Some regional facilities, as I said, are reporting highly on this medication error, prescription errors, and then the prescription errors are mainly about the doctor's handwriting, and then a few on falls, and then surgical site infection. Actually, we have a database where monthly you report surgical site infection into the national data system, where we analyze and see infections that has occurred. What we are not doing much is the healthcare-associated infection, general, not surgical site infection. We are not doing much over there. The reporting system in the sub-district is not very strong, even though we are doing our best over there. It's not strong because we think, as everybody has said, the blame game. I will not report it because I will be blamed. And that has been the challenge for all of us at the national level and then also the sub-national. So for Ghana, we are reporting some of these things. Sometimes not only what you report to us, but the client also move. And I said we have regulators that, like Nigeria has said, the Medical and Dental Council, which regulates the professionals, the practice of the medical team. So if there are any error that the doctor has committed, is the Medical and Dental Council that handles it. And the Nurses and Midwifery Council also. If there's any error that the nurse has also committed, they also come in and then to also put up some punishments for this staff. Then the quality teams are also...
Finalize? Yeah, just summarize.
Okay.
Yes.
So in a summary, what I'll have to say is that we are not much ahead too much. We know we are doing something, but not up to the standard that we are looking for. Surveillance is a challenge to us, and we wish to improve on that, have a lot of trainings around that to be able to report incidents as well as.
Thank you, and you've just made me be curious. When we were beginning the reporting, there was a challenge about will it be vindictive, will we be punished? And so having skills, including root cause analysis, system review, and pushing the blame beyond where the sharp end of the error, where it happened, to the rest, is very useful. So incident reporting can never stand by itself. It has to come with a patient safety culture, with all those skills for root cause analysis. So you brought up something very important about the aspect of punishment. Reporting, it say that healthcare goes wrong because we punish people when things go wrong, and at times it's not just the people. So thank you very much. So we will welcome Professor Esaias. If you're online, yeah, you're ready.
Yes, I'm online, Lydia.
Yeah. Kindly give us a snippet of what happens in Jimma Referral and Teaching Hospital, Ethiopia.
Thank you, Lydia. I would like to thank the organizers for the invitation to this important event. I am a professor of medicine, practicing internal medicine in infectious diseases. I am here as someone who had led the hospital a few years ago. I'm not currently working in quality or incident reporting. So I just want to share the experience we had just before the pandemic, a different experience we had. So before the pandemic, we had incident reporting of maternal health event that included near miss, maternal delays in C-section. Also, we had a self-surgical checklist and perioperative adverse event reporting. The Ministry of Health were visiting us frequently. There was regular enforcement, and it was included as a regular review meetings through maternal days audits, morbidity and mortality reporting conferences. However, as you know, COVID-19 came, and the staffs were reassigned to different units to combat the pandemic, some of which were sent outside the hospital to the quarantine site. And those who remained, they faced burnout, and of course the quality improvement initiatives became lower priority at the hospital. So it was not actively reinforced. And the committees met less frequently, probably not at all during the first 1 year of the pandemic. And this incident reporting was almost ignored after that. The other issues you mentioned, the culture of blame and the fear is there. But there are other issues also, time and workload, because people, my colleague from the Ministry of Health described there is a focal person, but most of the focal person assigned for this incident reporting are also assigned full time to other activities. Most of the time they were from maternity, midwives, or someone working in the operation theater. So that led to a heavy patient volume that left little room for extra paperwork. Budget constraints, particularly after the pandemic, that led to no training at all, unless it was offered outside. There was no follow-up. Even like the format that has been described were not properly printed out here. And there is also high attrition rate of nurses. Our hospital, like over the last 2 years, more than 100 staff nurses that have been here have left the hospital. And other issue is a lack of feedback. The staffs may report sometimes, but the action taken cannot be fed back to the person who reported.
Esaias, do you have a form for GIMA for reporting medical incidents? The ones that are not, let's say, for blood?
Currently,
or adverse drug events for...
Yeah, that's...
Yes.
Yeah, the adverse drug events are different. They are sent from the Ethiopian Food and Drug Authority, but this incident reporting is different. Currently, I don't know what they are using because, as I said, I'm not working there, but previously there were reporting formats.
Thank you very much. I think GIMA represents a typical hospital whereby when you'll have less staff, some roles won't be done, when there's less funding. So thank you for sharing the journey for GIMA. Allow me to give a question to Ronel. Ronel, there is a question by Dr. Ouma of Uganda, whether the learning and reporting system is also for the public, for the private institution. Isn't the government interested in the private system too? Then share an example of some changes realized due to implementation of the above system. I think he's trying to ask, has there been some change? Has there been improved in quality or improved reduction in some form of harm? That is usually $1 million question. I think Dr. Ouma is, yeah, great.
Yeah, thank you. The information system I spoke about is currently just for the public sector. So it's not used by the private sector. The private sector, most of the private hospitals have their own systems that they use to report patient safety incidents on. So it is something that we still need to move towards. As I've been listening to the other panelists, I think our country is also in the same situation where we have actually fragmented systems for reporting patient safety incidents, because the one I explained is all-inclusive for all types of patient safety incidents. But we have separate systems where our blood services also require reporting. For medication, adverse drug reactions, we have a separate system where they are also required to report. So we do have that problem as well, that we have, in some cases, for specific type of incidents, there are two systems where staff need to report. Regarding, as you say, the $1 million question, the change, what it changed? I think that is a very difficult question to answer, and I think that would be a research on its own. What I can say and what is, a concern for us is that if we, when we do the annual report every year, we do see that the type of incidents which occur the most still is the same. That has not changed, which you cannot, confidently say that no change has taken place, because you need to look at different facilities. This is just what we see at the national level. But yeah, I think that's a very difficult question to answer with what change have we seen.
Yeah, thank you.
Lydia.
Thank you. That's very difficult. In our target, when we began incident hospital, we said we'd want to increase the number of reports, and people were not happy. Why do you want more harm? We are like, we are not reporting, so our target is to improve. But however, when we talk of sentinel events, our target is 0. So it depends on what. Are you reporting just near misses or everything, or the sentinel events, like would want patient identification to keep improving over time? So I think it is $1 million question. Do we have any 2 comments from the room before we close? Yeah, there is Odwar. Any other? And Peter Lackman. Let's start with Odwar, then we go to Prof.
Yes, thank you. Mine is also just on Elle's presentation. On the incident report, I did notice that there was an element that is mentioned as contributing factor. So I was thinking through myself, at what time is this incident report made? Is it real time, or is it's made in retrospect? Because by practice, if I'm making an incident report and I'm required to indicate the contributing factor at the time of reporting the incident, I think there's something that needs to be explained as to, is it after an RC has been done, or is it before the RC has been done, but the incident has been taken note of? So that is something that I really didn't capture well. Maybe probably you can speak into that.
Thank you. I think, Ronelle, you're speaking to that, but my understanding is there is the initial report that is done, whereby you write the RCA as it's been done in the unit. But for serious reportable event, it is handed over to a centralized system, whereby you do a thorough root cause analysis by a dedicated team. So I will hear from Ronelle whether that is the case, but at Kenyatta National Hospital, the incident report has an RCA that is done just within the unit, like almost immediately. They should have an idea what happened, what are the contributing factors. But there's a threshold whereby a certain issue should be taken by an independent group. So it comes to the patient safety unit where Samora works. Samora, can you raise your hand? Samora does such things. So then there, at times they could do that RCA for a little longer, but they would want to start closest to the event. So Ronelle will hear about that root cause analysis that is documented in the form, and that which Odwar is alluding to, the other one that could be more in-depth. What is the relation, and at a national level, what does that look like? At our Kenyatta National Hospital level, I'm very sure how that looks like, but I wonder at a national level, how does that root cause analysis look like? Once you comment, I will welcome Peter to give his comment.
Thank you for the question. So we do advocate for real-time reporting. As I've mentioned, we have the notification system, which will only work if you actually capture the incident when it occurred. But we also have a lot of challenges in our hospitals, especially in rural hospitals. Some struggle with connectivity, and obviously have to have connectivity to capture. So some of the patient safety incidents are captured retrospectively. The system is set up that when you initially report a patient safety incident, there are just a few required fields that you have to complete before you can save the incident. So one of those are you have to capture initially your classification systems, including the contributing factors. But you can then save the form, then you go and do your investigation, root cause analysis, and then when you go, you have the opportunity to go back and update your classifications based on your findings of the investigation before you submit the form for the incident. I hope I've answered your question.
Thank you. I think that is a great attempt that you can go back to the form and fill it after you've done a much further investigation. Remember, some of the incidents are reported upstream. I could report in the ward an incident that they missed a certain investigation in accident and emergency. So you report as is, where is, with as much as information you know. So I think there is still value, and it is a learning curve. I think what Odor is saying is that it is a learning curve of what is the best way to get the information. And thank you, Ronelle, for the answer. So we'll finally have Peter give a comment. Dr. Lackman.
So I just want to comment because you're playing catch up to upper income countries that spend a lot of time developing incident reporting and now moving away from emphasizing incident reporting because it doesn't mean you're going to be safe. It takes a lot of time. It's important. So I just want to remind us we had a lot of what and how to do it. This is how we do it. But the question is, why are we doing instant reporting? That's the first question that you have to ask. Why are we doing it? Because it's all about learning. That's what it's really, it's about learning. So if we're not learning, there's no point in doing instant reporting because then it's not going to work. So I just want to remind everyone of the 5 pillars of of safety culture from James Reason. Do you all know the Swiss cheese model? And that's James Reason, who died. He died about 2 months ago, 2 or 3 months ago. He was 93 or so. A bit close here. And there are 5 pillars. Sorry. The first one is an informed culture. So the incident reporting is helping you to, I'm just going to take my computers here, to inform you of what's going on. So that's what Ronelle was telling us about. For them, it's informing what's going on a national level. But you've also got to inform what's going on in your own organization. To have that, you need a reporting culture where people feel safe to report and that they're not going to be blamed for errors. Because most things, when an error happens in the system, the person's just at the end of the system. Most people don't go to work to do an error. So that's very important.
I'm giving you 1 minute.
Then you have 3 things. Then you have a just culture.
Yeah.
And then you have a flexible culture that changes. And it's the learning culture. So those are the 5 pillars. So the instant thing that Ronelle will show in her report, it's the feedback loop. It's how people learn. And that's the most important thing for all these instant reporting, whichever they are. It's how people learn at whichever level they are. So that's what I wanted to stress, that it's important. But if you're not learning, then it's not worthwhile. That's it.
Thank you very much, Peter. I know there is much that can be said, but thank you for emphasizing that. Why are we reporting? It is for what? For learning. Why are we reporting? It is for learning. So I think that is a good takeaway. I'm so sorry for not seeing your hands because we are short of time. In fact, we will not go back to the panel. I think we will allow the next group to start, but we'll give them a big round of applause. Thank you, Selina. Thank you, Dr. Olatuji. Thank you for Caleb. Thank you for Lavender. Let's clap till when they get off the stage as I welcome Dr. Peter. Oh, there is a photo. Peter Mutanda, Mr. Peter Mutanda, welcome. I can give you the mic as we take the photo. Kindly proceed. Do you want us to stretch?
Thank you. Good afternoon. Can you stretch a bit? Just lift whatever you can lift up, whether it's your hand, anything you can lift up, or anything on your body that you can lift up, either a hand, a leg. I don't know how much you can do with a leg, but anything, even you can lift yourself up. Super. Thank you so much. So we have another 85 or so minutes to wrap up the day. So if you can take your seats, we continue, please. Thank you. The next session is equally exciting, but I just want to start by introducing myself. I had a hard time during break and lunchtime. I think people have seen me doing some work somewhere else. Then I asked me, Peter, please just tell us, what do you do on this planet? So my name is Peter Mutanda. I'm saying this just to save my job because my boss could be listening right now. So I'm a technical coordinator with the International Rescue Committee. I support a Gavi program in Horn of Africa and some Sahel countries. But I have a very strong association with IHI. I've worked with them. I've been their faculty member for their quality improvement work stream in Kenya. And I've also, I'm here courtesy of the Society of Quality Healthcare in the country. I'm just next to my president here and many of my colleagues in the society. And also I do some other work on a few of quality improvement work, both here in Kenya and other parts of the world. So once again, don't be misled by that post. I'm not going to give any keynote address. I'm here to facilitate the discussion. And I will start by just appreciating your participation, finding time to travel all the way, wherever you came from, to come and join us. So very honored to moderate this discussion this afternoon. And we are going to be exploring one of the most strategic challenges that we face in the country, in the world, more so in these parts of Africa, or these parts of the world, on how do we ensure that we prepare our healthcare workforce are ready to face the issues of quality in the workspace. So the session is right into the spirit of our theme, co-producing safer care. And we all know that whoever is producing that service that Dr. Lachman was talking about is the healthcare workforce. So how prepared are they when they step out of the graduation square and join the service delivery? So the evidence is there. I think for you who have been reading this, it's clear, it's urgent that we've seen from some researchers up to 10%, 15% of our hospital patients get some harm whenever they come to seek services. So it's all about preventing that harm. But also, we also know from studies that in sub-Saharan Africa, a lot of our students and faculties are not fully ready, or they are sort of limited in terms of exposure to quality improvement frameworks and application of the methodologies that will provide safer care whenever we have services. So this is not just an education or a faculty gap. It's not just about our institutions not having the right framework or the right curricula to prepare our students and our healthcare workforce. It is a systemic situation that affects the whole healthcare industry. And how do we meet as stakeholders to ensure that our healthcare workforce is fully ready, grounded in terms of the training, in the foundations of patient safety, so that we do not have quite a lot of investments when they are in service. So today, this afternoon, we'll dive deep a bit, get some findings from a comprehensive multi-site study that was conducted in Kenya, just to analyze the training needs. It's a TNA, training needs assessment analysis. And then after that, I will welcome some responses from the team, the plenary. And then by that time, I'll also want to welcome a panel to discuss other elements of how institutions are prepared or how they are conducting their business of ensuring that we have the right set of healthcare personnel stepping out of our institutions ready for work. I just want to confirm if my panelists are in the room. So where is Irene? Irene is right here. How come I can't see you and you're right here? Where is Professor Juka? Thank you. Where is Dr. Rodma? Adam? Thank you. Thank you so much for finding time. Can I also see Maureen Shabalala? Thank you, Maureen. Where's Dr. Peris Kiarie? Are you here? Thank you. I invite you formally to come. But now, let me introduce Dr. Caroline Muguha. Caro is going to make a presentation on their findings, but as she steps forward, I don't know how much you know Caro. I don't want her to waste time introducing herself. Let me just do that honor and tell you that Caro is a medical doctor by profession. She's worked in this space of quality improvement for some time. She supported a lot of institutions, accreditation. I think she's very familiar with a lot of our models in the world, SafeCare, JCI, Kenya Quality Model for Health. She's done some programs in the country supporting USAID evaluations in many of the projects. She's also very good with grant development, project management, and also she's a very nice person to work with because I work with her in the society. Is that enough? Please, Dr. Caro. Thank you.
Thank you, Peter, for a very elaborate introduction. So I'll move right on. No more conversations about myself. So I'm here to just talk about a study, a multi-site study that's been done here in Kenya on training needs assessment for quality and patient safety. It's done in 5 institutions: the Kenyatta National Hospital, that's our biggest teaching and referral hospital in the country, the University of Nairobi, that trains a lot of our healthcare workers, the Kenya Medical Training College, biggest trainer of very many healthcare workers, Kijabe Hospital, and also College of Health Sciences, as well as Aga Khan University Hospital. So a very good spread, a very good touch point, a study that touches both public, private, and faith-based. What you see there is a number, the study is a collaborative study with very many experts and professionals in their field representing those various institutions. So, just to give a bit of a background, I think we all agree that, healthcare service delivery is, it occurs in a space that is complex, and therefore quality improvement and patient safety is critical. But knowing that has not translated into how we train the healthcare workforce. And so that's what Peter is talking about here, talking about, are our healthcare workforce actually prepared? The keynote address by Dr. Peter Lackman today, very important statement that we need to inculcate these things in our genome. And he spoke about how many of us may not have encountered it in training, but what about now? What are we doing to ensure that that changes right now? So this study, and you know, many studies have shown that medical errors often stem from system failures, from communication and teamwork failures, rather than clinical incompetence. Yeah? And so this training needs assessment was to identify content gaps and to inform curriculum reform in this way. I'll skip that because it's pretty much, so the aim of the study was, to assess the needs for training, specifically to identify key content, yeah, and to explore teaching methods and instructional approaches in quality and patient safety, as well as, to assess what implementation barriers are there. What are these barriers and challenges that are making it difficult for us to actually implement this in our training institutions? So it was a concurrent mixed method study, combining both quantitative and qualitative. We had, the pointer is giving me a bit of a problem. We had an online survey that had a structured questionnaire, that focused on awareness, perceptions, and actually had some section of self-assessed knowledge from the participants. We had about 476 respondents from the various institutions, and we had 34 interviews, in-depth interviews with key informants that consisted of faculty, educators, and hospital administrators and program heads, as well as frontline healthcare workers. So I just want to delve, yes, and of course we had sought ethical approval in every one of those institutions, as well as the National Body for Research. Maybe you can help me move the slides because the pointer is giving me a problem. Next slide. So just to give a snippet of the findings, and there were very many, so I can only highlight a few. A lot of the participants, at least 75% of them, felt that some aspects of patient safety are mentioned or are discussed in the content that they are taught. About less than 50% felt quality improvement is ever mentioned in their curriculums. But when asked about awareness of patient safety initiatives in the hospitals where they work, that's for frontline healthcare workers, or the hospitals where they are placed, because we are talking to students and trainees who are in their final year of either medical training or nursing training or pharmacy training, lab training, whatever training, only about 29% were aware of any patient safety initiatives, and about 20% were aware of any quality improvement initiatives in the organizations where they were. There was an overwhelming consensus, over 96% agreeing that these things should be emphasized in their curriculum. And majority of these respondents were trainees, but then there was also a big number of frontline healthcare workers. And it's good to see that about 68% of them recognize personal responsibility when it comes to patient safety and quality. Next. So there was a lot about effective communication and safety, including in specifically even in surgical care and all that. I just want to focus on about 71% report that there is actual training on adverse events and near misses. So they're actually trained, yeah.
but then only 54% report that there's open disclosure after an adverse event, which is what we've just come from discussing, talking about reporting or the environment where disclosure of adverse events occurs. Next. So 70% say they are trained on managing clinical risks. Again, about 70% on actual adverse events, what they are, on near misses, what they are, but less than 40% report on anonymous error. They report that there's anonymous error reporting existing in the institutions where they are. Next. So on the qualitative bit, next, there was consensus affirming that there is need, yes, to integrate quality and patient safety training, both at pre-service level, that's at student level or trainee level before they get to the workforce, and also in-service training. So of all the training curriculums that we assessed, about 40 of them mentioned having embedded this training within the existing courses, somewhere, maybe mentioned within the different things, maybe some surgical care, maybe pharmacovigilance, embedded, not named as quality or as patient safety, but they identify them as aspects of care, of patient safety and quality of care. Only about 13% offer standalone modules or units that emphasize on quality and patient safety. And 20% and even the rest, or 20% offer minimal exposure, the rest offer none at all. When discussing preferred approaches for implementing and teaching quality and patient safety, the theme that it came out that a blended learning is blending theory and practice is what is preferred. Things like simulations, team projects, case studies, and aspects of mentorship. That's what majority were saying would be a good approach. And that priority content, patient safety came out as a priority, and then many recommended that this training should be around the 3rd or 4th year. Most of the training programs are around that long, so towards the end of an undergraduate training program. Next and last, maybe the main thing here is there were barriers that were elicited, things like curriculum overload, lack of faculty that are aware and that are able to teach these things, this content of quality and patient safety. And leadership support came out strongly as a theme, as an important barrier, and also as a mitigation strategy that they'd need leadership buy-in to be able to integrate this, as well as faculty training. And that, emerging themes from this study were that there's preference for a practical approach to teaching, a multidisciplinary approach to teaching, and a patient-centered learning system. So I'm going to stop there because we have a panel, a very rich panel that will discuss this further. Some who will tell us about training at in-service level and how the different experiences they've had training at in-service, and then we'll have experts that are in the teaching institutions where this study was done, and they're going to be talking to us about the approaches to implement this curriculum integration. Thank you.
Thank you. Thank you so much. When I told you she's a very nice person to work with, she keeps time. That's one of the things that she's very nice at. So I want to invite the panel. Please on my instructions. So I call your name. You step forward as I introduce you. Let me start with Professor Rodney. Professor Rodney as he comes. I don't know if you want to clap as he comes, but thank you. If I was to read his CV, it will take us another 2 days, but Professor Rodney is Professor at Aga Khan University here in Kenya, and a true polymath of medical excellence. He's board certified in internal medicine. He's very experienced in infectious diseases, with molecular parasitology, training at the National Institute of Health. He's also a professor in infectious diseases, and he has a very unique combination of clinical expertise, research leadership, and systems thinking. He sits on so many affiliations globally, but I can just mention that he's a fellow of the American College of Physicians, and also a fellow of the Infectious Disease Society of America, and a member of the European Society of Clinical Microbiology and Infectious Disease. Another warm applause. Thank you. Let me also ask Professor Ojuka to step forward as he comes. So again, Professor Ojuka is an associate professor and the chair of the surgery department at the University of Nairobi. He brings quite a lot of surgical experience and education reform. He's a general surgeon specializing in breast surgery with a PhD in surgical education. Professor Ojuka has served as the president of the Surgical Society of Kenya and also governor of the American College of Surgeons in Kenyan chapter. His expertise in clinical excellence and also education research will offer us very crucial insights on our discussion today. And as some of you may have heard earlier, he's also a family member of one of their choir founder members. Next is Maureen Shabalala. Please, Maureen, can you come forward? So Maureen, as Maureen steps forward, Maureen is, if you've not heard about AHI and you're in this room, you are still a baby in quality improvement and you're in the right place. So Maureen Shabalala is a senior director for global delivery at IHI. He's been my boss, that's why you're finding I'm standing like this. She's from Johannesburg. She has over 20 years of experience implementing a lot of quality improvement initiatives in South Africa and globally. A true science of improvement practitioner and specialist, and her PhD in public health and extensive work in IHI's professional development delivery will be very useful in our discussion. Thank you so much. Dr. Paris, I know you are still very far. As you come, please, Dr. Paris. Paris is from Kijabe. Yeah, Dr. Paris is the principal of Kijabe College of Health Sciences and quite a leader in the nursing education with a Doctor of Nursing practice from Vanderbilt University and quite experienced in terms of accreditation. She has sat in the board of Kenya and the National Council of Kenya, National Nursing Council of Kenya, and she's quite a pioneer in innovative academic programs. So thank you so much, Dr. Paris. Can I get Dr. Kennedy Rateng, please? Is he here, Dr. Kennedy? Dr. Kennedy, karibu sana. So Dr. Kennedy is the head of Department of Healthcare Services at the Kenya Medical Training College. KMTC has over 90 campuses in the country. I think it's the largest institution that channels out thousands and thousands of healthcare providers in the country on an annual basis. He's a family physician, and he's been instrumental in curriculum development for mid-level healthcare professionals in the country, having served this space for more than 20 years. quite experienced. He was at the center of the COVID response when he was in charge of the largest quarantine center in the country at the MTC. And then you will not be surprised to know that he's also a long distance runner. I don't know how much he's covered in kilometers, but yeah, he likes running like many Kenyans. Thank you. Irene, please step forward. So Irene is Kenyan, but you may have not even seen her in Kenya a lot because she works a lot in other countries. She supports training of quality healthcare professionals on quality improvement. She's a nurse practitioner, nurse leader, health systems thinker, and leader in that space. So we'll also hear quite a bit about her experiences on how the in-service work goes on with healthcare professionals around quality improvement and patient safety. So thank you so much. Okay, so where do I sit? Can I sit here? Okay. So I think we'll start with Maureen and Irene. Let me start with Irene because you are next to me. So you provide, from what you've had, you provide support to healthcare professionals in the space of QI through trainings, mentorship, and the whole work stream. Would you kindly tell us how is it, like what gaps do you see, or what have you identified as the critical gaps in the in-service training for quality improvement and patient safety for healthcare professionals? Yeah, thank you.
Thank you for this opportunity. I think it's easier to speak through the lessons I've learned. Some very difficult, some easy. I think the one thing that stands out completely in offering in-service training, especially in the private healthcare sector, is to be able to conduct readiness assessments. Most of the times when we go to conduct training, we never really look at the environment. We just sweep in and say, okay, there's a problem, let's train, let's move. And then after the training, you realize there was a lot of other things we should have done. So one of the things we now do is we do a readiness assessment. And what that means is we look at the way the organization is systemized, if there's such a word that we can use. And that means we are looking at, in terms of strategy, is quality showing up anywhere? Because when you leave, you need to leave it somewhere. So it has to be embedded somewhere. Then in terms of team readiness, is the team really ready? In terms of, I had someone talk about turnover and all that. It's not always, unfortunately, it's not always the right time to offer QI and patient safety training on the go without doing the groundwork. The other thing I can mention that I have learned is to always include, whether you want to call them supervisors or the leaders in this process. And by including them does not mean informing them, but then also coaching them or mentoring them, because the frontliner is being taught how to do something, but the person who enables them is the leader. If they don't get empowered, then the frontline person cannot do anything. Therefore, the training remains hanging. I think I would love to just mention those two, and in case there's any other question that comes up, then I can be able to respond to.
Thank you. As we request for another mic, please. So thank you so much. I will follow up on that because you mentioned about focusing on the competencies at the front line, but also looking at the supporting structures. So I think maybe the next response will be, how do you distinguish between who needs what in terms of preparing them for the space of quality improvement? But before you do that, let me just ask Maureen. Maureen, you sit in a very heavy faculty, a global team of experts, and we've been doing this for many years. And I think the gap was that the healthcare workforce wasn't truly prepared to offer the complement of quality improvement post-graduation. So how have you done it, and what is your experience? What are the gaps? What are the competencies that you see, and how do you approach it as IHI?
Thank you so much for having me. I think if we think about quality improvement for healthcare workers, they are key drivers. First one is what Irene has already spoken about, leadership, because the leaders kind of bring in an enabling environment for quality to take place. And then we also need to figure out data systems. How will we be able to collect the data in the field, in the sites that we'll be working on? And we need basics. So even though we use the available resources, we need those basic resources to be present, and it involves leadership as well. And we need knowledgeable healthcare workers, meaning when you introduce QI, you also want them to have the clinical skills. So in terms of whichever area, whether it's maternal, whether it's TB, whatever area they're working on, they need to be able to understand clinically, and when you introduce QI, they'll be able to embrace it. Having said or talked about these key drivers and getting engaged leaders, part of it Irene spoke. We need leaders that are knowledgeable on QI. So, you can't keep leaders for 2 days or 3 days in a session teaching them QI, but at least engage them. Even if it's half a day, they'll be able to embrace and bring that enabling environment for the frontline healthcare workers. However, on the field, when you're working with healthcare workers and they've learned the basic QI knowledge, learning the knowledge is one part of the journey. So there has to be another part where you are literally holding their hands, teaching them how to institute QI in the field, in their environment, in the ward, showing them how to use the tools. That's the bigger part. Learning in class, they'll grab it. Learning online, it's okay, but we need the coaches. So I'm also glad that the acquired team do have coaches that are coaching these team members. The coaching part is very crucial. The mentorship is very key to learning. Some of the gaps that are easily identified are data, either collection of data from the word go. We are good at collecting an outcome, like what we want to improve, it's easily collected. But if you think about the changes that you want to institute, we don't really collect that data, and that's where we want to collect the data. Reason being, most times we will not have an indicator that's already available for us to collect that data. So the coaching and the mentorship helps the teams to learn that skill of data collection. There's also an element of data interpretation. So when you start QI, teams get excited with one data point, like, we are improving. But then we know that with QI, we do have rules for interpretation, which also gets to a level of teams to understand their own data and interpretation. Another gap that we do have is we don't write a lot of stories. So if you think about all this fragmented QI that's happening out there that Carol spoke about, there's a lot of QI that's happening, fragmented in silos, but still we're not writing a lot of stories, whether it's a blog, whether it's just an abstract or a poster. We wait for these events to showcase, like, okay, we have a poster, and I need to write, but we need to do more of writing. So let me pause there. Thank you.
Thank you. Thank you very much, Dr. Mauri, and we'll come back to you in terms of how do you distinguish the cadres also from the institutional leadership, from the frontline workers. How do you package your training curriculum to address what you've just spoken about as gaps? So my next discussion question is, I'm looking at Paris and also Dr. Ateng, Dr. Paris and Dr. Ateng. But let me start with Dr. Ateng, because Kenya Medical Training College is quite big, 90 plus campuses. You have more than 100 courses of mid-level professionals that you train, and you have to prepare them for the environment. So the patient safety quality improvement angle has been quite prominent in the last decade or so. So from the results of the TNA, what do you feel are the gaps? Do those resonate with your situation at MTC? And how are you working around maybe correcting some of the gaps? Thank you.
Thank you. As you have said it, thank you. Rightly said, KMTC, of course, is the largest middle level training college. We always think that that statement is true to the entire Africa. We have about 70,000 students with programs. We have 18 departments, 126 courses. Yes, and according to the TNA that was done, I would say that it really speaks to us loudly, because most of these courses, the many courses that we have, we do develop them after TNA, and therefore this is one of the TNAs that would use then to come up or to bridge the gaps that has been seen. Yes, QI, patient safety, are there in various curricula in our training, but they are scattered. They are not, standing out. There's an area of training that we have made compulsory to all our students taking diploma courses, and this is health system management. And this is an area that there are topics in there on quality improvement, patient safety, and even in other clinical training. But what is coming out that the way it has been approached in various curricula as we have is not coming out well, that students can feel they have been trained in area of QI and in area of patient safety. And therefore, as a college, this TNA is going to inform, or has informed us, in which, which step to take. We have to come up with modules that would be speaking out clearly on quality improvement. I know it's very good that we are talking about quality. As a college for many years, the focus was more on the quantity, on the availability. Yes, but I think we are reaching a threshold that now we must bring quality in our thinking. And this is good to us, and I think for the last 10 years, this has been a feeling. And as a college, we have relied so much on skills lab training to tackle areas like patient safety. This is a method of training that students are allowed to practice, make mistakes, and those mistakes are corrected before they actually get to reach the patient, as a way of talking about or talking to patient safety. But I think we need, as the TNA has pointed out, we need to do it better. I know, again, in area of quality, we have some, I would say we have some achievement we have made, but I think we stopped at quality assurance. Yes, where as a college we have been very keen on coming up with protocols and making sure that these are followed and documented. But the talk now is quality improvement. How do we make sure that we're becoming better? Yes, not sustaining the level that we are doing things. So I think this is an area that from this TNA, we have to shift our thinking and bring these concepts very clearly to students. I know one area that, a barrier that I would say that sometimes we encounter is that we have clinical places that we attach our students. And you see, we give the students the theory, and after skills practice in the skills lab, we take them out for clinical placement. And when they get there, they get those, the practices there, not matching perhaps with the theory they have learned because of the systems in those clinical areas. They get out, they find out that perhaps the procedures that we have taught them to safeguard patient safety are not being practiced. And that somehow would bring that challenge. Yes, and this is why I like the approach of thinking of, as we think this at the pre-service level, there's also a thinking that is happening at the pre-service level, that people that are already practicing should be prepared for this new thinking in health practice, so that the clinical, the theory will therefore match the clinical practice at the clinical attachment for our students. Thank you.
Thank you. Sorry, this mic is failing. So thank you so much. Thank you for that response. It's almost like Dr. Rateng is telling us that we produce the right cadre, but you are not ready for them. They come into a team that is not prepared to apply the theory, We'll come back to that. Let me go to Paris. Dr. Paris, you are a leader in Kijabe Hospital, a training college, training institution. Almost the same experience in terms of curricular development and the application of theories to prepare our healthcare workforce, not to the scale of KMTC, but in a similar sort of situation. So what would you think are, from just the TNA, what will be the gaps, and how are you using such findings to improve your training curriculum?
Thank you, Peter, for that question. And I want to start by applauding the team that did the TNA, because the results shared are very timely. And the results are not that surprising because they reflect the current situation on the ground. Looking at the different curriculums that we offer, and in our institution we have 3 schools and a total of 9 different programs, and across those different curriculum that are under implementation, we currently do not have a standalone a module that focuses on quality improvement and patient safety. Though, yes, we have elements of QI and patient safety in some of the modules, we do not have a standalone module, meaning that this concept can, they are not given enough emphasis as they deserve. And also looking at the integration of theory
practice. There are also some gaps because we lack a formalized, hands-on practical exposure given to our students to utilize the QI methods and tools available. And also, we normally send our students to different healthcare facilities for their experiential learning, and these different health facilities are at different level. There are some facilities that lack structured incident review and reporting structures in place, and those that have these structures in place, some of them do not intentionally involve our students in when they are in their clinical rotation. And also looking at the health, the human resource that we have, the trainers and also the clinical mentors and the other staff. We also have a big pool of these health personnel who have never received formalized training in quality improvement and patient safety concept. Peter, you asked what are we doing to bridge these gaps that are in existence. Yes, I've said the results are very timely, and they have helped us to realize that we need to do something to improve if we have to release into the healthcare industry graduates who are market ready. So to start with, we have already identified a key competency focusing on patient safety and quality improvement concept that we plan to integrate in one of the module to start with as an update across different curriculums that are under implementation. And there is also a consideration that in future during the curriculum review cycle that we'll consider having a standalone quality improvement patient safety module. And also I know time constraint was mentioned as one of the major challenges, especially every time that we have new modules to be added into the existing curriculum. Time is always a challenge, and we plan to leverage on the online platforms that have free access given to students to interact with the patient safety quality improvement materials, so that the limited time that we have, we can use that time to discuss with the student, also give them practical exposure. We've also come up with a framework to give our students exposure to do small-scale quality improvement project in the course of their training. And in this, we plan to also use interprofessional training approach where we bring different cadres in class and also allow them to do collaborative small-scale quality improvement project with the hope that this will also foster collaboration and effective communication. And also, we plan to review the clinical objectives to ensure that we have an objective, objectives that are embedding quality improvement thinking when the students are in the clinical area. I think those are just a few of the interventions that we are currently doing. Thank you.
Thank you so much, Dr. Perez. Thank you. Thank you, thank you. It's good to hear that you already moved ahead to look at how you can review your curriculum. That's very impressive. Let me go to the two professors at the far end. I'll start with Professor Juka. We all know that changing a module in a university like University of Nairobi is almost like changing a constitution. I don't know, how are you using these findings to sort of make it different for the next set of generation of professionals? Thank you.
Thanks. Yeah, changing curriculum in the university, of course, is like changing constitution. because of course it's the basis of learning. I think one of the good things about institutions then is they also have systems. One of the systems is that there is a curriculum committee for the institution that we are engaging currently, having engaged the academic leadership of the institution. That is the Associate Dean for the undergraduate, as currently instituted in the Faculty of Health Sciences, and the Dean for the faculty, and I think they all they see the need, they see the gaps that are there for quality improvement, and therefore we have agreed with them that we will engage the committee for curriculum. I think recently the university, given the change of the education system from 844 to CBC, I think the university has instituted a number of committees to look at how the CBC system will evolve into university, and probably that is an opportunity for us to therefore look at how these gaps that have been indicated in the TNA can be filled through the change in curriculum.
Thank you so much. Thank you. Good to hear that the University of Nairobi is really moving towards looking at the future and also preparing for the next phase of generation of a healthcare workforce. So let me turn to Professor Rodney. I know you've done quite a bit. You manage institutions here in Kenya, but you have affiliates in other parts of the world. So how is the Aga Khan University Hospital using these findings and through your networks and influences to ensure that we prepare our workforce better and better to join the market in the future? Thanks.
Thank you. I think the best way I can say this is through my journey into QI. When I was at the University of Arizona, and that was for over 20 years, I was a consultant in infectious diseases and had a molecular lab, but I was not involved in QI. Then I was at University of Nairobi for a year as a Fulbright scholar, and then in 2012 I joined Aga Khan University. And at that time, the chief medical officer was the chair of the Infection Control Committee. And within the first 100 days, he said, you're now the chair for the Infection Control Committee. And I had a couple wonderful infection control nurses working with me on that. And then one left, and then another, and where do I get new infection control practitioners? That's a major quality issue. I mean, they were leaving for UK, for Australia, for US, so you couldn't really hold them back by offering them a bit more salary. And for whatever reasons, we've managed to have good people coming in again and again, but it made me start thinking about that it's time to start offering infection control training, and subsequently thinking beyond that to the whole QI setting. And in fact, also when I came, I think very few people in the hospital had quality background, and they brought in Duran to do a series of courses right in preparation for Joint Commission accreditation. And so that was one of those first things that brought the level of quality up. Also, the lab going through a similar accreditation process. But then, how do we build that to the next level? On the institutional side, there is now a robust quality department that has things in good order. But what I would love to see is the growth of a graduate program in QI, and to include the things that are next to me, including infection control and also antimicrobial stewardship. So hopefully that addressed the question.
Thank you so much. So still have the mic. So based on that experience and the application of the same at our private university, I know Aga Khan relatively is a premier university in terms of the private sector. So what competencies do you see maybe lacking in terms of the application of the improvement science to the cadres that you see in your practice or students that you coach or mentor or teach?
Yes, there are people who are at a high quality level, but countrywide we need many more. But some of the common things, one is the lack of systems thinking. I think once you get beyond the quality office, if I were to point out a problem, the first thought of the person I talk to about it would be the individual who did something wrong, but not, is there a system that we can change that will prevent it from happening in the future? So I think all of our institutions need a growth in that systems thinking, whether it's bedside barcoding for blood collection, on and on. What can we do to make it safer for the patient? So I think expanding that and making it more available to everybody.
Thank you very much. So I want to come back to Irene. I hope I prepared you for this. When you spoke about, I think you mentioned leadership. You have to identify the leadership component. Same to what Maureen spoke about. So during your in-service support, you go to an institution, a hospital with 100 plus people, maybe 10% are management, the rest are the front line. So how do you distinguish, how do you identify who needs what kind of support in the application of science of improvement and patient safety?
I think the first step is always to look at their job descriptions, because as you come in, you're employed to do some tasks, and your job description should be clear enough to say whether, at what point the roles intersect or not. So during the readiness assessment, we do look at these job descriptions, and then we're able to see if it's a nurse, what are their roles, and then be able to contextualize and say, if we're going to offer a QI training to them, then what are we going to discuss at that point? Of course, if it's a manager, same thing, and then at leadership level. That being said, it's not always the easiest thing, because one of the bottlenecks we've seen is most facilities have a generic job description, which is something that you can download over and over and over. So what the title this person has versus the work they do are worlds apart. So we find that even in the process of offering training, we also have to provide role clarity. And most of the times, we end up also helping them to redo their job descriptions so that we tie in quality improvement with a performance indicator so that it's able to be tracked moving forward. So that's how we've been approaching it so far.
Thank you so much, Irene. Maureen, so this is about resources. You know, all these concepts, all these ideas and adaptations, they need some investments. So, and I know you supported programs across the globe, you know, first world, middle income, and the lowest of the lowest. How do you manage the concept of using your own resources to apply the science irrespective of where you are, so that the concept is not lost because of the resource limitations?
Thank you. I think in terms of resources, it really boils back to the facility. What do they have? What can they offer on the ground? Because whatever you're implementing, you do not compare middle income and low income environments. Having said that, you need to make sure that whether it's low income, they do have the basics for you to do improvement. And sometimes it also means you need to help the leaders think out of the box. So I'll give you an example. There's some work that we're doing in one low-income country. And when we went to the hospital, specifically one hospital, would see that it's a very challenging environment. And it was around maternal and child health. So we're reducing mortality for newborns, including with low birth weight, preterms, and so forth. Obviously, part of it is infection control, which is patient safety, and QI, introduction of QI and the like. The first question the CEO of the hospital asked me was, Maureen, you want me to do patient safety, to do QI? Right now, as I speak to you, we don't even have hand wash soap for these mothers to wash their hands. I don't even know what I'll feed my patients in the next 2 days. The government has not given me money to do this. So I had to think quickly, think out of the box to say, how can we resolve this so that QI still happens in this hospital? So the first question I asked him, I said, okay, let's think out of the box. Let's assume the ministry, the headquarters is not there to give you the supplies that you want. In your district, do you have pharmaceutical companies? He said, yes, I've got 2. I said, good. Let's call them. We called them and asked if they have hand washing liquid that these mothers can use. Within hours, they received liters of the liquid that he was looking for. That's one. The second one, food. I said, do you have farms in your district? And I knew that it's a district with lots of farmers. So I said, can we call the farmers and figure out if they can give us corn, we grain it, we get beans, we get vegetables, so you can have food for patients. And he got food. What I'm trying to say is most of the times we are clouded by the problem. So we don't really think what else we could do to institute QI. So to answer your question, most definitely they needed the liquid for patient safety, for several changes that they needed to do. But we need to help these leaders, and at all levels, whether senior leaders, middle leaders, even the leader within the ward, how they can think differently according to the resources that are available at their disposal. It might be internally, it might be resources that they need to get outside their comfort zone, but we need the basic resources to do QI. And one point I also want to make is that QI seems simple, but when you're on the ground with the teams, it's not as simple as we want to think. And I also like the idea about system thinking, because for you to start thinking in that manner, you need some level of support and some level of seeing things with different eyes, where the problem is not about Maureen, the problem is about the institution, and how can we look at the institution and close that gap that we have. Thank you.
Thank you so much. Another round of applause for our panelists. So we want to take the next 5, 7, 10 minutes maximum, just to hear from you. What do you think? I think your hand is up so fast. Yeah, we'll come to you. Make sure you give him the mic first. But before we hear from him, please think about, I think it was interesting to hear what Dr. Rateng said, and also what Dr. Perry said, is that we train, we have the theories, not fully maybe embedded, but when we send our students all out there to a practical guidance, they don't get what they are being trained on. So is it like maybe they have tried, but we are not just ready to support the healthcare workforce as they come into the work stream? That's something you can think about. But let's hear your reflections and perspectives based on the presentation earlier and also the discussion that has just gone by. Please give him the mic. Carol, please.
Yeah, thank you very much. My name is Dr. Mugisha Ntionza Nkoronko. I am the surgeon practicing at the Benjamin Mkapa Hospital at the capital of Tanzania, Dodoma. And I also sit as the president of Medical Association in Tanzania. I'm a beneficiary for acquire trainings, first in the basic certificate and second as a coach. I really applaud all of you for making this particular conference happen and this particular session coming with strengthening the training capacity. I would like to go beyond what our colleagues have discussed. We have been thinking in the healthcare industry alone to see how best we can incorporate patient safety and quality improvement. But I think the best way to do it, we need also to think about population health. We need also to integrate patient safety in the communities, especially in the primary education, secondary education, whereby we can capacitate our citizens with the ability to question, ability to demand, the ability to understand and integrate all what it takes for them to be safe while receiving healthcare. Yeah, when we interject and institutionalize a training in the healthcare, maybe cadres or professionals, well and good. But if we do not integrate the community in the healthcare, so that the community, the people, the citizen, it will be difficult to have one thing. Once citizen knows what it takes for them to be safe in particular hospitals, they will demand, and then the doctors will behave, the pride will go down, the healthcare workers will integrate, and probably will have a certain cohort of practitioners who have the story, our story. The second part that I wanted to make a point is why it is important to engage them. Most of them, they are the first advisors to our patients. They are the first people in the community. You see trauma happen, they are the first responders. You see someone is sick with this disease, and there's, what did you do? What did you do? What did you do? Where did you go? Then they gave recommendation. Once we integrate all those things, that patient safety start with good health-seeking behaviors, will probably make a point somehow more better. I understand we are at different levels and the quality is not part of what we think because we have been struggling with so many problems, but it's important to appreciate the little steps we are making towards that. I'll finish with an African proverb, especially from Kenya, because we're in Kenya. It's not only the rabbit that finish the race, tortoises also do at their own pace. Thank you very much.
Thank you so much for that really quite informative session. Mine was to come in form of a question, but I'll try to combine them two just on my thoughts. One of the things that has been really challenging is when we are focused to go probably and just doing the training needs assessment that you're talking about. How do we capture the really supportive element to the healthcare provider, that is the supervisors? Because most of the times you find we put trainings, then on a training day, the supervisors are never there. What we have is the healthcare workers at the facility. I think really just to get some insights of how to go about this. And then secondly, I've just been thinking of the place of the community health promoters, especially in this era of universal health coverage. They are very key when it comes to the quality of services happening both at the community level, as my brother has just highlighted, and at the facility level, because these are the people that link the community to the facility. And when they're not empowered, they'll not understand what is the role of just knowing, probably, visiting a family, getting this pregnant mother early enough to the facility. Thank you.
Okay.
Yes, thank you. Now with the institutions training for pre-service, and then we have the in-service training aspect. But the other missing link, I think, is from the professional regulatory bodies or the councils. Because I have a sense that as much as, for example, as much as we go through periodic licensure renewal, the element, the competency frameworks that we have does not really stress or make patient safety a competency area that would come in as a core area for your licensure or for your continued practice in service. So as the trainers, maybe probably from Dr. Ateng and maybe Professor Juka and Professor Rodney from Aga Khan, do you find that mix or role that you can play to ensure that the regulatory bodies over the fence to whom you hand over the healthcare professionals after training are ready to pick up this, so that at the back of the mind, when the students go back to the facilities, they find that there are conditions that are making the healthcare leaders to factor in this so that everyone else stays within the pipeline. I think that is something that is missing, and I'm really feeling that we need to find a way of tying that loose area. Thank you.
Okay, thank you so much, moderator. Edwin Ouma from Uganda. Two questions, please bear with me. One to Kennedy. Thank you for your work. Now, I do not know, apologies, whether your institution is public or private, but I wanted to, we have a challenge back in Uganda of identifying which persons lead or are in the offices of quality improvement and safety, which person can be there. In our experience, most of them are nurses. So my question is, do you have any, I don't want to call it advocacy depending on what your institution is, but experiencing you, the people who train, trying to, advocate or push whichever organizations control you to introduce these courses that then can influence or see that we have these specific people with specific knowledge or skills taking on these offices in these hospitals, and therefore that will probably support when you post your students there, they find these programs running, okay? And then maybe influencing government to have these positions formal so that people can be employed based on their competencies in QI and safety. So I just want to know whether you have those experiences of or discussions on making sure these courses are standalone and people can take them with a view of being employed. And then to Irene, thank you for your work. I just wanted to know, how do you identify the institutions that you train? I bet they pay for the training. So how do you price and how do you ensure that after your training, there is kickoff of whatever you've trained and then measure the sustainability. You see, after training, people eat the food, it's nice and what, but kickoff is not easy. Thank you.
Let's take those ones for now.
Do you want to go first?
We can start with you, just public or private.
Thank you. Kenya Medical Training College is a government-owned institution. It is a government, is a semi-autonomous, but trains on behalf of the government. Now, you have asked a very good question about the regulators. How do we bring, that was not you, that was your neighbor, the regulators in? That's very important. Regulators here in our country are they have what we call the master curriculum for our trainings. And they get this master curriculum based on the inputs that we give them as trainers, together with also needs assessment that they do. So it's very important and it's very easy to bring them in this space. And as you have put it right, I think we should think of how do we bring in the idea of CPD points specific to these areas. I think that's a good thinking. We saw in some presentation, we are told there's where they do this and they earn points. And I think that's very important because as in training, we know students or trainees tend to really take areas of the curriculum that are examinable and marks awarded. And that's why if we attach the CPD points on these areas, I think the regulators and everybody can take interest in this, in a QI and patient safety.
Yeah, thank you. Thank you so much, Dr. Kennedy. Irene, may you please respond on how near is...
Yes. So there were two questions, actually. She asked something about how do you keep supervisors and managers in the room, because when you go to do training, somehow they are never there. So what I've learned over time is to contextualize the training and then be able to, especially for the supervisors, be able to offer it to them, for the lack of a better word, in their comfort. And that means bite-sized. It's not the same as having frontliners sitting in a room for 3 days. The supervisor can't afford to do that because, not in a bad way, they're probably fighting a fire somewhere in the hospital. So they'll keep coming and going. So it's easier to pace it for them. And then also just being able to know, what do I want this supervisor to know? Mostly it's, especially if they've ever gone through QI, it's the monitoring and evaluation section. So therefore, that's where I lean in. So that's what we do. The other aspect that I forgot to talk about that's so important, that we really try to advocate for, is protected time. If we don't get that written down in our terms of reference, so for us, all the clients we work with, they must sign a terms of reference, and in there, there's a commitment for protected time. Number of hours for supervisors, number of hours for frontliners, and for frontliners, we even ask for their rotas for us to see where QI hours have been allocated. So that helps us, I guess, to be able to follow up on those days to ask, are you being able to do this? Or do you need us to advocate for you to actually get the time that has been allocated? In terms of pricing, pricing is dependent on the needs assessment. So a facility will call, we'll get into a call, talk about whatever the issues are, and then what we have to do before we price anything is always an assessment. So whether it's virtual or in person, we will do the assessment. Based on the gaps we see, then we will be able to price it. Before that, we used to lean heavily on just training and say, oh, you need a training, it's this much. Then, when the trainings didn't work on their own, we discovered that some facilities don't even have a system. So the training is hanging, literally. So now we ask, when you call, we want to do an assessment and find out, do you have an existing system that the training will be embedded on? If not, then we price accordingly. In terms of kickoff, yes? Kickoff, a lot of sensitization. I take time to sensitize. I take time to push for sensitization for the front line. Sensitization meaning either focus group discussions or emails or meetings at the point of handover. Everybody must have heard something about what's coming before we ever go into a class for training, so that they can understand why we are going through that. That has helped us to reduce what we sometimes quote as resistance. It's normally just, I don't really understand why we are going through this. So that has helped me a lot. And at the end of it all, in terms of sustainability, we end up in a community of practice. So after we work together, when we are done, we end up in a community of practice, and in that community of practice, we have monthly sessions where we are just looking at key indicators and finding out how are you doing, do you need any support? And in the event you do, that is beyond what we can offer there, then we re-engage you for anything else that you may need. Thank you.
Thank you. Thank you so much. We would have loved to spend another 20 minutes on this one, but I'm afraid we have to stop here. And really appreciate, I know there was a question about community health promoters and how do we engage them and prepare them, because the whole aspect of PHC is around, quality and access and all those financial elements. But just to appreciate you, and with all the surgical precision of Professor Juka, the experience of Professor Rodney, the calmness of Dr. Rateng, and the energy of Irene and the rest, please. Thank you so much for finding time for this panel, and all the best for the rest of the evening. Of course, and Caro Nkoha, sorry. Caro, thank you so much for the presentation earlier. Yeah.
Everyone, we've had a very full day. Do you see that Mentimeter poll? Will you do us one final favor today and answer those questions? Okay? Just put that camera up. And I want to say, I think while your hands are on your phones, I still want you to give a great round of applause to our panel. Thank you so much for telling us ways to think about how to bring the training we need right to the front line. Today, we've had great opportunity to learn and engage. Tomorrow, we're going to do it again. Tomorrow we start at 8:30. And we're starting with dancing, so bring your dancing shoes and get your jive on, all right? And we're looking forward to another rich day tomorrow. As we close, I want to remind all those who did a scientific poster and are present at the meeting to come up front to the podium for a very short briefing on how the session will run tomorrow. With that, thank you, and we're complete for today. Have a great evening.
Is tea and snacks outside. Don't make the